in transplantation. And you can see in this little illustration, you can see this is the GI tract, and you can see these little bugs, and they're sitting at a table, and they're eating on the capsules and tablets that are present in this GI tract. So I have been interested in studying whether or not that this in fact is true. Does the microbiome have an effect on transplant drugs, especially the immune suppressants? Now, there's a number of different mechanisms by which this might occur. Like, how is it that bugs could affect the drug? Well, these bugs in the gut can express proteins. These proteins then create enzymes that can activate or inactivate the drug. So it changes the clearance. The drug also could be directly sequestered by the organism. So in other words, that bacteria binds directly to the drug. Once it's bound, then that drug does not have the capacity to exert any sort of activity. The drug can also be metabolically reactivated by enzymes. There are some drugs, and I'm going to show you the example of the drug we're interested in is MMF, mycophenolate, where it is metabolically inactivated. And we believe that there are bugs in the gut that reactivate mycophenolate. So that's another mechanism. The fourth mechanism is that these bugs can generate alternative drug metabolites. So in other words, generally a drug is metabolized. We generally understand the metabolic pathway of the drugs, but in certain situations where the microbiome may be adverse, maybe different drug metabolites are formed, and these may be good metabolites or they may be bad metabolites. And then finally, we also know that the microbiome can alter transporters. And transporters are present in the GI tract, and they move drugs across the mucosal membrane out of the GI tract and into the bloodstream. And so we know now that these gut microbiomes can influence these drug transporter proteins, and then you can have troubles with absorption. So the big question now is, what is the effect of the microbiome on immunosuppressant drugs? We don't know. There's data that's emerging, and I'll show you just a little bit of the data, but the data does suggest that perhaps the microbiome does affect mycophenolate and possibly even tacrolimus. So you might ask, well, why do we even care? Because is there anything we can really do about it? Well, we have to care because we know that drug levels are important, and low drug levels are correlated with acute rejection. So that's why we spend so much time doing therapeutic drug monitoring to keep people in the therapeutic range. We also know that mycophenolate overexposure is bad, that people can get are at more risk to get anemia or leukopenia. We also know too much tacrolimus is bad because there's a lot of different toxicities that occur with too much tacrolimus. And we know that if a person does end up with rejection, so if they are not treated ideally with their tacrolimus or MMF, they're more likely to get a rejection. When they get a rejection, they get chronic kidney dysfunction, and then they're more likely to have allograft failure in the setting of kidney transplantation. And of course, long-term overexposure to immune suppressants increases the risk of infection and malignancy. So long-term chronic overexposure can be bad too. We also know there's a lot of GI side effects from the immune suppressants, tacrolimus and MMF being the biggest culprits, the nausea, vomiting, dyspepsia, and diarrhea. Of course, we are interested in that. Okay, I promise, I only have two chemical pathway slides, right? The first one is tacrolimus, and I'm going to show you a pathway of MMF, but this is tacrolimus. It's a really, really large molecule. It's the metabolism of tacrolimus is very, very complicated, but it forms all these different metabolites. Some of these metabolites are active, some of them are inactive. Some of them that are active, they might be less potent. For example, the M1 is 15-fold less potent than tacrolimus. The reason this might be important is this was a study done a few years ago now, where This was done in a laboratory. This is not patient data, but they took bacteria. They exposed these species of bacteria to tacrolimus, and then they measured the metabolism of tacrolimus after exposure to these different species. And it showed that species, a couple of species of Clostridium, resulted in lots of M1 being formed. So what happened was, in the presence of some bacteria, but not other bacteria, a lot of this M1 metabolite was formed, suggesting that perhaps that there can be changes in metabolism based on the type of bug that might be residing in the gut. There's also this very small study that was published several years ago now, which it was patients, and on the x-axis is the patients, and the patients that were in the green group, which is the majority of the patients here, they had stable tacrolimus. They didn't need a lot of dose increases to get to the stable therapeutic level. But then you had these other patients that were in the red. These were what they called the dose escalation group. And these patients had a lot of problems with their tacro levels, that they were flopping around. They needed a lot of dose increases. Well, then they studied the stool in these patients, and they found that these patients that were in this dose escalation group, or this hard to manage group, they were more likely to carry this particular bacteria in their stool, which was a Faecalibacterium. Again, so suggesting this clearly is not good enough evidence for clinical management yet, but evidence that perhaps the microbiome matters for tacrolimus. Another bit of evidence, again, I'm showing you a lot of the some of the emerging data because we don't have a lot of clinical data yet on the microbiome. But this was a really exciting study that was published in Nature 2 years ago. And they took 271 drugs, and they're drugs that you would recognize, and they studied those 271 drugs against gut bacteria. And I know you can't read this, but this is a list on the y-axis. Here is all the drugs that they studied. And the drugs that were most affected by the bacteria are the ones at the bottom of this figure. I blew this up here on the top right. And guess what? One of the drugs that was most affected by these gut bacteria was mycophenolate mofetil. So that also, and so there were up to 70 of the bacteria that they studied. Of these 76, 70 of these bacteria affected the metabolism like mycophenolate. So that was also important evidence for us that maybe in fact there could be a clinical importance to the microbiome in terms of immunosuppression. Okay, here's my second metabolic pathway, but this is the pathway of mycophenolate. Many of you probably already know this, but so MMF is a prodrug. MMF is not active. MMF has to be converted to mycophenolic acid, MPA, when it's, and this is what provides the immunosuppressive activity. MPA is then converted to MPEG, which is an inactive compound. So this is the inactive metabolite. But what's really, really unique and interesting about the metabolic pathway of mycophenolate, it undergoes something called intrahepatic recirculation. We call it EHR. And what happens is this inactive metabolite, MPEG, the G, or the glucuronide, will be cleaved off the MPEG molecule. And when the G is gone, it's converted back to MPA, and it's reabsorbed in the bile and in the GI tract. So essentially, patients get a second dose of MPA when this metabolite, the G, gets cleaved off, it's then reabsorbed. Now, what's really compelling about this intrahepatic recirculation, that it is facilitated by beta-glucuronidase. That's the enzyme that cuts the G off of the MPEG. Beta-glucuronidase is formed by bacteria. That's how we get beta-glucuronidase in our GI tract. It's because of the bacteria that live there that produce it. And it turns out that what we call GUS bacteria. GUS is expressed by Bacteroides, Firmicutes, proteobacteria, acinetobacter. These are the bacteria that produce this beta-glucuronidase. And if you look in the top right-hand corner here, this is just a concentration time profile or the pharmacokinetic profile of mycophenolate. My MPA level would be on the y-axis, and this is time on the x-axis. And this is intrahepatic recirculation right here, where this is you would expect the drug to peak and then it slowly comes down. Well, in the case of mycophenolate, you see this secondary peak. This is because of intrahepatic recirculation, and it's mostly driven by bugs. We think this is going to be mostly driven by bugs in the gut. So this can really change the exposure that a patient has. So if you're essentially getting 2 peaks of the drug, you're getting a lot more exposure to the drug than another patient who doesn't have one of these secondary peaks. All right, so what is the evidence that this might be occurring? I mean, we know that beta-glucuronidase is a responsible enzyme. We know that beta-glucuronidase is made by bacteria. Well, we also know that there's a number of drug-drug interactions with mycophenolate that would further support the premise. One, we know that when we give somebody an antibiotic with mycophenolate, that we see a decrease in the area under the curve. So MPA concentrations go down in the presence of antibiotics. And this was an animal study of amoxicillin that very clearly showed that the area under the curve of MPA was decreased when they gave them. And what is happening in this situation most likely is the amoxicillin is killing the bacteria. And then you get this change in the absorption and the intrahepatic recirculation. We also know from this really interesting study from a couple of years ago, again, it's mice, so it's not humans, but it's certainly compelling, is that mice are a common animal that is used to study GI toxicity of MMF. And mice who get MMF end up with weight loss and colon inflammation. So that's how MMF toxicity displays in animals. And so what they did is they gave these mice MMF. They then gave them vancomycin. Vancomycin wiped out the GUS-expressing bacteria in their GI tract. And guess what? The MMF weight loss and colonic inflammation went away. So again, more evidence now that the microbiome is involved in perhaps some of the toxicities of MMF through this study, where they were able to change the microbiome in the GI tract in these animals by giving them vancomycin. So now I want to switch gears now, talk a little bit about the study that we're doing at the University of Minnesota. This is called the MISSION study, and it stands for the Microbiome and Immunosuppression in Kidney Transplantation. We're recruiting patients from the University of Minnesota and from Hennepin Healthcare. Ajay Israni, who is transplant nephrologist over at Hennepin, is my partner in this study. So the study has 3 main aims, and the first aim is to determine the association of microbiome with MPA and metabolite concentration. So we're looking at the pharmacokinetics of mycophenolate and then associating that with the microbiome that we observe in patients' stool. So we're collecting stool from patients. We're also going to determine the association of the microbiome in transplant recipients with MPA toxicity such as anemia and leukopenia. So we do believe that the microbiome it might have an impact on whether or not patients get anemia or leukopenia. So we're going to be following that, or we are following that. And we're also looking at the association of the microbiome with diarrhea in transplant patients post-kidney transplantation. This is our inclusion criteria. We're recruiting patients who undergo kidney transplant. They have to be adults. They have to be receiving tacrolimus, and they have to be on MMF. They can't be on Myfortic, but they have to be on MMF CellSat. Of course, they have to give informed consent. They have to be willing to come in for the procedures, because we are asking patients to come into the clinical research unit to do PK. They have they can undergo either living or deceased donor transplantation. And we have a number of exclusion criteria, although I won't don't feel that's necessarily that important for today's talk. These are our endpoints. So our primary endpoint is MMF pharmacokinetics. Patients are coming into the clinical research unit at the University of Minnesota. They spend, they get a 12-hour PK study there. So they generally are there about 13 hours. By the time we get the IV placed and everything set up, it's usually about 13 hours. We are paying participants to attend. So we're paying patients $200 to come and hang out with us in the CRU for the day. We are looking at anemia and leukopenia, so trying to understand if they're developing these diseases and what that is, if that's associated with their gut bacteria. We're doing that through chart review. We are also following diarrhea, but we're not looking at diarrhea in terms of what's reported in the medical record, but this is a patient-reported outcome, and I'll show you how we're doing that. And we're also then looking at tacrolimus trough concentrations. We're doing that for chart review. We're just using the concentrations that are measured as part of normal clinical care, and we're going to associate tacrolimus troughs with the microbiome. So our diarrhea assessments are going extremely well because we're using text messaging. So twice a week we text message the patients, and this is all automated. And we ask them about are you having bowel movements? Are they unusual? How many have you had? We have had remarkable uptake in responding to text messages. We have almost 100% compliance or adherence with response to text messaging. We are using a company called Mozio to send our text messages. I'm not advertising for Mozio, but their program is really nice, and the text messaging system that they have is also HIPAA compliant, because you have to, if you're going to use text messaging for research, it does also have to be HIPAA compliant. So you have to find a vendor that has a HIPAA compliant text messaging system. So here's the schedule of events. Patients around time of transplant, we are consenting them. We collect some blood for DNA, and that's because we're going to do some pharmacogenomic testing in these patients too, as an additional as something additional, because we need to control for pharmacogenomics in the statistical analysis. We're getting a stool sample at the first week. And then any time between 1 month and 3 months, we're asking the patients to come into the CRU for PK. We get another poop sample from them when they come into the CRU, as well as some other things. And then we get another stool sample at 4 and 6 months post-transplant. And then after 6 months, what we're doing is we're following the patient along in the medical record, looking for their outcomes, like do they get rejection? When do they lose their graft, and other kind of EMR data that we can pull from the electronic medical record. So we are paying the patients for every poop sample too. So we give them money every time they return a stool sample, and we're also paying the patients for responding to text messages. So if they respond to more than 80% of the text messages, that we also pay them for their responses. So patients, so this is pretty patient-friendly type of study, although we are finding that some patients really don't like to collect their poop. So that for some patients, they won't even sign up for the study not because they don't want to come to the CRU, but because they don't want to collect their poop. So we're also studying microbiome beyond the stool. We're going to be looking at the oral cavity, the nasal cavity, and the urine. And this is my last data slide. This is just kind of a sneak peek into what we're finding. This data is not part of the mission study because we haven't analyzed the patients that we've already enrolled. But I'm also doing the exact same study in the bone marrow transplant patients at the University of Minnesota. And this is our data in 20 patients, BMT patients, and our hypothesis is turning out to be correct. So this is MPA pharmacokinetics in BMT patients. And the blue line are patients that have high intrahepatic recirculation. You can see that they're pharmacokinetically, that they have higher exposure to MPA. And the orange line is people that have low intrahepatic recirculation. We, of course, have microbiome information on all these patients. And what we are found is that the patients that have high intrahepatic recirculation have significantly greater abundances of Bacteroides. And this exact microorganism is one of those that very commonly produces beta-glucuronidase. So this is entirely consistent that the patients that have the Bacteroides species have higher MPA levels. And in the if you are familiar with trough concentrations of MPA, that the people who have the low intrahepatic recirculations, almost always their trough levels are less than 1, more likely less than 0.5 microgram per ml, whereas the patients who have good or high intrahepatic recirculation have trough concentrations that are usually between 1 and 3. So clearly this appears to be impactful. So in conclusion, the microbiome is associated with multiple diseases and plays a major role in the immune system. Data suggests that the microbiome may affect the pharmacokinetics of mycophenolate and tacrolimus. Animal data has shown us that there are associations between the microbiome and immunosuppressant toxicities, and we believe those will probably hold when we now finally study in humans. And in the future, how I would envision this may occur is that microbiome testing may be routinely performed on patients. Maybe we would perform it on patients who have drug levels that just can't understand what's going on, or maybe they develop some sort of toxicity like a diarrhea, and we wonder if it's because of the microbiome, so we might be doing microbiome testing at those times. And then we would be able to correct an adverse microbiome. So, and how would you correct somebody's microbiome? Well, there would be a microbial products. I mean, we can create, that's what probiotics are, is where you have a capsule that has the microbiome, the bug in it, or bugs that maybe this patient lacks, could potentially correct the microbiome with things like dietary supplement. And there's always a possibility that the microbiome can be corrected with dietary changes. So there's a lot of things that we'll be studying in the future, and a lot of important implications, I believe, for transplant as we further dig into the microbiome and how it matters. So there's lots of people involved in these studies. Of course, the coordinators at Hennepin Healthcare and University of Minnesota have absolutely been imperative in getting these patients enrolled. With that, I think I'll stop and entertain any questions, if there is any.
Thank you, Pam. I don't see anything in the chat at this point. We'll give just a couple more seconds to see if anyone unmutes themselves to ask anything. Thank you so much for your presentation. I can't wait for the results of your study.
Yeah, we're looking forward to it. We're back in now that, COVID, I hope, is getting better, or at least we have good policies in place. Hopefully, our enrollment has definitely picked up. During COVID, we definitely had a slowdown in enrollment. Patients just weren't interested in coming into the CRU, or were we allowed to bring patients into the CRU for very good reasons. So
definitely. Well, thank you.
Okay. You're very welcome. All right.
Have a great day. Okay, so for our next speaker, we have Dr. Basam Shukrala. Dr. Shukrala completed his residency at Vanderbilt University and the University of South Alabama and his fellowship at the University of Minnesota. He's board certified. He's a board certified thoracic surgeon with professional interests in ventricular assist devices, ECMO, and heart transplantation. And Dr. Shukrala is also a current member of the International Society for Heart and Lung Transplantation. And he will be speaking to us today about heart transplant from DCD donors. I don't see him. There he is. He's joining again. We'll just, it looks like Dr. Shukrala just joined us again, so it'll just be 1 minute while he gets ready to share his slides.
All right, can you guys hear me?
Yes.
Okay, I am sharing, share. Okay. Are you able to see my screen?
We are not seeing your screen right now.
Okay. I'm not sure what to do here. I've hit share screen, desktop, share.
Yeah. Can you see if you can get him to share his screen from your?
Share screen from my- Oh, yeah.
Allowance.
It doesn't say allow. Screen. Should I make him a co-host? Sorry, guys. Bear with us while we try to figure it out.
When you click share screen, what does it tell you?
It says, it comes up and it says basic advanced files. Google Chrome, desktop. I hit desktop and I say share. Maybe we can try PowerPoint, hold shift. Let me see if I can't move this file into here. 1 second. Let me see if I can't move a file into your. Nope. Yeah.
Okay, when you click on your desktop, did you go to the lower bottom right and it says share? Did you click that share again?
I did. And then when I hit that, it says allow Zoom to share your screen. And I say, and then under it, it says open system preference, security and privacy to grant access. So I do that in this security privacy comes on. I click, like it won't let me click on the Zoom. I don't know what to do here.
Dr. Shukrala, do you want to try? I know your presentation might be kind of large. Do you want to try sending it to me via email and see if it goes through, and then
Sure.
Celeste can pull up your slides?
Yeah, I'll do that right now.
Okay, thank you. And maybe while we figure this out, maybe we could take our morning break a little bit early. And instead of 9:45 to 10, let's maybe plan to be back at 9. And we will start, we'll start from 9 to 9:30, and then we'll have Annie Doyle talk from 9:30 to 10, and then we should be back on track. So if people want to go grab some coffee and take a quick morning break, that would be great.
Pause.
Mute. Can you guys hear me?
Yes, we can.
Okay. All right. So you won't be able to see me, but we'll work on it. So, can you guys hear me?
Yep, we can hear you. If you want to put your slides in presentation mode, we can see your screen and we can hear you really well. Everything looks great.
Okay. You said you can see my screen?
I can see your screen, but I'm seeing I'm not seeing presentation mode. So if you go up to slideshow.
Where is that?
Across the top.
Yes.
In PowerPoint, across the top, it says animation slideshow.
Okay, I'm sorry. I just do not see that.
Okay, that's okay. We'll watch it from here. This looks good. Thank you.
I understand, but I cannot see what you see.
Okay.
Okay. This looks great. We'll go from here. Thank you.
I don't have a presentation up.
Well, we can see it. Oh, now you stopped sharing.
Okay, interesting. So
Go back to your PowerPoint that you had up. I don't see it now. Are you trying to share a screen? No, you.
We can still see your screen.
okay. How about I do this? I don't know what you guys are looking at. I could talk off my slides. I'm not sure what you're seeing. It's a blank screen that says Celeste Hansen. That's all I see.
We see if you go to your PowerPoint though and maximize it so that it takes up the whole window, we can see that.
Yeah. Perfect.
Perfect.
Okay. You guys can see that. And if I do this, does it move?
Yes.
Sure did.
Yes.
Okay, perfect. Sorry for the, anyhow, good morning, everybody. We'll be talking about the organ care system in the setting of donation after cardiac death. But before we do that, we kind of have to lay some groundwork. I have no conflict of interest. This is Christian Bernard is there on your left screen. He's the first surgeon to transplant a human heart. He came and trained here in Minnesota, and shortly after leaving, trained under Shumway, he returns to South Africa and beats him to the first human transplant, I believe by a few weeks or a few months. But it's interesting to me of how, we advertise these things, or they advertise these things in newspapers. Of course, we don't do that anymore. But, after the initial decade of the 60s, the decade of the 70s was really a decade of disenchantment. We just couldn't keep these people alive. We could not immunosuppress them appropriately. So while there was a big inertia to start and do transplantation, it almost died off. But in the background at Stanford and Norman Shumway, they were working on innovating the immunosuppression medication, and they introduced endomyocardial biopsy, and they really started doing some work that led to the modern era of transplantation. And in fact, it was cyclosporin that first used by Shumway that began to show a dramatic survival to these transplant. And from there, there was a rapid rise in heart transplant centers, and with great results. Heart transplant is essentially the gold standard and best therapeutic option for patients with end-stage disease. Why do I say what's the difference between gold standard and best? Well, it's the gold standard because it has the best outcomes, and it's the best therapeutic option because it gives you a near normal quality of life. And I say near normal, I highlight that near normal because immunosuppression is not normal. It is quite challenging for patients. But this organ is severely limited by its availability. We just don't have enough donor hearts. We have about close to 7,000 people on the list, and half of them get transplanted. The limiting factor is essentially this the preservation. One of the many limiting factors, I should say, is preservation. We preserve on ice. We go get the organ, we put it on ice, and ice has a problem. If you get to the 4-hour mark, the organ starts to experience problems, and you will not do well if you exceed that 4-hour mark. So 4-hour mark, 4 or 5-hour mark is really our limiting step for transplantation. And so, for example, if we get a heart and it is in California, we can't go get it. If we get a heart and it is in Florida, it's very difficult to go get it because these are, well, California is a 3-hour flight, so you got to incorporate procurement and return and travel time. That'll exceed 6 hours. Same with Florida. Texas can be doable. It requires a lot of coordination. Of course, South Texas wouldn't be. So essentially, if you have a travel time, which includes procuring the organ and returning it to your institution, that exceeds 4 hours, you can't have that organ. We don't generally take these organs. Steen and colleagues in Sweden began working on a different preservation model, and this ex vivo preservation, which they used a proprietary solution to preserve their organ called the Steen solution, and they successfully demonstrated good effects and eventually used it in heart transplantation. And this kind of led, this and others were working for other organs. Kidneys use it with great results. There's a reduction in graft dysfunction. Lungs, there's a landmark paper published in New York, New England Journal of Medicine that clearly demonstrated there was a reduction in primary graft dysfunction using this this machine when you compare it to ice. And the liver is undergoing a trial right now. So let's focus on the heart. So Walid Hassanian was a resident in the in the 90s, and he witnessed procurement of a heart and came back home and started thinking about how can we preserve this heart in a different manner. In 98 he published his work, and I'll go very quickly through it. Essentially, he looked at two groups. Group one was he preserved these hearts with blood, and group two, he preserved them in the traditional way using ice. And this is kind of the schema that will eventually become the organ care system. The heart's connected to a pump and oxygenator and is essentially closed off, creating a closed circuit system with a few non-invasive monitors. There's a probe here, and he monitored lactate levels, pH levels of this heart. So if you look at the top line here on your screen, can you guys see my arrow? I take it as yes, you can. The top line is the hearts that were preserved using blood, whereas the bottom line was the rectangle. I'm sorry, the triangles were the hearts used preserving ice. And then at point B, he separated these hearts from the machine, and he took these hearts off ice, and then reconnected these hearts to the machine, reconnected these hearts to the machine. And as you can see, despite reperfusing these hearts with blood, the ones that were preserved on ice, he never really attained near normal pH on them, while the hearts preserved with blood maintained good pH levels. Again, when you look at cardiac output at 1 hour, they're near normal. The hearts preserved with blood versus the hearts preserved on ice. But at 2 hours, you can see a clear difference in the function of these hearts using blood is much, much better than those using ice. So this led him to conclude that the new method extends current preservation limit and avoids time-dependent ischemia. And this is what we're battling with ice, time-dependent ischemia. And this essentially led to him engineering this organ, the organ care system, which is a system that that has three major components. It has a monitor, it has proprietary solution for you to infuse within the heart, and it has the console, and this is the perfusion model, what we connect the heart to. And so it kind of looks like this after we're done. There's a pump, there's an oxygenator, the organ is connected there, and there are these non-invasive ultrasound monitors that allow us to measure pressures. And these here are what we sample the blood from the venous side versus the arterial side to determine lactate levels. So heart procurement, how is it done on the OCS? Essentially, when you get to the receiving hospital, you must collect 1.5 liters of blood before anybody touches their organs. So this is the first thing we do. We collect 1.5 liters of blood. And then, we arrest the heart. We cross clamp the aorta. We arrest the heart. We vent the heart in 2 areas, usually IVC in the left atrial appendage. And then we remove the heart. And these are the cut lines. Folks will always want to know what are the cut lines. We cut across the aorta, the pulmonary artery, the inferior vena cava, the superior vena cava, and then we'll remove the left atrial cuff. Then we take the organ to the back table and connect it to specialty made cannulas. This is the aorta. This is the specialty made cannula. We've closed off the SVC. And then the pulmonary artery is connected to this cannula. And then we hook it up to the machine. And as you can see, the pulmonary artery has this drain. The aorta has this drain. The SVC and IVC have been closed off and therefore creating a closed loop. Blood comes through the aorta. Oops, let me go back. Blood comes through the aorta. Because you have a competent valve, it'll go down the coronaries. Then it circulates in the coronary sinus and empties into the right side of the heart, out of the right ventricle, and out of the pulmonary artery and down this tube, and the blood, and you just go round and round. That's the flow of blood through the organ. And this is me after procuring an organ in, I believe, is in Idaho, which required a refuel. We're basically preparing to travel. I'm closing off, I believe, the IVC or something like that. But as you can see, a very, very nicely perfused organ. And here it is. We put pacing wires on this heart. We like to pace these hearts fast, usually about 90. And then we begin our travel. And when we begin our travel, we're essentially trying to manage three numbers: coronary flow, aortic blood pressure or aortic pressure. And then these are the lactate levels that we're monitoring. So coronary flow, we like it to be about 700 to 800. Aortic blood pressure, we like it between 80, we can go up to 85, 90, but usually we like it in the 70 to 80, the map in the 70 to 80 range. And that's usually where we try what we're manipulating. We'll manipulate it through giving the patient medication, the heart medication, or by increasing the flow of blood through the aorta. If I can make this as simple as possible, we're running an ICU on this heart. This is essentially what we're doing. And then we sample through these, the red and the blue. The red samples blood from the aorta, the blue samples blood from the pulmonary artery. And what we'd like to see is that the red is higher than the blue. And as you can see here, the red was lower than the blue. So we did some management maneuvers, and now the red was above the blue. And usually you just need a slight separation. Here there was the whatever we did, we needed to readjust, and we readjusted. And essentially this blue mark is an error. It was this red and this blue, and then this red and this blue. As you can see, we have a nice separation of lactate levels, and this continued until we landed. So once we land, we separate the organ from the machine by cooling it. We begin to cool it, and it starts to slow down. As you can see, we remove it off the machine, remove the cannulas. Here, my partner and I are removing the cannulas and preparing to transplant the heart. So I would like to share with you three trials that you should know about, and that basically control the entire organ care system and procurement with ex vivo circulation. So PROCEED-2 trial was a non-inferiority trial. All this trial was demonstrating is that preservation using the organ care system and or ex vivo circulation is not inferior to ICE. And this is the PROCEED-2 trial. Essentially, this is a multi-center international trial that spanned in about 3 years. They collected data, and they concluded that heart transplantation using donor hearts adequately preserved with the organ care system or with standard cold storage yielded similar short-term outcomes. From there, we moved over to the EXPAND trial. Now, this trial is looking at hearts that we would not take, meaning hearts that were far away. So this is not an non-inferiority trial. This is a trial that was designed to look to see if we can go after hearts that we normally do not use. The inclusion criteria for these are, ischemic time greater than 4 hours, older donors, downtime exceeding 20 minutes, left ventricular hypertrophy in the order of 12 to 16 millimeter, 12 greater than 12 but less than 16. And so these were kind of the inclusion criteria. And what were we looking for? We're looking for the endpoint was a composite of patient survival at 30 days and freedom from severe primary graft dysfunction in the first 24 hours. And what we saw is that the organ care system, we were able to perfuse 93 hearts, 18 of which did not meet criteria for transplantation, meaning the lactate levels were too high. Of those, we transplanted 75 So therefore it yielded an 81% utilization rate. Now, that is impressive by itself, but when you look at the endpoints, the incidence of primary graft dysfunction is nearly similar to ICE, with a 30-day survival that is very impressive at 95%. So the results, again, is after the trial, it met its primary effective endpoint. Use of the Airborne Care System resulted in very high utilization rate of extended criteria hearts with excellent short-term outcomes, and most notably with very low primary graft dysfunction. The trial went after more hearts to get more data as it was being evaluated by the FDA, and this is the continued access protocol arm of this trial. Very similar inclusion criteria. This one expected the total cross-claim time greater than 4 hours. Or if you have extended clamp time greater than 2 hours with any of the following. So we increased age, donor age greater than 55, or donors between 45 to 55 without coronary catheterization data, or left ventricular hypertrophy. Essentially kind of the same inclusion criteria. Primary endpoint, again, same primary endpoint. We just essentially, this trial was just going after more patients. So there were 66 extended criteria hearts have been transplanted across 6 sites. There have been 4 hearts declined, again with a utilization of 94%. And what's really impressive about the CAP is greater than 45% of the donors had multiple inclusion criteria. Not only was it long crash clamp time, you had older patient, you had left ventricular hypertrophy, low EF, etc. And despite that, you had a very high utilization rate and good survival. The MHI data where I presently work, we had 6 patients enrolled between August 2019, January 2021. We had 100% utilization rate, 0% primary graft dysfunction, all alive and all are doing well. Let's switch gears and talk about donation after cardiac death. Most of our procurements of organs is donation after brain death. When you're brain dead, you are legally dead. You're just a body holding organs. Donation after circulatory death or cardiac death is essentially, the best way to think about it is donation after brain death and circulatory death. You have a devastating head injury. But in donation after circulatory death, you have some brainstem activity. And so you cannot be declared brain dead. So because you have some brainstem activity. Again, these are devastating head injury with 0 chance of survival. So these are the 2 different modalities. So presently, most donations involve procuring organs from patients that are brain dead and their heart is still beating. In circulatory death, the heart actually is no longer beating. So we haven't been able to transplant these hearts because we don't know what happens during the time of you progressing to circulatory death. And what do I mean by that? So if you look at brain death, if you look at A, you're brain dead, your heart is evaluated, we're going to accept it for transplant. This heart is perfused up until we cross clamp, preserve it with our preservation solution, and transport it. In death after circulatory death, there's a period of hypoxia. We withdraw, and then your heart, once your heart reaches once your blood pressure reaches a systolic of 50 and saturation, O2 saturations of 70, the clock begins. So we can wait 30 minutes during this time for you to be declared circulatory death, and that's PA arrest. If you do not arrest within that 30 minutes, then we cannot take your organ, and so we leave. But if you do arrest, this period of ischemia, we don't know what's happening to the heart. And so this is how the organ care system has helped us use these hearts, because we can take the heart and essentially study its function on this machine. So I'm going to switch gears and talk to you about some of the publications that have come out. Essentially, there are two main ones on this. The group from Papworth and the group from Australia had the largest series on this. The group in Papworth has done a lot of work with this, and essentially, when they look at their hearts that were procured using donation after cardiac death versus brain death, you can see that their 30-day survival or 90-day survival are identical, nearly identical. Cardiac performance, DCD hearts had slightly better performance, but again, excellent function. Mechanical support, the DCD hearts did require mechanical support immediately after transplantation, that can come in the form of ECMO and or balloon pump or a temporary VAD. But again, had no difference in their survival, and they usually were weaned off these supports and did well. Again, you can see here their 90-day outcomes for DCD versus DBD at 90 days versus 1 year are nearly identical. The group from Australia, the highlight of this group is that they clearly documented almost a third of their patients required mechanical support after transplantation from cardiac death. But despite that, all had excellent outcome after a brief run of mechanical support. 9 out of the 23 required mechanical support after DCD procurement. Again, I highlight DCD heart transplant. Outcomes are excellent despite higher requirement of mechanical circulatory support. For delayed graft function, primarily in recipients with ventricular assisted devices. Overall survival and rejection episode are comparable to outcomes from contemporary brain death donors. This led us to initiate our trial here in the United States. This is a prospective randomized and concurrent controlled non-inferiority. Again, this is a non-inferiority pivotal trial where we took DCD hearts and compared them to standard criteria donor hearts. There were 15 centers chosen, but I think only 7 were active participants, of which we were one of the centers. I will speed through this. The inclusion criteria is that you essentially had a devastating brain injury and had some brainstem activity. You're between the age of 80 to 49. And your ischemic time had to be, your warm ischemic time had to be less than 30 minutes, which means when we withdraw support, you had to pass within 30 minutes for us to procure your organs. Primary endpoint was a non-inferiority comparison to procuring these hearts using the OCS versus the standard criteria hearts. Initially, we were going after 53 patients, but centers were so excited and gung-ho about this that they increased the number to 90. The trial has now concluded. But these are some of the we don't have the complete outcomes, but very, very favorable. When we put these organs on the machine, again, we met great aortic blood pressure, which is in the, if you remember, I told you 70 to 80, coronary flow between 730 to 800. The perfusion range were about 4 hours, but many exceeded that. You know, so some hearts were procured from as far as 8 hours away. A primary graft dysfunction, right? It cannot be reported now, but I've spoken to the Life Source folks, and it appears to be very, very favorable. At our home institution, we did 5 runs. We used it in 3 patients for a 75% utilization rate. One heart was declined after it arrived at our institution for poor function, and one heart they did not pass. 2 of the 3 required postoperative mechanical support for primary graft dysfunction, but all recovered well, were removed from their support, and are doing very well. So the OCS for expanded criteria heart is approved for commercial use. This came out about a month ago. And then the DCD is undergoing FDA evaluation. So in conclusion, organ shortage is still a limiting factor. Death on waiting lists, despite changes in allocation strategies, is still an issue. Distance is a major obstacle to allocate organs, and the ex vivo perfusion is helping and will change the way we allocate organs. I want to finish our time together by telling you that last year at the International Society of Heart and Lung Transplantation, this was the landmark article that everybody was anticipating with great excitement. And this was the group from Papworth reporting their 5-year results for donation after circulatory death. I'm going to go over some of the things in the paper, but I want you to really pay attention to my red box. DCD heart donation increased overall heart transplant activity at Royal Papworth Hospital by 48%, with no difference in 30-day or 1-year survival in comparison to donation after brain death. So they increased their activity by nearly 50%. This is unheard of. If you look at the years that they initiated from 15 to 16, they did 14, and you progress through the years, their activity begins to increase, and between 19 and 20, 21 hearts were procured using DCD donation versus donation after brain death. And this is really what's remarkable, is that we're seeing is that these hearts, donation after circulatory death, not only continue to perform well, even as far as 5 years. They just continue to do well. We don't see this, and all of a sudden you get to the end of a year or 2, you start doing well. These hearts continue to perform well. So this is a quiz for you guys. I can't hear you, but maybe if you look at this heart, you can see how vigorous it is. It is beating very nicely. It's got a very nice color to it, and it's snappy. And when you look at its numbers, you can see that our coronary flows, 700, 800, our aortic blood pressure was in the appropriate range. Between 70 to 80. But let's look at this heart. If you look at this heart, it's not as snappy, and you look at the left ventricle, it's very sluggish. And then if you look at its numbers are a coronary flow of 50, and our aortic blood pressure is sky high. This was as high as 200. The aortic mean and the AOP, not the systolic, but this was 200. So this was like 250, the systolic. And we couldn't do anything to bring this down. So this heart ended up declined. But this just goes to show you of how we use this organ care system to help us go after hearts they're very far away, and it gives us an ability to evaluate them. Are there any questions?
Thank you so much, Dr. Shukrala. That was a great presentation. I don't see that anyone has any questions in the chat at this point. We'll give people just a couple seconds to unmute if they want to ask anything. Otherwise, if we get any questions after the fact, I can send them to you via email as well, and we can get back to them that way.
Christine, I
Okay,
have a
thank you very
question.
much.
Ooh, yeah, Michael.
Yeah, this is Michael Petty. Hi, Sam. Quick question for you about the DCD donor hearts that were just reported in the UK. Do you know anything about whether or not those patients were high urgency as well? Which would, well, first of all, it would say something more about how important it is to get those DCD hearts because these people can't wait long. But secondly, it also is pretty impressive about how sick they would be going into the transplant and then having good outcomes coming out.
Yeah, that's a great question. How shall I put this? It's very tough to answer that question without me, going off into on my soapbox of a durable mechanical support. Heart transplantation is not a salvage therapy. So it's not like we're going to take someone that is very, very ill, that is in renal failure, that those people don't get transplanted. What happens to you when you get transplanted is you are essentially a patient that has a heart that is very sick, but you have been stabilized. Meaning your other organs are doing well, your liver's doing well, your kidneys are doing well, your heart is doing well. Then you go onto the transplant list, and then we stratify you, etc. But I am unsure of how many hearts they did off temporary support. We do those. I bet if I closely scrutinize their paper, probably about 15%, 10%, which is normally high for transplant centers. Like, for example, with us, we have done 2 heart transplant off temporary circulatory support. So it's very vague. I'm unsure you could tease that out by the articles that they've written, but these and they also do things that we don't have the ability to do. They do preservation within the human body. So essentially, they withdraw care, and then they reanimate the heart within the body. We are currently not allowed to do that in the U.S.
Thanks very much.
But if I may just expand on that a little bit, about 50%, and I glossed over this very quickly in presenting some of our trial results because I'm trying to speed through the presentation. Close to 50% had multiple inclusion criteria. I'm not sure if you saw that. That's on the donor side. But close to 50% also were high risk recipients, meaning they had a previous VAD. They were either on some support. But when you have a previous durable ventricular assist device, your complication mortality rate rises. And we saw that in our trial, which is very similar to the Papworth and the Australian groups, is that all 50% of the recipients had multiple risk factors, not one, multiple risk factors for morbidity and mortality. I'm not sure if that answered your question.
Gave me some ideas. Thank you so much, Sammy. That was great. Great talk.
Thank you so much.
I also, if you look at who they transplanted and you compare that to their brain death transplantation, That's what they're doing. They're comparing their DCD hearts to DBD hearts, and they're seeing similar outcomes. It's not like, the DCD heart got placed in a sicker patient, whereas the DBD, they gave it to the healthier patient. That is not the case. They basically, in England, because of their geography and center locations, they have center specifics that just do transplants. So they have a geographical we have geographical challenges that they don't have to deal with. Let's put it that way. So they're able to, the hearts that they get are going into the patients, not on how sick they are, but they're not picking and choosing which one gets the DCD and which one does not. They're basically, whoever's sick on this is either going to get a DBD or DCD heart, and they would transplant that person on their list, and then they compared them and they saw similar outcomes.
Thank you so much. We really appreciate your time. And
okay,
we'll stop there. Really appreciate it. And apologies for the technical difficulties at the beginning. Thank you for sticking with it and working through it and sharing your great presentation with us.
Thank you.
Thank you. Have a good day.
Bye-bye.
All right. Next, we will move on. I'm going to.
Hi, everyone. Thank you very much for being with us today. My name's, I forgot to take my mask off. Hello. My name's Allison Heil. I am the membership secretary for the local chapter of ITNS. And I have the great privilege today of introducing Annie Doyle. Annie has worked at M Health Fairview, University of Minnesota for the past 15 years in solid organ transplant. She has spent her first 12 years as an inpatient nurse on the SOT unit. And the last 3 years, she has been a living donor coordinator. Annie will be speaking to us today about a particularly interesting ethics case that spans both of her areas of expertise in inpatient nursing and living donors. Please join me in welcoming Annie.
Can you guys hear me? Okay.
Yes.
Okay. Thanks. I just got a little pop-up that said unmute. So the name of my presentation is To Operate or Not to Operate. And that is the question we faced when we had a positive HCG result the morning of a living donor nephrectomy. And I did Photoshop this cute little kidney here with Laurence Olivier from Hamlet, and I have no regrets. Disclosures. I have no professional disclosures. However, I want to make it very clear that I'm not a bioethicist. I am touching on ethical principles, but that's not my area of expertise. But I am a nurse. So, and I was a nurse on the solid organ transplant unit at the time of this case. And then I'm now a living donor coordinator. So it really, this was a really fascinating case when I was inpatient. Fascinating for the donor team, and thought it would make. So the purpose of this presentation is to discuss the ethical dilemma our team faced when a kidney donor's serum HCG came back positive less than 2 hours before her scheduled surgery. So I work at M Health Fairview, University of Minnesota. We do this really adorable thing where we change our name a lot, but this is what I think we call ourselves right now. And we've done a lot of kidney transplants. So since 1963, we've done about 8,500 kidney alone transplants. That number is closer to 10,000 for combined kidney and other organ transplants. And more than half of those kidney alone transplants are from living donors. We know that living donor kidneys work better faster and last longer. So it's certainly a preferred avenue of transplant. And this is the story of one of those many donors. So in this scenario, the patient C needs a kidney. So in this family unit, there's mom, dad, and siblings. So hopefully, there might be a few potential donors. So dad comes up first. He's referred, does an intake form and some basic screening, passes that screening and comes to evaluation. He's denied though, because he has possible PKD. So he had more cysts than he was allowed per decade of life at that time. And it was felt that we needed to rule him out and look at other donors. So next up was mom. Mom came to evaluation and was approved. And this slide just is a kind of just to show you that evaluation is no small feat. It is an all-day evaluation in our clinic, and it involves meeting all the providers listed here, the coordinators, surgeon, nephrologist, dietitian, social worker, living donor advocate, clinic nurse. There's laboratory testing, so blood, urine, iohexol, which is a specific GFR measurement, EKG, chest x-ray, abdominal CT, tissue typing, and physical exam. So it is a really rigorous workup. And she's approved. So about 44% of donors are approved from evaluation after evaluation. So if you think about it, there's not that many, there's a certain amount of people that express interest in donation. Of those people, that number is whittled down because of pre-existing conditions or other issues that are not compatible with donation. And then of those people that come to evaluation, only 44% of those people, so less than half of the people that come to evaluation are approved. So she was one of our really quick approvals. So she went to evaluation and was approved the following week, which meant she had a really flawless workup. And then they were able to schedule surgery right away. So her surgery was scheduled for July 16th and her pre-op was set 5 days before that. So 22 days from the day she walked into evaluation to surgery, which is about as fast as we can do it. So donor goes to pre-op. Now at this time, we were doing pre-ops closer to day -1, day -2. In this instance, this donor went, in our current model, we actually are doing our pre-ops more like day -7, day -10. But this donor wanted to attend the recipient's pre-op. So she negotiated this day -5 pre-op, had labs done. These are just the basic labs that you do at pre-op, and had a serum HCG, which was negative. Had provider visits. So nurse practitioner does an H&P, surgeon visits the patient, does consent, and the donor coordinator educates about the day of surgery and post-op expectations. So recipient, meanwhile, undergoes a pre-op as well. Day of donation is an early check-in, 5:30 in the morning. Of course, it's this sort of revolving door of people giving you the Spanish Inquisition, everyone kind of asking you the same questions, running through to make sure we have the right patient, right procedure, everything looks good. So of course, all these people are coming in, introducing themselves, talking to the patient. And because she had done her HCG at pre-op 5 days before surgery, that was no longer valid. So a day of pre-op HCG was done. And as you already know from the title of my presentation, the donor did have a positive HCG result. So timeout, of course. Donor is informed she is pregnant. She is not particularly, doesn't seem particularly phased. She says, I don't even know that I'm going to keep this pregnancy. Regardless, I want to proceed. I want to donate today. So this is kind of the fun interactive part if we were in person, or I had a way to poll you guys, but I don't, so you can just make a mental note. But your options at this point are to proceed with surgery, stop and cancel, or you can just be non-committal and plead the fifth. So next, what we did was utilized, as any good, strong team would do, we utilized our multidisciplinary team. So we gathered the donor team, the maternal fetal medicine team, and an ethics team. The donor team huddled, and that involved the surgeon, fellow, anesthesia, donor coordinator, donor social worker, and ILDA. Anesthesia, not surprisingly, because they tend to be really conservative, they did not want to proceed. Patient was counseled regarding post-donation pregnancy outcomes at this time. And what we know about post-donation pregnancy outcomes is that there is an increased risk of gestational hypertension or preeclampsia in pregnancies after donation when compared to pregnancies before donation. There have been a handful of studies on this. The percentages can be anywhere between 5 and 10%, depending on the article you look at and where the study was done. But we know that it's a statistically significant value, and we certainly counsel any female donor that is not completed their family planning or doesn't know if they're about their family planning situation to consider this additional risk when agreeing to be a kidney donor. So we worked through all this information with the patient, and she continues to want to proceed. So next up was maternal fetal medicine. They perform an ultrasound, and she is about 8 weeks gestation. General anesthesia agents are unlikely teratogens. So this is sort of what they call an all or nothing effect on the fetus. All meaning that it can severely compromise the fetus, or none meaning that it just doesn't really have any effect on the fetus at all. So basically, we don't really know. What we do know is that non-obstetric surgery occurs in about 0.5 to 2% of pregnancies. The most common reasons why pregnant women have surgery are appendectomy and cholecystectomy. I think bowel obstruction was number 3, but it's just kind of a few reasons usually. If it's possible, surgery is safer in the second trimester. There's just less risk of miscarriage in the second trimester. We know that physiologic changes occur in pregnancy, and they span across almost every organ system. And there are hemodynamic changes that begin at 5 weeks. So thinking about putting someone under anesthesia, using paralytics, intubation, things like that, there is data that says that you need to be particularly careful with oxygenating to ensure that the fetus is properly perfused. In terms of fetal outcomes during surgery, the miscarriage rates are similar, about 10%, as well as the birth defect rates of non-pregnant patients, of non-surgical patients. There are increased rates, though, of low birth weight infants and early neonatal death in women that have had surgery. Again, these are really small studies and small numbers, just because, again, it's not particularly common for women to have surgery while pregnant. Donor acknowledges this information and continues to want to proceed. Also of note, there is an international case study that in 2006, a mother donated her liver, or a portion of her liver, to her 1-year-old son while 18 weeks pregnant. So next up, of course, is decision time again. So we know mom has heard from the transplant team and been counseled. We know that mom has heard from maternal fetal medicine and been counseled, and we know that she continues to want to proceed. So again, our options are to proceed, to stop, or to plead the fifth. Meanwhile, OR space and pre-op space is precious resource. And so this is kind of dragging on. So the patients moved to the inpatient solid organ transplant unit. That's where I intercepted the patient because it was early in the morning and people were just getting their day started, and no one was really in a position to take this patient, to take care of her. So I was called in to do that. So this is where additional deliberation occurs, as well as an ethics consult. Of course, patient is really upset. She's getting further away from the operating room. She's getting a little more hostile, tearful, just really anxious to get the show on the road. Also, the recipient team and the recipient themselves are waiting. With living donation, we are very careful to protect donor information from the recipient. So we always assure patients, and it's part of our consent process, that we will never share information about them and their medical health with the recipient. So in this case, the recipient team, of course, the surgeons, know that there's a delay, but the recipient themselves do not, know what the nature of the delay is. And of course, with family or anything else, the donor is always welcome to tell the recipient, but we as the donor team will not share that information. So Ethics 101, this is just a basic sort of a crash course here. There are 4 main ethical principles: non-maleficence, autonomy, beneficence, and justice. Justice kind of doesn't apply so much in this case. It's really about doing things consistently and scarcity of resources. And in this case, technically the fetus is not viable. And so we don't really have enough, coffee or time to sort of think about that in terms of this picture. So we just are going to focus on these 3 main principles as they apply to the patient, the donor. So autonomy, and those are the rights of an individual to self-determination. The patient has the right to refuse or choose their treatment. The things we asked ourselves related to autonomy was, does informed consent exist? Is the patient able to, understand and make an autonomous decision? Is the donor able to consent to additional risk? That is a common theme you see in organ donation and living donation, where donors might have risk factors such as clotting risk or other things related to their history that they might be willing to agree that they're willing to accept all those additional risks, but the surgeons and the rest of the team also have to agree that that's a reasonable risk for someone to accept, given that this is an elective procedure. We also had to ask ourselves, are we being too paternalistic? And again, a very common theme in donation when we have donors with high blood pressure or kidney stones or things like that, is it sometimes, our bias in terms of telling them they can't do something, or is it reasonable for them to accept some additional risk and go forward with donation? Non-maleficence is to cause no harm. So it's more important to not harm your patient than it is to do them good. The questions we asked ourselves with this principle is the risk of harm too high relative to the benefits? Do we even understand what the additional risks and harm are? So certainly, this was unexpected, and we didn't know if we even had time to really anticipate all the additional risks and harm other than just the surgery itself, the post-op care, post-op management, and so on and so forth. Beneficence is to act in the best interest of the patient and promote well-being of others. We know that with living organ donation, there's no medical benefit to the donor. Of course, you can argue that there's plenty of benefit to the donor in a psychological, emotional, family way, spiritual way, possibly, but we are not making them medically better by putting them under anesthesia and taking their kidney out. There is a clear medical benefit to the recipient, and there's non-quantifiable benefits to the donor and the family. So next up is ethics consults. And they recommend that surgery should be postponed until the patient has the opportunity to process all of this information. Donor continues to want to proceed. So now she's had 3 separate multidisciplinary groups counsel her. And and she continues to want to proceed. So again, your options are to go, stop, or plead the fifth. Fun fact, this is my younger brother when we were in Paris at the Rodin Museum. And we thought it was so cool that we got to see the thinker in person. And then we found out Rodin made hundreds of these. And this is just a thinker and not the thinker, but cool nonetheless. So at this point, you've probably made up your mind. I'm kind of guessing in my head, most of you are leaning towards, yeah, cancel, postpone. But I'm going to sort of stir the ethical pot here and see if anyone changes their mind if I told you that C is only 5 years old. So she's a true pediatric patient. She's not an adult child. She's a young child. She's dialysis dependent. And even if you don't know any 5-year-olds on dialysis, you can imagine that that would be very challenging to have a young child undergoing those types of treatments. She's also wheelchair bound. She's severely developmentally delayed. She has Sensenbrenner syndrome, which is a really rare genetic disease. It's, they think only about 100 people have been diagnosed with it. It's an autosomal recessive disease. It has cranioectodermal features. So there's issues with the soft tissues. There's issues with kidney and liver abnormalities. And it's a very debilitating disease. And also, so I told you that it's a very rare disease. 2 kids actually have it. So C, the child that needs a transplant, has it, as well as her brother B. So there's 2 children in the family with special needs. So you can already start to kind of see the picture that this family has a really stressful situation. This is just a stock photo of a child with Sensenbrenner syndrome. That's short limbs are another hallmark of the disease. So wondering if any of this new information has had anyone change their mind. Also, this is our hospital, our adult hospital, which is on the East Bank campus. And our children's hospital is, of course, on the West Bank on a different campus, separated by the mighty Mississippi there. So most of you are from the area, so this is not that much of a bombshell. But when I gave this presentation in Orlando, people really had strong feelings about that, just that this family unit wasn't able to be together while they were going through this situation, and they were physically separated. And speaking of separated, mom and dad are separated. So mom and dad are biological mom and dad. Dad is with the child at the children's hospital, and mom is, of course, by herself at the adult hospital. Mom is pregnant with her significant other's child, who's also not present. So mom's really the only one that knows what's going on right now. And we're not sharing mom's medical information with her ex-husband, of course. So things are just, really tense. So at this point, you're probably feeling a little uncomfortable and wondering if maybe anyone has changed their mind. Final answer. Well, we canceled surgery. The donor discharged, not happily. She kind of left kicking and screaming. Recipient dialyzed at the Children's Hospital and discharged as well. And a cool off period begins. And this is an actual picture of me this morning because it was so cold. So it really came down to informed consent for us. Informed consent is a shared decision-making process. It requires competence, volunteerness, disclosure of information, recommendation of care and plan, understanding of the information, decision by the patient, and the authorization to proceed. We felt that the donor did not meet those requirements due to emotional duress. Now what? The next day the social worker calls, patient seems to be coping and seems okay and has cooled off some. The next day the donor coordinator calls, patient is very upset, becoming more hostile and angry. So things are heating up. Donor demands to be seen in clinic. At this time, a group is assembled, surgeon, social worker, advocate, donor coordinator. What the donors explained is that she does not meet criteria to donate her kidney at this time. However, she is encouraged to work with her primary care physician and her OB/GYN and her spiritual advisors or community, family, whomever she'd like to lean on to make whatever decisions are in her best interest. And that she's welcome to come back to us if she's, whether that's in a couple days or in a couple years, when she's medically suitable to be a donor, but that we are not going to do this surgery while she's pregnant. So she was not pleased with this answer. And so they actually called in the department chair just to add another layer of support and kind of cohesiveness from our team and a united front. Of course, we recommended lots of other things, that there can be, the eggs aren't all in her basket, another donor can come forward. Again, reviewed the post-donation pregnancy implications. Donor is not a surgical candidate again because she is pregnant. So just a quick review of the timeline. We talked about mom getting through evaluation to surgery very quickly, only 22 days. But if we march it back, it's been 133 days since they kind of started this journey. So in mom's eyes, this is just adding more and more and more time to something that she had hoped would be over. And she is feeling very defensive and very angry and really trying to advocate for her family. Timeline continued. 9 days after surgery, donor undergoes elective D&C. That was, of course, with her own physicians. We were not privy to the information till after the fact. Subsequent HCGs were trended, and once they were undetectable, we were able to reschedule surgery. She had a pre-op on the 15th and surgery on the 20th, which was 35 days from the original surgery. She was actually in the hospital 4 days, which is unusual. Our average length of stay is 1 to 2 days, but she had some sort of, pain and post-op nausea, vomiting. And she did not come to her post-op appointment. Fast forward to the present day, donor's creatinine is 0.86. She gave birth to a healthy baby girl in 2018 and a healthy baby boy in 2020. Had no issues with preeclampsia, very normotensive throughout her pregnancies and beyond. When I gave this speech right before COVID, I guess, the recipient was doing well and her creatinine was 0.6. But when I went back to prepare myself for this presentation, she was actually retransplanted earlier this year. It sounds like she had a septic episode and had some loss of her graft function and needed a new transplant. However, the good news is her second transplant is working well, and her creatinine is normal at 0.87. So in conclusion, did we make the right decision? We'll never know. We think we made the best decision at the time. In the end, we felt that patients' informed consent was compromised. There was a lack of shared decision-making. The risks exceeded the benefits. And ultimately, kidney donation is elective. It is a precious resource, and we need to be good stewards of it. It takes a village, of course, to get someone to transplant. And it's a lot of work on the donor and recipient team. And of course, all the people that are working throughout the whole process. And this is a thank you to all of those people that help make these transplants happen. That's what I got.
Thank you so much, Annie. What a fascinating case. Does anyone have any questions for Annie? Thanks for sharing. All right, if anyone has questions for Annie, please feel free to email them to me or directly to Annie if you know her, which I'm guessing a lot of you do. And we will move on to our next speaker. Thanks so much, Annie.
Thank you.
Our next speaker is Reverend David Hottinger. Reverend Hottinger is the spiritual care manager at Hennepin Healthcare. He holds degrees from Oberlin College and Harvard Divinity School and was a Wallenberg Fellow at the Hebrew University of Jerusalem. David has served as a family support coordinator for LifeSource, a staff chaplain at Hennepin Healthcare, a chaplain in hospice and community and mental health settings, and a refugee relief worker in the Middle East. He's an adjunct professor at the United Theological Seminary of the Twin Cities and has been a leader in an initiative to transform Hennepin Healthcare into a trauma-informed system of care. And with that, we're very excited to welcome Reverend Hottinger. Thank you so much for joining us.
Yeah, thank you, Christine. I'm gonna go ahead and share my screen. Right. All right, can everyone see those?
Yes, you can.
Perfect. All right. Well, good morning, everyone. It's a pleasure to be with you today. I looked at the agenda and I was like, wow, I'm the one sort of non-clinical presentation for your day. So it looks like you have a packed agenda with some really, really cool stuff. So my task this morning is to talk a little bit about taking care of healthcare workers in times of trauma. And I would certainly characterize this as a time of trauma and an extended one. And really, I'm going to do this talk through the lens of trauma-informed care, which has been, it's a set of practices and really a change of perspective that has had a huge impact on my own work as a chaplain, as a clinical caregiver at Hennepin Healthcare. I'm going to talk a little bit more about that journey and what that shift might look like, and with the hope of really giving you some practical tools to take care of yourselves, to metabolize your own exposure to secondary stress and trauma as you take care of patients and families and one another. So I think I'd like to just begin with the question of, is what we're doing now working? And I would have to answer for myself, not so much. I think some of the tools that we have developed in healthcare to metabolize stress, to try to overcome conditions of burnout and compassion fatigue aren't really always up to the task of what we're facing right now, especially with COVID-19, with the social unrest following the murder of George Floyd, also just the ongoing state of surge that our hospitals are experiencing with so many sick patients. And so you could put in the chat or just speak out. I'd like to kind of get a pulse from you all about, where has COVID-19 put us on the edge of or over the edge of? So what are some of you feeling or experiencing in your own work settings? I'd just love to hear a little bit. If anyone would like to put in the chat or turn your microphone on and talk. Sorry, what was that again? Oh, I'm a chaplain. I'm very good with silence. So feel free to just type in something like, what are you guys feeling right now in your own organizations? Understaffed, burnout, yeah. Initial guilt for not being on the front lines, strong, yeah. Anybody else? Anger, yeah, unstaffed, overworked, limited resources, anger that people are selfish and refuse to be vaccinated, yeah, for political reasons. Yeah, these are all things. Closed OR due to not enough staff, not able to get patients in for needed procedures. Frustrated people don't want to be listed, or yeah, to the facts, or yeah, some of the usual coping mechanisms don't work. These are all exactly things that I've been noticing and experiencing in my setting. Tired of rolling with the punches of having to change how we operate due to COVID. The ongoing, just, you don't know what the next day is going to hold. So a lot of those kind of old models that we learned how to cope, focused on, okay, to be resilient, you need to just take care of yourself better. You need to eat right diet, you need to get more sleep, you need to exercise, you need to have better work-life balance. And those strategies are all good strategies, but they don't really work over the long haul in a sustained trauma situation. And kind of what we are facing has been kind of a mass casualty disaster situation in a sustained way. And we don't really have a framework in our healthcare systems to address those kinds of things. So I do think that trauma-informed care is one way of looking at this, and has really given me a helpful framework as we try to think about things differently. Here's one definition. There are a number of them out there. It's about 10 years old, a definition of trauma-informed care. It's a strengths-based framework, so that's important. It's not just talking about pathology and the things that are wrong. It's based on our strengths and our innate ability to cope and to survive. It's a framework that's grounded in an understanding of and responsiveness to the impact of trauma, emphasizes physical, psychological, and emotional safety for both providers and survivors, and that creates opportunities for survivors to rebuild a sense of control and empowerment. So those are really key themes here. Recognizing the impact of trauma and traumatic stress. To move forward, we have to sort of acknowledge what's actually happening. We've got to step back and take the time and say, this is painful. We are overwhelmed. We're not sure what we're doing. We're feeling a lot of, we're suffering even. But to do that is hard. We'll talk about some strategies to do that. But in the long haul, we want to build a framework that creates opportunities for us to feel a sense of control in our day-to-day lives, and a sense of empowerment, even in the face of this overwhelming crisis, because so many things are out of our realm of control. What are the things we can actually control day in and day out? A couple resources that were really key to me in my journey as I learned about trauma-informed care was the work of Sandra Bloom, who's a psychiatrist out in Philadelphia. And she's written some really amazing books, not just about individual trauma, but really how healthcare systems as systems can be impacted by trauma and traumatic stress. So here's one of her definitions of traumatic stress. It's when we experience an event that's overwhelming, usually, not always, life-threatening, it's terrifying or horrifying in the face of helplessness. And certainly that definition rings true for me as I looked back on those initial weeks and months of COVID-19, when we didn't really know what we were facing. Our setting, we received a lot of really sick people. HCMC at one point had the most COVID patients in the state. A lot of them were dying. We didn't really have great treatment options at that point. And for me as a chaplain, one of the most terrifying and things about which I felt helpless was how to care for these patients who had no families present as they were so sick and as they were dying. And sort of the moral distress and moral injury of doing that had a huge impact. And me and my team really weren't prepared. Nothing in our training had prepared us for the kind of work that we ended up doing. SAMHSA, for the federal government, they define trauma, again, as an event or series of events or a set of circumstances that's experienced as physically or emotionally harmful or life-threatening and has lasting adverse effects on our functioning. and our mental, physical, social, emotional, and spiritual well-being. So it's not the event itself that's necessarily traumatic, it's how our brains and bodies respond to that event and what we do with that event and that stress that we are experiencing. Forgive the really amateurish, but I do think this explains quite well without going deep into the science of trauma. There's some amazing work out there that's being done. If anyone wants to go deeper into some of the science, I would highly recommend a fairly new book. It's actually an interview book with Dr. Bruce Perry, who is a quite famous neuropsychiatrist, a pediatric neuropsychiatrist, and Oprah Winfrey, and it's called What's Happened to You. And it's a really fantastic book about trauma-informed care, what happens to children, especially when they're exposed to traumatic stress, and how we as healers can respond to those things. But our brain and our bodies are really programmed quite beautifully to survive. And under normal circumstances, we're going down the road, we're taking in stimuli from our environment, our bodies and brains are interpreting that stimuli, we're processing what we're experiencing. We go to those higher brain functions where prefrontal cortex is working, and we know how to evaluate options, we're planning, we're acting, we're in that thinking brain mode. Well, when there's a threat, that proverbial threat on the road, and we meet the bear, something terrifying presents itself, our brains and our bodies are programmed to survive. And so you bypass the processing, evaluating options, the planning. You're not solving a math problem or thinking complex thoughts. We go into the reactant state where the amygdala takes over, the limbic system takes over. We react. We're programmed to fight, to flee, or to freeze, and that's what we're programmed to do in order to survive. Well, the problem is with repeated stress, for a lot of people, that alarm system express route becomes the main road. So when there's stress and trauma coming at us all the time, we get conditioned to going into that survival mode. And then we are unable to access our thinking brain, or it gets really hard to do that. And you see this with patients and with families and with staff who are exposed again and again to conditions of stress. And the key here is then we're unable to perceive threat that's real from threat that's perceived. We're always in that state of hyper arousal. We're always ready to be triggered, where some people are always kind of going to that shutdown mode. And that becomes really, really difficult because so much of our healthcare system is based on at least somebody being in thinking brain mode. And ideally, it's going to be both the patient and the staff person, the provider who's in thinking brain mode. We can talk. So I heard some of that, some of the story of the previous talk and about that donor. I'm guessing, the day that she came in and demanded to speak to the team, she was probably not a lot in thinking brain mode. She was in survival brain mode and was triggered emotionally in certain ways. So you always have to kind of consider what part of the brain are you actually talking to when you're dealing with someone who is in crisis. We teach this metaphor. It's a very basic one. We teach this at our hospital, where we've got the thinking brain that's like the rider on the horse. Thinking brain's making those rational, informed decisions. The survivor brain is the horse. That's protective, based on protective instincts, based on feelings. And when triggered with threat, the rider falls off the horse. That's natural. That's supposed to happen. That's going to happen to us when we're triggered in, all these stressful environments. The key for us is, though, we have to have strategies for ourselves to get our rider back on our horse. We at least need to have strategies in our organization for other people to help us get our riders back on the horse. We need strategies to help learn how to get our patients and their distressed family members' riders back on the horse so that we can move forward with our healing work. Some characteristics of trauma-organized individuals who get organized around that constant trauma and threat. They become unable to grieve and to anticipate the future. They have lots of problems with authority. Don't tell me what to do. Become quite reactive. They're very mistrustful. because they have a lack of sense of basic safety, loss of ability to control their feelings and their emotions, problems with thinking. So you think we're communicating this clear communication with people, and they're grasping like 10% of what we're saying because they're in survival brain mode and they can't process what is actually being said. Problems with communicating, and then a confused sense of fair play. So lots of people think, well, you're out to get me. There's always a game that's being played here. There's always an agenda, and they don't trust at all. Well, this can actually happen in whole organizations. It can happen to whole teams when we are experiencing ongoing threat, or when we're dealing with all of these patients who are in such a state of trauma reaction themselves, where we take on those same characteristics ourselves. And then this bottom one, I think, is especially important, because then over time, what happens is we lose our ability to act justly. And I've seen this happen in my setting, where we become so overwhelmed by all the situations we're encountering, we get frozen, we fail to act in a just way, or we fall back on policies and procedures and aren't always like there for good reasons. And then it just contributes to that cycle of mistrust and trauma that our patients and families are going through. So it's important to remember here that 80% of the feedback is going from our bodies to our brain. You know, when stressed, we're holding tension in our body. This isn't an intellectual thing. Only 20% of our nerve fibers actually go from our brain to our body. So there's this feedback loop that we really have to pay attention to, that we can't think ourselves out of stress. And a lot of our models of healthcare delivery, a lot of what we learned about how to be good providers are intellectually based, and we're not paying attention to what's going on in that moment. Like, I'm really uptight. I'm holding all this stress in my body right now. We do talks at the hospital to a lot of nurses. When we're doing our trauma-informed care training, we ask nurses, what's the longest you've ever gone without going on a bathroom break? And you hear these remarkable answers, 8 hours, 10 hours, 12 hours, 14 hours, 16 hours. Oh, I worked a double. I didn't have time to go to the bathroom. So you're holding all of that tension in your body. How can you actually, begin to metabolize the stress that you are experiencing when you're holding that deep tension? Your body wakes itself up in the middle of the night when you have to pee. Why do you think that you can go 16 hours without going to the bathroom and then stay in a relaxed state where you can metabolize some of the stress that's coming at you? So that's a really important thing, I think, for us to transform some of what we do to overcome stress and trauma. Pay attention to our bodies, and to recognize that people over time begin to develop this trauma lens. When they're perpetually stressed, they begin to view the world through that lens, and it modulates our feelings and attitudes and beliefs about others when we're framing everything through this lens of trauma. Just some graphics here. So with regards to trauma or stress, oops, my little quote kind of disappeared here. Sorry, my point. Well, we need to realize, this is from Stephen Porges, when people get triggered into either mobilization defenses, that fight or flight or shutting down, they're going to develop elaborate narratives, stories to make sense of what their body's doing. It's important to acknowledge the awareness of body reactions. These reactions not only shift physiological state, but also bias perception of the world. And I wonder if that's what's happening right now in a lot of healthcare, where we're so overwhelmed, we're so besieged. It's hard for us to even go back and see the purpose of why we're there in the first place. And I'm going to talk about that in a moment, because we're just in the survival state on a day-to-day basis. It's hard to go back, recover that deeper sense of meaning that has brought us to this work in the first place, because of this sense of anger and powerlessness that many of us have right now. The fundamental question of trauma-informed care is moving from what's wrong with you, patient X or nurse Z or Dr. Y, We're looking at that behavior, those outbursts, that shutdown, or even ourselves when we start to judge ourselves, to a deeper look at what's happened here to cause people to show up this way, to motivate the actions that don't seem very adaptive right now in the moment. What's happening right now to our systems of care? What's happening to our leaders? And that helps us view the world. Doesn't help us necessarily fix or change some of those realities, but it allows us to take a step back, to breathe, to develop some empathy and a deeper sense of compassion, and then hopefully to also empower us to begin to change the things we're able to change in our direct sphere of influence, which really begins with ourselves, especially how we're regulating our bodies and our brains and our spirits. First, we have to overcome this myth of objectivity that we have been trained as healthcare providers, that, well, we're not impacted by the pain and suffering of our patients. We're not impacted by the trauma and stress that is going on in our wider society that is now crashing down on our healthcare systems. And what this myth of objectivity does is it makes us ineffective for developing and maintaining resiliency, because we tend then to go into shame, like, oh, I'm a bad provider, I'm a bad nurse, I'm a bad chaplain because I can't deal with all this stuff that's coming at me. I'm supposed to on my own figure this out. I don't have the tools to do it. I'm not really supposed to be impacted by all this. So I go into shame, I go into more isolation, I develop more fear response and exile. And we see people even leaving the profession in fairly large numbers right now because of this reality. Part of this is because of something that we are programmed to feel with one another. I'm just going to play this real quick. There's no sound at the very beginning, but
let me take you back to the early 1990s, sleepy little laboratory in Parma, Italy. And scientists had a MRI brain scanning machine on a macaque monkey as the macaque monkey was trying to open up a nut. They wanted to see how the neurons would light up. So the monkey's trying to open up the nut, the neurons light up. And just by serendipity, and this is how science sometimes happens, a human being walked into the laboratory. I don't know if it was by mistake, and he was hungry. He saw the nuts and opened up one of the nuts and tried to crack it open. The macaque monkey was totally shocked because who was this invader in his laboratory? And he didn't move. He just gazed at this human trying to open up the nut, just like he had done a few seconds earlier. And then the scientist looked on the MRI brain scanner. The same exact neurons were lighting up when he observed the human being opening the nut as when the monkey opened the nut. And the scientists had not a clue as to what this was. They thought the MRI machine had broken. They then began to put MRI brain scanning machines on other primates, especially chimpanzees with our big neocortex. Then they went to humans. And what they found over and over again is something called mirror neurons. And that is that we are apparently soft-wired, some of the primates, all humans. We suspect elephants. We're not sure about dolphins and dogs. We've just begun. But all humans are soft-wired with mirror neurons, so that if I'm observing you, your anger, your frustration, your sense of rejection, your joy, whatever it is, and I can feel what you're doing, the same neurons will light up in me as if I'm having that experience myself. Now, this isn't all that unusual. We know if a spider goes up someone's arm and I'm observing it going up your arm, I'm going to get a creepy feeling. We take this for granted, but we are actually soft-wired to actually experience another's plight as if we are experiencing ourselves. But mirror neurons are just the beginning of a whole range of research going on in neuropsychology and brain research and in child development that suggests that we are actually soft-wired, not for aggression and violence and self-interest and utilitarianism, that we are actually soft-wired for sociability, attachment, as John Bowlby might have said, affection, companionship, and that the first drive is the drive to actually belong. It's an empathic drive.
So really, I think an interesting, that we have science behind this, that we are wired to connect with one another, and that when we are witnessing the distress of another, we're impacted by this. So I think that the new paradigm that I'm suggesting here with trauma-informed care is just to put on the table caregiving hurts. It does have an impact on us emotionally, and to sort of name that reality and sort of acknowledge that it's impossible to avoid the pain associated with professional caregiving. But we don't have to suffer in the pain that we're experiencing, that there's a difference between pain and suffering when we can evolve and mature our personal and professional skills to metabolize our own reactions to the pain that we are encountering in what we're doing in these toxic environments. And that it is possible to be healthy while working in a toxic environment. I don't know about you, but I don't really see our healthcare systems changing radically anytime soon. So I think for all of us, we have to make a determination, and some people say, hey, I just can't sustain myself amidst all of the pressures and the new realities. But are there other things we can do to keep ourselves healthy, to metabolize our distress, to heal our trauma, even when with all this toxicity around us? And I think that's sort of the fundamental question we have to ask. So again, the old paradigm is we've got where I'm just an objective caregiver, I'm not impacted by this, to yes, I'm a relational human creature, I'm a relational human being, I'm going to be impacted by what I see going on around me. The myth of this has no effects on me, this work doesn't really impact me, to yes, it does, but I can be resilient in the midst of that. Where there's this denial of weakness, I'm the tough care provider, to an acceptance of pain, from stoicism to saying pain is not suffering. Suffering is the story we attach to the pain. And I'm going to talk about that in just a few minutes. Moving from, I just need to suck it up and deal with it. And that's kind of a message, I hear a lot in my place. We're a level 1 trauma center. I'm just going to suck it up. And of course, that has this long-term impact. How do people really suck it up? Well, they go home and they have to drink a 6-pack to go to sleep, or they kick their dogs, or they just check out with their families. And that's not working well. Moving to, there are strategies I can adapt to regulate myself, not just when I go home, not just before I go home, but in the moment, in the day, throughout the day, so that I can get my rider back on the horse, let go of some of that pain that I'm experiencing, and go home to my loved ones intact. And then I love this, going from I got to be strong but brittle, the tough nut, to yes, we can maintain our strength, but we can also be malleable. There's an image that comes from Buddhism that talks about us having a strong back and a soft front. So I can be very strong in my caregiving, in my ethics, in my professionalism, and in my boundaries, but I can also have a compassionate heart and presence with my patients and families and my colleagues in the face of the pain that they're going through. And then moving from this notion that, all the stress I'm dealing with is caused by my environment. Well, a lot of it might be, but what is our personal role in how we deal with the impact of that? Because I think our systems, from where I sit anytime soon, are not going to, again, take a lot of responsibility. So we have to take responsibility for staying well within those systems, even as we change that system, because that systems need to change. So I'm going to get into a couple strategies before I close out here. Why trauma-informed care? And it really has to do with, we can have more empathy for ourselves and the people we welcome into our environments, because we can make ourselves aware of the way in which our internalized experience of stress in others impacts us. By changing from what's wrong to what's happened, we start to understand problem behaviors as adaptive to a distressed nervous system, and talk to the part of the brain that can receive information. And that's been a really key shift for me in my work. We recognize that our nervous system doesn't know the difference between past and present. Our job is to make sure our brain is reassuring it. It's got to reassure the nervous system. Okay, what's going on right now is not a real threat. The story I'm telling myself needs to be reframed. And I have to learn the difference between threat that's real and threat that's perceived, so I can go home intact. And frankly, this has been hard to do, when you're facing a pandemic, because you walk into a room, you walk into a Target, you walk into a restaurant. Am I going to be exposed to something? Am I going to take something home to my family or back to work? Or am I overreacting to all this? So I'm not saying this is an easy thing to do right now, especially as we're so on edge collectively. So a couple strategies that I would leave you with to do some of that trauma mitigation and healing. The first is to find ways to cultivate safety. The founder of polyvagal theory, which is very important in trauma-informed care, Stephen Porges, he says, safety is the treatment. A fundamental experience of trauma is having our sense of safety in the world disrupted and compromised. So the more we can do to reduce the effects of trauma, to restore conditions in which we can experience real safety at the neurobiological level. So do you have, and part of this is about having people in your life who can help you do that, having a place you can go that you feel safe, having someone you can talk to and vent to if you need to just get stuff off your chest, having a work environment where, and this is, I know, easier said than done right now, where even if it's going to an office, going to a quiet room, where you can get yourself kind of the rider back on the horse when the rider's falling off, and to go, okay, right now, in this moment, I'm not unsafe, I am safe. I can get through this day, I can help this next patient, but I need to take some breaths, I need to slow down, I need to reconnect with why I'm here and the compassion that I know I have in me. And it begins with our sense of being physically safe. Safety is also emotional, it's cultural, it's social, and it is spiritual as well. So do you have spiritual practices in your life that can help you do that? Do you have a culture you're connecting to that's giving you a deeper sense of purpose and meaning? Embodying presence. This is a quote by Bonnie Badenoch, who's a therapist, does a lot of work in trauma-informed care. And she just puts it so beautifully. I think we all need groups of support that are dedicated to just being present to one another. Whether it's 2 people getting together, it's 10 getting together like you all are today, however many people you are, even by Zoom as we collectively gather, there's a sense in our bodies that we're really just here for one another. We can hold whatever's happening and that arises in that moment. We're meant to be interdependent through our entire lives. And I have found that really key, particularly when I was working in transplant directly, when I was working at LifeSource, going in and out of these really trying situations that were sometimes, we didn't have the answers. We couldn't fix what was happening, but I had people I could go back to in my organization that I could be present to, that I could say, wow, this has happened. This has been hard. And that created a sense of safety for me to go on and do the work the next day if I needed to. It was also nice. Usually when I was out in the field, I wasn't always totally alone. Sometimes I was. Having someone even I could make a phone call to. We developed a practice as family support coordinators. We would call a friend before we would go talk to a family, a donor family. And we would just ground with them a little bit and say, is there any barriers for you right now going in to do this work? How are you feeling in your body right now? What do you need to let go of? And then after that conversation, the same kind of thing. And that helped me get re-regulated so I could finally go home and leave some of that at work as well. We are meant to co-regulate, to be with one another, and that's the core of it all. But relationships can signal for some people safety, for others threat, for all of us threat and safety. So we have to recognize like what's actually happening. A lot of that awareness of threat really is unconscious. It's in our bodies. Trauma can severely distort people's ability to distinguish from real from perceived threat. So we have to recognize for some of our patients in particular who have had trauma in their lives, they're going to feel fundamentally unsafe even with us. And we have to go the extra mile to help co-create those conditions of safety so that, again, it's less stress that's going on when we're encountering them. And then to reframe some of the behaviors, these problem behaviors that we see in our patients and their family members, maybe in our colleagues and ourselves, that a lot of the things that we see as attention-seeking behaviors, that we label manipulative or abusive or whatever, they're in fact connection-seeking behaviors. People they don't know how to make those connections, but we have to ask, what's the need behind the behavior? So just one tool to do some of that is one of the strategies we teach. Is the pearls concept. Hey, let's work on this together. To always express empathy. That sounds frustrating. To make apologies. You don't have to agree with what people are saying or say, yeah, you're right, but hey, I'm sorry that happened. To validate through respect. You've gone through a lot. Makes sense that you're feeling this way. And then support. Let's see what we can do. That's one just mnemonic to help us build relationships in our day-to-day. And then witness. This comes from Deborah Hunsinger, who's a theologian. Though compassionate witnessing does not remove the pain of trauma, it reconfigures it by restoring human connection, building strength and hope even in the midst of tragedy. This is hard, I think, for us as healthcare workers because we're trained to fix. I know in the world of transplant medicine, you can't always fix or change outcomes that become truly tragic. So at what point are we able to step back, use our compassion, even as we're feeling the sadness and the grief of what our patient or their family member is going through, to witness and to stay connected as we bear witness in outcomes that we can't change. My experience is those who are able to do that and to do that well are the ones who remain resilient in this work. They keep that strong back and soft front. My mentors in this work have really taught me a lot doing this. It's not always easy, but it also is incredibly powerful for the people for whom we're able to do this, to be a witness. Now, my last couple things here, I'm going to close. To nurture story. When trauma leads to physical and mental injury, it also engenders a healing response. One aspect of this is the trauma story, whose function is not only to heal the survivor, but also to teach and guide the listener, by extension, society in healing and survival. So nurturing story, we're created to be storytellers. And I know it's hard in the clinical setting. Sometimes we don't have a lot of time with our patients and with their families, or even with one another. Can we create time to have those stories told? And I know when patients are given a chance to tell their stories, and I know in my work, I was more on the family side, working with LifeSource, when I was able to get into a room and hear those donor families tell a story of their loved one, and say, tell me about Amy, and how powerful it was for me. And I know sometimes it was sadder. Sometimes I was like, oh, I don't want to be here listening to this. When I was able to let that wash over me, it created a much deeper sense of meaning and inspired me to go on and do the work that I was doing, hard as it was. We would also bring in donors who would tell their stories of their sickness and how donation had saved their lives, and hearing those stories was incredibly powerful and nurturing and helped me stay resilient in the face of some really, really difficult work. So nurturing story is really, really key. And then finally, unearthing meaning, sources of meaning and sources of strength. There's a whole new field that's emerging called post-traumatic growth. We recognize for some people, the trauma never goes away for some people. So it's sort of a myth to say, oh, people can come out and they're totally like transformed and not impacted for the rest of their lives by what's happened. But trauma can transform people in powerful ways and make them more compassionate. It can make them much deeper conduits of healing for other people. We all know people who had been through just incredible challenges, who emerge as these incredible teachers. And so I love this quote from Dr. John Allen: "To hope is to adopt an existential stance. The grounds for hoping do not lie in the facts of reality, but rather in the meaning we ascribe to reality. Hence, hoping is an active process of meaning making. While hope is founded in our capacity to make sense of suffering, we need more than the power of our reasoning to sustain it. We need more than the head, we need the heart." Viktor Frankl, famous psychiatrist who lived through the concentration camps, he says, "We're not destroyed by suffering, we're destroyed by suffering without meaning." So as I close, the challenge I would have for all of us is, as we face these overwhelming circumstances right now in our healthcare systems, in our teams, in some of our patients who seem to be getting sicker and sicker, are we able to unearth meaning in all of that, to identify our own sources of strength? For me, one of them is a reminder, why did I go into this work in the first place? To recall some of the teachers I've had, many of whom have been my patients and their families. What lessons do they give me now for the long haul? What ways during the day can I continue to regulate my body, especially through my breathing, just breathing those deep breaths in, breathing out. Our bodies, that's one of the beautiful things we're programmed to do, to metabolize stress, taking care of myself, I'm able to regulate myself physically, and keep my rudder on the horse, so that I can go home intact. What are the ways that I can stay connected to my colleagues and to people who are important to me, as I co-regulate and offer support and provide it? And so that's kind of a trauma-informed lens I think we can use as we take care of one another and as we heal our healthcare system in the midst of all of this stress and distress that we're facing. This is not to say this is easily done. I'm not the guy for the quick fixes, but I would encourage you again to do that reframing from what's wrong to what's happened, to develop that strong back and soft heart. So with that, I'm going to close my talk, and I'm open for any comments or suggestions if you have them.
Thank you so much, Reverend Hettinger, for sharing with us. We have a couple of comments just thanking you for your talk and your insights today. Really appreciate all that you've put forward here during this difficult time.
Yeah, thank you. Thank you very much. It's an honor to be asked. Again, transplant world is dear to my heart. Actually, during my training at the University of Minnesota Medical Center, I was one of the chaplain residents in solid organ transplants. So that was really, had prepared me well then to go work at LifeSource, working on the donation side. And I'm just very inspired by the work that all of you do. And I also recognize how hard it is. It's high stakes medicine, but there is an incredibly deep emotional component because of all the life and death realities that you're facing on a day-to-day basis. So I was honored to be asked to be with you all this morning. And oh, there's Bobby, my friend Bobby. Okay, great. Fantastic. So I hope all of you have a great rest of your conference and day. And I know Christine has my email and contact information, so I'm happy to chat or reach out or share the presentation if people would like more.
Thank you.
All right. Take care.
You too. Have a good day. And with that, I will introduce our next speakers. Happy to introduce our next speakers. Dr. William Rovner and Dr. Brooke Palmer. Dr. Rovner is a board certified clinical health psychologist and is professor in the Department of Medicine and Pediatrics. He's a director of health psychology and the psychology internship at the University of Minnesota Medical School. Dr. Rovner has served on several interdisciplinary teams at the University of Minnesota Medical Center and formerly served on the medical staff executive committee of UMMC. He's worked with solid organ and bone marrow transplant patients for over 35 years. His scholarship addresses health psychology, transplants, clinical trials, adherence, education, and professional affairs. He's a former president of the Association of Psychologists and Academic Health Centers. And Dr. Robner completed his PhD in clinical psychology at Washington University. He's the recipient of national and local awards, including the University of Minnesota's President's Award for Outstanding Service, and is a member of the Academic Health Centers Academy for Excellence in the Scholarship of Teaching and Learning. And Dr. Palmer is a health psychologist and incoming assistant professor in the Department of Medicine at the University of Minnesota Medical School. Clinically, she supports patients' psychological well-being at various stages of their illness injury and works in outpatient and inpatient settings. Her research interests relate to integration of psychological services in medical settings, health behavior change, and psychogastroenterology. Dr. Palmer earned her PhD in health psychology from the University of North Carolina, Charlotte, and has trained in various settings through which she has interacted with transplant patients, including the University of Minnesota Medical Center East Bank, acute rehab settings, and the VA healthcare. So Dr. Palmer and Dr. Robner will speak to us today about psychological aspects of solid organ transplant. Thank you very much for joining us.
Well, it's a pleasure to be here. Thank you for having us. I think we were supposed to be here about a year ago and it got postponed. So it's great that something's happening now. I love working with transplant nurses, so it's really a thrill to be here today. And unfortunately, we don't have any financial relationships to disclose. If people want to come up to us later on, let us know. So we're going to be talking about a number of things today, but let's start at the beginning. Where did the patients start? You know, they're feeling okay until one point, and suddenly something happens, and suddenly they're not feeling okay. And so what are, you know, a lot of this you may have covered in nursing school previously, but I think it's always helpful to think from the patient perspective, what are all the things that they're dealing with? So they come to us, you know, certainly when they come to the psychologists, we're talking about the emotional equilibrium that they're trying to achieve. But think about all of the tasks that they've got as they try to deal with their illness and with their transplant, with their follow-up. You know, maintaining a good sense of who they are, dealing with any of the discomforts or hassles or incapacitation. A big issue is dealing with uncertainty and loss of control. They're learning a lot of language. Sometimes they tell me they wish they go into medical school to understand all the concepts that they're suddenly being barraged with. Dealing with the medical environment. I know that we used to see patients in the Phillips Wangenstein building, and every now and then you meet a patient who was going up to one of the higher floors, and they weren't used to being in buildings that were that tall. And so some very basic things that we take for granted, they're adjusting to. A big part of it is the relationships that they're trying to maintain with everybody. How does their illness fit into that? And of course, as you all will know, you know, how do they maintain relationships with all these new people that are entering their life, the different doctors, the different nurses, sort of an ongoing stream of people. I have a family member who just moved to a nursing home, and I think in the first day they met 20 new people, just to give you an example. So you know, they're coming, we're at it at a point of familiarity over time, but they're dealing with all of these tasks in an ongoing way. They're also dealing with what other people are thinking about them. Should they have taken different care of themselves if we can see some of the sort of behavioral factors that went into the illness that they have, like drinking and liver transplants, for example? Or people should have certain beliefs. Are they being punished? Is that why they're having their illness? Or you know, people say the darndest things to them. They should feel lucky that they have this instead of that. Or how come you're being seen here instead of Mayo, or being seen at Mayo instead of the U, or you know, all kinds of things. They're suddenly having to defend their actions to be criticized by things. I once saw a bone marrow transplant where a patient, their uncle would come in and say, well, the reason that you're having this leukemia is because you weren't born again. And so would try to address, when they were visiting them, all these religious things that the person really had considered very strongly and was not interested in. So there are all kinds of conflicts that can enter into it. They can be prime in people's minds as they're dealing with them. It's not just the medicine. What we know from the sociology literature that we expect people to do things when they're in the sick role. First of all, they're exempt from certain social responsibilities. Not having to do things, be it around the house, like mow the lawn if they're sick. Not having to wear a mask is one of the things we hear about these days. I have a sickness of some sort, so maybe I shouldn't have to wear a mask. We expect people to take care of themselves, to look to others for help, but to also try to take care of themselves, to do things the way that other people think they should. They should be speaking to their doctor. They should be thinking about getting a transplant if they have kidney disease, but maybe not. There are certain things about the social roles that they have that have been talked about. You look at how old this slide is, for more than half a century. And a lot of what they're dealing with is loss. There's so many stressful parts about being ill. Sometimes it's the comfort. A lot of it is the question about what's going to happen to me. How come I don't have control over my life like I used to at least imagine I had? People not being able to do things the way they used to, feeling weaker, feeling all the side effects of medicines, for example, being less independent. Americans like to be independent. There's nothing like hitting a major illness and realizing I'm not as independent. I can't do things the way I want to. How does it affect their ability to work or to have an income? So there are a lot of things that people are coping with as we're seeing them day to day that may not be front of our minds, but we need to think about. And again, a lot of it, to my thinking, is about the losses that they're experiencing. Brooke?
Great, thank you very much. So I'm going to take the baton and address, how some of the tasks in coping with acute illness may differ from chronic illness, or just how the environment may require different skills. And I'm basing this on, I have more contact with transplant patients in the inpatient settings, whether that be while they're waiting for transplant, after surgery, or due to complications that require admissions. So wanted to kind of highlight that, the role and the expectations are so different when we're dealing with more of an urgent issue, right? Patients need to exercise more flexibility, which can be hard. It can be hard if people have more of a rigid kind of approach to things, and it can be difficult to adjust that or to develop that flexibility. The stressors that we see in the acute setting, typically people respond to them in the same way they would kind of dealing with their chronic health conditions, yet the responses might be amplified, right? So if the demands upon us increase, we meet them ideally with adaptive resources to respond, right? We might seek support, we'll seek medical care. But when people have sometimes maladaptive patterns, whether that be maybe they cope with eating, maybe they avoid things, they also might double down on those maladaptive patterns. And I want to say that part of my motivation here is to also kind of engender some empathy that a lot of times what may be kind of frustrating behaviors on behalf of a patient, it may just be them really trying to grapple with the acute stress and the acute illness in this phase. So maybe they're really asking so many questions that we've already answered, but they're really trying to understand. So think of it as it's just kind of their response pattern on steroids, I guess. And then the following domains, I'm kind of addressing these as, in the acute setting as a psychologist, here's the things that we might see, and here's the things we might be addressing most commonly. And I can kind of talk about like how, if someone has anxiety before they kind of approach an acute admission or the transplant and post-transplant recovery, if they have anxiety prior, here's what it might look like at this phase. So obviously, when we're going through the acute phase, they're dealing with more intense somatic issues. So we often can get involved in helping people cope with pain, nausea, fatigue, maybe helping them kind of acknowledge they do have more control over it. They can do some behavioral skills. It can be hard to kind of get them on board at that point, but that is one way we can help. Anxiety in the acute stage is very easily activated. Sometimes it can even begin at this phase. Maybe people weren't anxious before and they just kind of coped with things pretty well, but it just becomes too much to handle. Sometimes we see that. And the worry tends to be about, obviously, what the symptoms are, what's going to happen, worry about the transplant itself. What's it going to be like? Tolerating the unknown is a very typical anxiety symptom that we really try to help people cope with. And there's a lot of specific fears about rejection, medication side effects, right? So the anxiety targets can become very specific with the acute phase. I'll go to the next slide, please, Bill. Thank you. And I did want to mention too, with the anxiety, when we do research studies on different different solid organ transplants, we see sometimes people do have, they can develop panic disorder, can have some panic attacks that begin to become more routine. People also they can have PTSD, right? And we talked a little bit about trauma in the previous presentation, but medical trauma and just living with the chronic illness beforehand and everything they went through can develop this kind of pattern of avoidance, nightmares, and et cetera. So depression in the acute setting, often what we'll see is, especially during the times of COVID, dealing with acute illness and not being able to connect with our social supports, losing routine and sense of time can really exacerbate some of those depressive symptoms. People might kind of withdraw, they have a hard time orienting themselves and getting motivated potentially. So we would work with patients maybe in the hospital or kind of as they're thinking about transitioning back home, how to establish some of the routines, how to engage regularly with their social supports, whether that be virtually if they're in the hospital or how to plan for it after. And I think it's helpful, obviously, to recognize or acknowledge the environmental factors when patients are in the acute care setting, how they contribute to these symptoms as well, right? So if we have a lot of interruptions in sleep, we're not able to have the foods that are comforting or regular control over these things, that can definitely exacerbate the symptoms. And depression is often a much more common condition that we see, whether it reaches a clinically significant level and we would diagnose someone with a depressive disorder or not. But rates can be as high as 20% to 30% based in different transplant populations. And this is after, I'm speaking towards after transplant process, but they're also very high in dealing with the chronic health conditions that require transplant. Next slide, please. This slide kind of deals with how our beliefs and expectations might butt up against dealing with an acute illness. So a lot of times, people experience setbacks. That might be one of the reasons they're dealing with an acute exacerbation. Maybe there's an infection they didn't plan for and they're back in the hospital and it's really upsetting. They made so much progress. How people deal with setbacks and cope with them and bounce back is incredibly predictive of long-term outcomes, both emotional and physical in the transplant population. We use the term self-efficacy quite a bit, which defined as your confidence and your abilities to manage these things. There's a specific type of self-efficacy that we call recovery self-efficacy. So it's your ability to recover from setbacks and how much you believe you can. This is something that is malleable. We can help people increase their confidence. We can highlight, you've done this before, right? We can show them examples of what they did do that is promoting recovery. We don't want to only kind of paint a rosy picture and try to be the cheerleader the whole time. We want to acknowledge the setback and the loss and the emotional difficulty, but we do want to focus on building the confidence. Another challenging belief that we kind of help patients cope with is when the reality of where they are and kind of dealing with an acute exacerbation or even something that they wanted, like when they finally get a transplant, sometimes the reality doesn't meet the expectations. And we often can help patients kind of cope with finding some reality acceptance. We really try to use terms about managing expectations as opposed to lowering. We never want to kind of think about using the more negative terminology in helping people reframe their expectations and plans for the future, but that's one thing. And next slide, please. What about when there can be positive outcomes of dealing with acute illness and exacerbations? As psychologists, we tend to focus on when things aren't going well because we want to help fix, but sometimes good things can come out of challenges. And that was mentioned at the end of the previous presentation about post-traumatic growth. I'll talk about that in a second. You know, we can kind of see these connections with patients when they're dealing with acute illness as an opportunity, right? Sometimes they can have relief from ongoing, very long-term suffering. So that can be a positive outcome. They have a lot of gratitude potentially that is very beneficial for health. And we can kind of foster that and highlight the things they say that are demonstrating gratitude. Also, when we come into contact with patients in acute illness, it's an opportunity to make a change, right? Sometimes we think of these kind of near-death situations as people reflect on what they want to do differently. And we can try to guide things towards a preventative or more adaptive pathway from there. And here on my slide, I have a little bit more information about post-traumatic growth because it is a really unique concept in the mental health field because it is something we can measure. We can give people a questionnaire and see how much they're exhibiting post-traumatic growth. And it really addresses these 5 areas listed here, changing and related to how we relate to others, recognizing new opportunities, appreciation for life, recognizing our strengths, and there's also a lot of spiritual or existential change that come from it. So I think it's great to recognize, you know, I often talk to patients about, we go through a trauma, sometimes we develop some unhelpful coping skills that goes down towards the kind of a PTSD pattern. Other times we experience growth, and that's more of this post-traumatic growth. And I try to kind of provide some education about that. And last slide for me, or 2 more. So how can, in the nursing field, you know, I think you guys have a unique opportunity to really highlight how when patients are naturally demonstrating some of these adaptive things, or you can identify much more quickly than other providers in the acute setting when things might not be going well, right? So looking for the red flags at early stages before maybe depression develops more deeply. So obviously noting changes in behavior, limited participation, maybe patients express regret for having had a transplant, things like that. Those might be reasons to get a psychologist involved or a clinical social worker. But also you can really, like I said, provide the positive feedback. Maybe you heard a patient say, you know, I didn't do great yesterday in PT. Today I did really well. And you can kind of ask more questions about, wow, that's great. It went well today. What went well, right? And really reinforce the positive kind of patterns of talking and acknowledgement that we want to continue. And then I find my last slide. I also wanted to make a note of, you know, I've been seeing a lot of impact that the pandemic is having both on patient distress in acute settings, but also how the unique demand it's placing on staff. And I think it's helpful to recognize that and name it. And, you know, patients are really struggling with the limited visitors. So they're having to kind of find different ways to cope when sometimes they're asking for more support, whether it's explicitly, like I need someone to talk to, or implicitly, and maybe they're calling for more requests, or maybe they're feeling lonely and they want to talk to someone, and it's kind of taking more time to get in and out of patient rooms. There's also a lot more fear, obviously, right? So the anxiety symptoms being uniquely impacted by this. You're contracting the virus when they're immunosuppressed, uncertainty about vaccines. That comes up in our conversations with patients quite a bit about, will it work? You know, what do I do? Kind of, we can help prepare them with what questions to ask their providers. And then obviously the impacts on staff and everyone that's working in these settings. It's incredibly stressful. And I'm glad you guys had the previous talk about kind of dealing with the trauma from that. So that's where I'm going to hand back to Bill.
All right, so one of those last points that Brooke was making is, in terms of the vaccines, I've never seen patients so angry at other people in my whole career as the transplant patients that I see, who are so frustrated with people who are not masking, or don't think there really is a COVID, who refuse to get vaccines because they really feel like their lifestyle is so cramped and we're never going to get back to something like normalcy because of that. So that's the big group of patients I see that is actually the most upset. So we're going to do a segue here to depression. Brooks talked about depression a little bit. It's always helpful to let people have a reminder about what can depression look like? What are these things that the phenomenon that are part of it? To get a diagnosis of depression, you need one of those top 2 that are in blue, the depressed mood or the diminished interest or pleasure, and then you need a total of 5 symptoms overall to get that kind of diagnosis. And generally, at any point in time, close to 7% of US adults are meeting criteria for depression. There are a lot of risk factors for depression. Medical illness is a big one, chronic pain, a lot of the things that you see. Gender and other things, age, younger people and older people tend to have more depression if people going through transitions in terms of relationships and so forth, if they don't have adequate support. There are all kinds of things can affect the risk for people having depression. And we know that with all chronic diseases, there's an increase in depression relative to populations that don't have diseases. It's very common, and it tends to affect things. When people are having an illness, it tends to trigger depression. If people are depressed, they're also at greater risk for an exacerbation of an illness, of its impact on the illness. So it really is important, and we'll be talking about that in the next series of slides. Depression in transplants, there's variability in terms of the estimates about what percentage of patients with transplants are depressed, but there isn't any question that it is a group that's at higher risk. They have more distress, they have more anxiety, more depression, and in some cases more substance abuse than non-clinical populations. And so I think I missed a slide there. There we go. The work that I've done has been with many different types of transplants, but probably the most has been with kidney transplants. And as you can see, at least a quarter of transplant patients that get screened for being depressed. And it can be moderate, it can be severe. And the work that we've done is often just mild, but it's affecting their experience, their behavior, the impact of any treatment that we give to them and so forth. You can see that with kidney transplants, it's about 20%. It's even higher in liver and in heart transplants. And in some studies, it looks like it's more that first year after transplant. In one study that we did recently, we found that depression went down from being on the transplant list to actually after getting a transplant. If you look at Medicare claims, those first few years after transplant, you can actually see an increase here over time from about 5% to 9%, looking at about 50,000 kidney transplants. And I think what's critical for your group to recognize is, it's not all done once the transplant's done, once they're out of the hospital, but some of the stressors just really grow over time, like dealing with side effects and dealing with other complications. And so we really have to be kind of mindful of this and be looking at it long term. One of the reasons that, we as mental health professionals, we're more concerned about the person's sort of mental well-being, but it's more than that. It's also affecting their risk of all kinds of complications, losing a graft failure, returning to dialysis, and so forth, all go up. Death goes up. And so when you look at depression and illness, what are the connections? Depression, people who are depressed report being more in pain. They report being more fatigued. There's more disruption of their life. And more critically, they may not be taking as good care of themselves. So this can affect the work that we need to do with them to make sure that they continue to take as good care of themselves as possible. It can affect their health risks, how it affects their immune function, premature mortality. In some cases, dosing requirements of antidepressants as you get interactions among drugs. So there is a lot to be aware of. One of the things that we know about transplant patients is they're told from the beginning, you're going to have to take your medicine every day. And many people do. Thou shalt take thine medication. But what we also know is that adherence, which is an area that Tom Nevins and I have spent many years looking at, is a huge problem in healthcare and especially in transplant patients. As the former Surgeon General, C. Everett Koop said, drugs don't work in patients who don't take them. And you don't have to be doing the work that you do in transplant very long to be surprised that not all of our patients are doing what we ask them to do. They're not all taking their immunosuppressants. They may give themselves holidays, possibly they don't like the side effects, or there can be all kinds of reasons why people don't do it. In general, we know that about 25% of people do not adhere well to medical regimens. And Mary Amanda did a nice meta-analysis a number of years ago where they were estimating across studies what is the non-adherence rate for medications. And so kidney transplants, about a third, more than a third. Heart transplants, a lower percentage. Liver transplants is sort of interesting. I was surprised by that because I think sometimes we think about people with liver transplants maybe having some more non-compliance or health-related behavior issues earlier on, like substance use. But you can see that really all of our transplant patients may have issues of non-adherence. So this is basically the final slide. What are our thoughts about, what's our elevator speech about psychology and transplant? Well, first of all, transplant patients have a lot going on and a lot to adjust to. It's not just the medical stuff. And they are at risk for all kinds of mental health issues. And so it's really important that as teams, we be checking in with people, not just once or twice, but the depression can come on at any time, or a new source of anxiety, like with COVID. Suddenly there's a source of anxiety that our patients did not used to have. They might have been concerned about getting the flu, but now it's a whole different ballgame. And it's unfortunately in the area, in the direction of increased level of intensity. We all as health professionals need to cultivate within our patients a sense of their own resilience. They have had a rough go of things by the time we start seeing them. And our job in part is to help them to bounce back from that. David Hottinger's speech talk just before us was really great in terms of looking at the traumas, but traumas doesn't mean that people have to be in pain, don't have to be suffering in an ongoing way. We have to find some way of making room in their own heads and hearts and lives about how do I have a good life despite these challenges that I have. I feel like I always have to put in this pitch about adherence. Please, please, please speak to your patients about, are they taking their medicine? Are they doing the other things that they need to? If they're missing appointments, chase them down. We really need them to be getting good care and have some roles to play in doing this. So I'm going to deputize all of you into being psychologists and social workers to be making sure that that happens. You can't presume that just because you've told them that they need to take their immunosuppressants that they are doing it. You need to kind of find ways of checking with them about how well they're doing it. And also consider team-based approaches. I mean, this is not solo practice. We're functioning as a team. And so whereas you guys see these patients day in and day out, we love to work with you and with the patients as mental health professionals to address the psychological and behavioral issues that can ultimately lead to better outcomes, not just in those mental health ways, but also in the physical ways. So I know that we just shared a lot of information. Sorry, there were so many slides. I hope you had your glasses on and that you had your coffee beforehand. I don't know how close we are to the break in your day, but we just want to spend a few minutes opening it up for questions that people might have, or responses, additional thoughts. And I'm going to stop sharing the screen at this time.
Thank you so much, Dr. Rockner and Dr. Palmer. Really appreciate hearing from you. Does anyone have any questions? Feel free to unmute or put them in the chat. I'm not seeing any right away, but if anyone has questions kind of as we move forward, I will definitely get them to you via email and communicate a response back. Thank you so much both for being willing to speak with us today.
Thank you.
Thanks for having us.
Thank you. Have a great day. We are moving into our lunch break at this point. So we are scheduled to go until about 12:15. So I think we'll keep on that schedule. And if everyone could return at about 12:15 after lunch, that would be great. And we will jump right back into it. Thank you so much.
All right.
Hi, everyone. Welcome back. I hope everyone had a good lunch. We're at about 12:14. We'll get started here in just a minute. Dr. Heimbach, I see you. Thank you for joining us. And Jaleesa, I think, has also joined us. And Linda is going to introduce you both. Hi, thank you. Nice to see you.
Hello there, this is Linda Kazmerzak, and I'll be introducing our next two speakers. Jaleesa Gibson is a 19-year-old from Pennsylvania. She's a college student at Mankato State. She'll be sharing her story about COVID-19 and her liver transplant journey. And then also we'll have Dr. Heimbach speak after her. And Dr. Julie Heimbach is a professor of surgery and the director of the William von Liebig Center for Transplantation at Mayo Clinic in Rochester, Minnesota. She's an abdominal transplant surgeon who is focused on living donor liver transplantation and liver transplantation for hilar cholangiocarcinoma. Dr. Heimbach has also been very active in organ allocation policy development at the national level, having recently served as the chair of the OPTN UNOS Liver Committee. She has also served on the board of American Society of Transplant Surgeons and the governing board of the AASLD. In addition, Dr. Heimbach serves as an associate editor of American Journal of Transplantation and the Journal of Hepatology. So I'm hoping Jaleesa, oh, she is there. Looks like she is ready to go. Jaleesa, go ahead.
Oops, sorry, I was on mute. I'm trying to share my screen. 1 second.
I just made you a co-host, so maybe that'll help with screen sharing a little bit.
Okay, let me see. I'm actually trying to open. Maybe I should have did this before. Let me see. I'm looking for my PowerPoint. I can't seem to find it. Does anyone know how to get to the PowerPoint?
Do you have it open already?
So I have it like near my downloads, but
It's usually easiest to open it before you share your screen because you can find it easier. So I would open it up and then do share screen and you should be able to find it.
yeah, that's what I was trying to do, but 1 second. It's picking it harder than I thought it would be. I have it open, but
So do you see the share screen button that'll be along the bottom of your computer?
yeah,
probably?
yeah.
Okay. Click that.
Yeah, click that.
And then another window should open up and you should be able to see your PowerPoint there in one of those squares and then click that.
It's not letting, I don't see it popping up. Yeah, I'm having some difficulty. I just see desktop, whiteboard, iPhone, mail, and mail. I don't see any.
Yeah. So do you don't have do you have the PowerPoint completely opened up, ready to run?
Yeah. I don't, let me see this.
If you open it up, it should be on there. I don't know. Do you have tabs across the top of the like the sharing tray, the window that opens up when you hit share screen? Are there tabs across the top of it?
I see Dropbox, Microsoft OneDrive, Google Drive, and Box. I don't see any of the files. like my PowerPoint.
Okay,
I can go first, and that would give you a little more time to work on it. I don't know how to advise you to find it.
I'm struggling a little bit too, but Jaleesa, maybe I will send you a
So,
message the last time.
Christine, I
Yeah.
have a suggestion. So that what she just quoted is under files.
Yeah.
So at the top, it should say basic, advanced, and files. Pick basic.
Yes.
Okay, basic, and then what do I do after that?
Then you should be able to see your PowerPoint in a whole bunch of different screens. You might have to scroll down a little bit to find it, but you should be able to see your PowerPoint there. You see?
No, I don't see it.
Don't see it?
How do I get it to appear there?
If you have it open, it should appear there.
Yeah.
Do you want to send me your PowerPoint?
Yeah, that's what I was gonna do. Yeah.
And I can pull it up and share my screen.
Yeah.
Okay, sounds good. It's I'll put my email address in the chat for you, okay?
Okay.
Okay. Dr. Heimbach, while we're getting that worked out, do you want to share your screen and get started? Is that okay? If we switch things up a little bit?
Yeah.
It's okay with me if that is what is preferred. I'm happy to do that.
Jaleesa, is that okay with you?
That's fine, yes.
Okay, thank you. Yep, go ahead. Thank you.
Okay, folks, I hope that you can hear me okay. I'm here to speak to you as Linda asked me to just kind of cover the issues that arose with this challenging case, which was liver transplant. I'm just going to try to move this little Zoom thing, so it's really annoying me. Here we go. Okay, so liver transplant and how that could relate to the situation of COVID-19. So that's the topic that Jaleesa is far more interesting than me, so I hope we're going to spend most of the time talking to her, but I'll just kind of give you a little bit of background here to this. So this basically is, we had a patient, Jaleesa, who you'll speak to, 18-year-old female who was transferred to us from an outside hospital after having experienced a 3-day history of being unwell with symptoms, including here, fever, nausea, vomiting, epigastric pain, shortness of breath, and she was exposed to SARS-CoV-2. I'm sorry, we've got some sort of auto advancement going on here. Vital signs, you can see there, respiratory rate was elevated, heart rate and blood pressure okay, but she was having a low saturation at 80% on room air. ABG markedly abnormal with hypoxia, as you can see there, a PO2 of 39 and a gas of 7.17. Her initial labs did demonstrate that she did have the COVID virus. She also had a very profound coagulopathy. Sorry about this. And hyperbilirubinemia, hemolysis with a hemoglobin at 4.6, which is quite abnormal, elevated creatinine at 7.8. She was imaged actually as she was coming in through the emergency department, which did show, as you can see, no consolidation in her lungs. Her liver actually appeared quite normal on her CT. She had splenomegaly and mild changes there. That was an ultrasound of her liver did show that it was some hypogenicity. These are the laboratory studies, and I'm just, there's a pretty busy slide here, but the things to really pay attention to is her coagulopathy. At the time she presented with an INR of nearly 7, bilirubin, quite jaundiced at 12. And then you can see her creatinine, as mentioned, at 7.4. And then interestingly, also with really much more elevated AST than ALT, which can give us some clue, already showing a very high lactate. So overall, just extremely concerning labs. And this just outlines her course, really. I'll just kind of walk through this. This is when she was admitted to us. And she initiated dialysis, renal replacement therapy on day 4. She did get convalescent plasma for treatment of her COVID on day 5. Also on day 6, she had, as mentioned, the previous profound anemia, very, very low hemoglobin. So to further evaluate this, she did undergo a bone marrow biopsy. She also started continuous renal replacement therapy at this time. And then, whoops, sorry about that. She had a bone marrow biopsy, as I mentioned, continuous renal replacement therapy. And she was intubated on day 14 due to progression. And finally, on day 16, we did make the determination to list her for transplant, although you can see on the bottom here, day 3, day 7, day 11, day 13, day 14, day 15, still positive for COVID. So this is a really difficult decision to understand what to do in the setting of continued COVID positivity in someone with acute liver failure and how we should proceed. We ultimately did proceed to liver transplant with prednisone, basiliximab, and remdesivir, which is an antiviral. She did not begin her tacrolimus until day 21. She also did receive induction, although it was delayed. She was ultimately extubated on day 27, came to the regular non-ICU ward after that. And mycophenolate was finally initiated. So we normally would have used this earlier, but we held it due to her COVID-19. She did ultimately come off of dialysis as well. And you can see how this overlays with her diagnosis. And we're just going to talk a little bit more about her ultimate diagnosis, which turned out to be fulminant liver failure, which is acute liver failure from an underlying condition called Wilson's disease. This is an autosomal recessive disease of copper metabolism. Normally the copper is absorbed and excreted in the bile, but this doesn't happen normally in this condition. So the incidence worldwide is 1 in 30,000. The hepatic manifestations, as you can see there, and especially steatosis, rarely, so 5% of patients with Wilson's disease do get acute hepatitis and acute liver failure. So that's just really not a common presentation, but it can be precipitated by a severe, infection. In this case, likely severe COVID infection precipitated this crisis, Wilsonian crisis. And then chronic hepatitis and cirrhosis, more common manifestations for people that do not have treated Wilson's. Presenting laboratory studies were typical of Wilson's, actually. And the treatment, if we had known about this, there would have been a different potential option, but doesn't necessarily mean that ultimately the outcome would not have been the same, but could have had some possibility of treating it, but it's typically not diagnosed unless it's known. If someone has acute liver failure, there's no other option for treatment other than transplant. So the challenge is really accurate diagnosis in the setting of liver disease. It appeared that it was a possible Wilson's, but the biopsy was not possible because of the severity of her liver disease. A quantitative copper could have confirmed the diagnosis, but this was not possible because she was anuric. The confirmatory genetic test takes weeks. We thought it was potentially SARS COVID hepatitis instead, but we really couldn't be sure. So that's a major challenge for this case. Another major challenge was there was an unknown outcome of transplant in the setting of a patient who still had persistent SARS positivity. Also, she's critically ill with an INR that at one point rose to more than 20. She was on CBVH. Her Glasgow Coma scale was 3. She also had some posturing, and her head CT showed some concern for some edema. And she, of course, required the ventilator with lung injury. And unfortunately, we had restrictions for visitors. So all of these conversations about transplant had to happen with Jaleesa's mother on the phone. We weren't actually even able to meet with her to speak about this. So it was really hugely challenging for her to understand the critically illness of her daughter and what it meant for COVID. We also had a huge challenge with the OPO miscommunication. They had sort of allocated us the liver, but then they realized that they had to go with the intestine. So then they had to take it back, and it was really craziness. We had to directly plead to the other program, Vanderbilt, who actually did allow us to proceed. So that was really great. We also had a question about whether our patient should remain in the COVID unit post-transplant or move to the ICU where the transplant patients were normally cared for. So these were all of the challenges plus so many others that we were facing in this case. So you can see a lot of uncertainty. You know, what went well in this case, the Vanderbilt team allowing the liver to be allocated when our patient was very critically ill, and we really just had a tiny window of transplant, which happens in fulminant hepatic failure. We had this partnership with our infectious disease team. So even though they did not have all the information they needed, they were able to be making definitive recommendations and give us the authorization for remdesivir, which is amazing. We had a critical care team that was really supportive, and I really actually don't have everybody that was critical on this team, but in the transplant unit, we had nephrology who actually gave up MARS as well as CVVH. We had neurology who came every day. Of course, we had the most amazing nurses, both in the unit and on the ward, and physical therapy. So a lot of team members were super critical, dietitians, our hepatologists, all of these people. We had an anesthesiologist that really provided a very smooth and unremarkable intraoperative course, so that allowed really excellent. We did modify the immunosuppression, as I've already noted, and these modifications, of course, we just sort of guessed because we had no experience with what to do. It turned out that this would be, I think, the right way to do it. We also didn't know, you know, if the patient should be in the COVID unit. Luckily, I think it was really in her best interest to stay where she should have been, in the transplant unit, and everybody accommodated that. So I think it was really great. So the key points to wrap up with: the current guidelines recommend deferring liver transplant in patients with severe acute respiratory, so basically COVID, until the clinical improvement occurs and you have 2 negative tests 24 hours apart. Obviously, we didn't meet that recommendation and we still proceeded. But I think this case really does highlight that COVID-19 with continued positivity of the virus may in fact not actually be an absolute contraindication for transplant in acute liver failure. And I think finally really highlights the value very highly of teamwork, where in this case, I think the team made what really looks on the surface to be actually impossible to be possible. So thanks. That's the background of the case. And I think hopefully you'll be able to hear from Jaleesa now, who has a much more interesting story to say than this. So thanks. I'm going to stop sharing my screen. I'm certainly happy to answer any questions, but hopefully we got the technology for Jaleesa to be able to give her side.
We are still working on it. Jaleesa, I'm trying to open your file. Do you want to start talking through as I'm trying to get it opened? It's asking when you're sending it, I'm getting a link instead of the actual presentation. I haven't been able to open it. So I just sent a screenshot of, I don't know if it looks the same on your computer, but of how I have to attach things and you're sharing your screen.
Yeah, I think I figured it out.
Awesome. Okay, perfect. That looks great.
All right.
Yeah, if you want to start your slideshow, it looks great.
It finally popped up. It wasn't there at first. It was blank.
It looks great.
Okay, you guys can see, right?
Yes, you can. Thank you.
Okay. So I'm going to start. Okay, it says track athlete gets COVID cause that leads to liver transplant. Okay, I guess I gotta click it. Okay. Background about me. I'm from Bristol, Pennsylvania. I was majoring in business management and a minor entrepreneurship. I run track and field. I'm a sprinter. I played field hockey in high school and flag football. I have 4 brothers and 4 sisters. I have a new dog. His name's Picasso. He's a mini golden doodle. I love painting and shopping. My favorite food is mac and cheese and I've been in a relationship with my boyfriend for 5+ years. Why did I decide to come to MSU? I got offered an in-state tuition track and field scholarship. I was looking forward to change and to be independent. I wanted to become a well-known college athlete and set records. I like the fact that you could be in a learning community. 2 months into my freshman year, the workouts were starting to affect my body negatively, with it being hard to breathe and like recover from most of it was like hip injuries. I would go to the trainer and like try to see what was wrong with me, and I would be so tired and I couldn't like get through the workout at all. And then like plus with having schoolwork and stuff, it was just making me tired, and I was just laying in bed, not doing homework like I usually did. So it was just kind of awkward. And then I would have like severe stomach pain during practice. I wouldn't eat or anything, and then I would be sweating in my sleep. I didn't have an appetite to eat. I got continuous migraines. I was very fatigued, couldn't get out of bed, vomiting and continuous bowel movements. And I experienced these symptoms for about a week and a half. I thought I could recover because I was like really healthy, but it was just my liver like that had the disease or whatever. So I thought I could recover from COVID like my other teammates did, but it wasn't the same thing. And then as a result, it was COVID-19. So October 30th, 2020, I called 911 and told them what I was experiencing, because I was like, couldn't get out of bed, couldn't shower or nothing. And it was just getting scary. And I didn't tell my parents or nothing. So they didn't, because I was just scared. Like they knew I was like not eating and stuff, but they didn't know how like bad it was. So when I called 911, they came as soon as possible. They thought I could like walk down the stairs and like come out there, but they had to bring a stretcher up because I couldn't walk at all. And like when I did try to walk, I was like fatigued and like really dizzy. And then they checked all my vitals and saw that my oxygen was not 100%. And first they were like, thought I was fine. And I was like, no, like this, I don't feel like myself. And then they did another scan again. And then that's when they saw my oxygen was not 100. So they took me to the emergency room in Mankato. My test came back that I had COVID-19 and severe organ failure, was my kidneys and my liver. And then I got rushed to St. Mary's Hospital in Rochester in a helicopter. That's the last thing I can remember, because I remember they put the headphones on my ears and they were like, just stay with me, Ms. Gibson, just stay with me. And like they wanted me to just stay awake. And then I guess they called my mom and updated her and the rest of my family, but she was so scared because she was all the way in Bristol, Pennsylvania. So that was like, I was sad because I couldn't tell her like what I was going through, because I was scared myself and I didn't know how to go about it. So that's the last option I had was just to call 911. And then what happened next? I had to get on a breathing tube and feeding tube as soon as possible because I was using too much of my energy. And Dr. Heimbach had said that I was actually like functioning on a high level, even though like I had this stuff was going on in my body, because I was still going to practice every day and everything. Like it was normal, but I was just doing it and like fighting it just to get better. So then they told me that I was induced in a coma and didn't know anything. And I didn't know anything that was going on. And then when my mom came to Minnesota, I actually remember because I could still hear. And she wasn't allowed to come see me because of COVID regulations, but eventually she got the chance to see me for a few hours. And she had like a head neck suit on or whatever. She told me she was like trying to do my hair and stuff. And then they tried to do liver and kidney dialysis to get my organs to function again, but the liver didn't work. The kidney did work eventually, like the dialysis. And then I had to get a catheter for my waist. And then my kidneys recovered and eventually started working again, like I just said. Liver dialysis didn't work. It was still eating my insides. I got diagnosed with liver disease, the Wilson disease that Dr. Heimbach talked about. And then my family had eventually come to a decision of getting a liver transplant because my liver was not functioning still from the dialysis. The list. The doctors had to make the tough decision to do a liver transplant with the spreadable sickness, COVID. I got put on a list for a liver transplant. Within a few hours, they found a match for my liver. A 49-year-old woman that was brain dead from a car accident. November 14, 2020 was the day of my surgery, and it was said that the liver fit perfectly and was working properly to keep me alive. My family was so amazed and thankful that I could be giving another chance at life. My mom got to talk to me once I woke up, and she was so happy. I still remember that day when she actually got to be on FaceTime and the doctors were like holding my head up because I was like so weak because I lost all my muscle. And then that's when I realized I was on so much medication. They had to like give it to me through the feeding tube or whatever, like as liquid. And it was just so nasty. And then I had to get insulin, check my sugar levels. and had to do like daily treatments to keep clean bacteria out of my chest. And I couldn't eat or drink anything, was still on a feeding tube. The doctor started to notice severe muscle loss. So I got a muscle biopsy, and I was diagnosed with muscle, I don't know how to pronounce that. Doctor, make my hat, and I it was caused from a lack of physical activity that made it difficult for me to move an arm or a leg. Because mind you, I was an athlete doing track every day and just staying in shape. And then once I was in the bed for a while, I wasn't moving no muscles or nothing. So I lost all my muscle mass. And then here was the muscle biopsy. I don't know if you guys can see it in the camera, but yeah. So after that, my recovery from my transplant, I would have physical therapy twice a day. The nurses did everything for me. I love my nurses. They were so nice. I had to learn how to walk again, feed myself, do my hair, brush my teeth, hold my phone, all the day-to-day activities all over again. It was really upsetting. I couldn't believe I couldn't walk. That was like the scariest thing ever. I was just like, what? Like what even happened? And when I noticed my scar, I don't remember noticing it. Like I feel like it would just like automatically happen. But I was just so sad and upset. And they did different exercises to strengthen certain muscles each time. And I progressed every week, and I was just trying to like get out of there. Like I was just tired of being in there. It was so long, like a long 2 months. And then my mental health in the hospital. So I was in the hospital for almost 2 months, like I mentioned. I missed my family because they weren't allowed to visit me and help me recover faster. But I was still strong and just was like, I'll be out here soon. The more I progress every day. I was just very sad, and I thought I wouldn't be able to walk again. I eventually got to have my phone back, and I had a million missed calls and messages because I wasn't on my phone for an entire month. I would FaceTime my family, my friends, my boyfriend throughout the day because they made me happier when I heard their voice. The doctors and nurses would tell me that I would be going home soon, and I would get my hopes up, but it wasn't true. They were just doing that to make me like feel better. And I would just cry to my mom because I just felt lonely, but the nurses always tried to keep me company. My family would send me care packages of things I loved, such as cozy pajamas, socks, hair products, lotions, teddy bear, and snacks, and which made me happier. I was just so insecure about my body because of my scar. My body just didn't look healthy as the way I looked before. Because it was the first time I actually got to look in the mirror at myself, and it just felt like a whole different person because my face was like bloated, and then like I was just like really skinny. Then I was like 120 something pounds, and I eventually was like 160. So I lost like a lot of pounds from the COVID. And then my face was also breaking out. Like I had a lot of pimples and, acne from, I guess, the medication and what all my body went through. So I didn't want to go home because of the way I looked. I thought people would look at me different. I was upset that I had to take so many medications. It was 15 medications when before all I had to do was take my vitamins. Post-transplant recovery, my future plans. I went home January 7th, which I was in there since October 30th. Then I finished therapy at NovaCare in March. That made me so much more stronger. And my day-to-day activities are at 95%. I can do my hair myself. I can shower, brush my teeth, walking, eating, driving, etc. 46 months after transplant, I experienced very bad hair loss. That was very upsetting. But as October 2021, my hair has grown back because I had like no hair here at all. Like it was all gone. And I was just like crying in the shower because like I had got braids in my hair, and I took my braids out, and then it was all my hair just coming out in like globs. And I'm just like, oh my God, what is going on? So I texted my nurse, and she told me, yeah, the first 4 to 6 months of transplant, you usually have bad hair loss. And I was like, okay. And then in April, I bought my new puppy, Picasso. He's right here, actually. I don't know if you guys can see him. Look, guys. I bought him. And I actually registered him as an emotional support animal. So I take him everywhere, like to the grocery store, the mall, everywhere. He just made me feel so much better emotionally. And I still continue to be on the steroid prednisone to prevent rejection, but it made me gain weight faster, in which I didn't like it because now I'm like so big, but I work out now with my coach. I work out with my coach 3 times a week, and he's helping me get back in shape and like back to running again. And I actually run. It's crazy. I never thought I would be able to run again. Like I actually do my workouts, and he's just so happy for me. And I bought a new car actually August 26th. And I only take six different types of medications now, including my 2 vitamins, which is so awesome. And then I'm back in school online at MSU and practicing with my high school coach, like I said, 3 times a week, running and lifting weights. And I actually been lifting weights since like May, because at first I only could lift like 10 pounds, and now I'm like lifting about 100 something pounds. So it's actually progress, a lot of progress. And I plan on getting my business bachelor's degree and going to a trade school to get my college cosmetology license, because I actually want to do hair too. But here is me and my dog Picasso. He's a mini golden doodle. And then here's some pictures. That's Lindsay, and I actually forget her name. My other nurse next to me in this picture. I think Megan.
That's Maddie.
Oh, Maddie. I know what an M. But yeah, Maddie. This is me on the left with my pink shorts before I took a photo shoot for track. And then this is when I was in the hospital, able to actually sit on the edge of the bed. I couldn't even do that. I was just in bed, and I was so happy when I got to take that picture. I sent it to all my family. Here's the picture of my mom and my dad when I was signing to MSU for the track. But yeah, that's me. Anybody have any questions about my experience with liver transplant and COVID?
Lisa, thank you so much for sharing your story. Really appreciate it. I love your puppy. I've been bugging my own family to get a dog now for about 2 years.
Yeah. He's actually asleep. I will come up now.
Oh.
Hi, Dink. Say hi, Picasso. Tired.
A cute puppy. Thank you so much for sharing.
You're welcome.
I'm seeing a lot of comments just saying thank you for sharing. So we really appreciate hearing your story, and people are saying really glad you're doing well and what an amazing experience. And I think, I don't know, I don't want to speak for everybody, but you know, it really is so, it's so emotional to hear about, you know, the other side of what you do. You know, we're all transplant nurses, we all take care of transplant patients, and it's so, so nice to hear about it from the patient's perspective, and it really puts into perspective what we're doing. So thank you. Dr. Heimbach, thank you also for speaking. We really appreciate it. I see you took yourself off mute. Do you have anything to say?
Well, I just do actually have a question for Jaleesa. You know, that was amazing, and I really appreciate you telling that story, and I'm so happy to hear that you're running. It's awesome. You know, one of the things when we do liver transplant for most patients, we're able to speak to them about the surgery and, you know, before the surgery. And in this case, I wasn't really able to talk to you about the surgery, and you just woke up and you had a new liver. And, you know, I'm sure that must have been really kind of a shock. And I don't know if there's anything that we could have done differently to help you with that shock, or maybe it sounds like maybe the muscle weakness was a bigger shock for you to manage than the liver, is what I'm hearing from you. But still, I'm just wondering if there's any other way we could help our patients who are like you, who get acute liver failure. There's no warning, all of a sudden they're in liver failure. If there's anything we could do when you wake up to help you better than we did, maybe.
I mean, I feel like you guys honestly did a good job, because I can't even remember when I actually wanted to look at my stomach. Like, I just remember you guys saying like I got a liver transplant and stuff, but like I guess my mind was still like in a daze, I guess, from all the medicine and stuff. So when I actually looked at it, I'm just like, wow, this actually kept me alive. So I looked at it as like a positive. Now that's like a warrior scar for me.
Great. Thanks.
That is awesome. Wear that scar proudly.
What did you say?
I said, that's awesome. Wear that scar proudly.
You guys want to actually see it? It's actually healing really good.
Yeah, I want to see it. Definitely.
Let's see that. And I look way different than I was in the hospital. I look so much more bigger. So I don't know if you can see it.
Yeah, that looks really good. I can see it.
Oh, you can see it? I can't see it in my camera because it's like dark.
Oh yeah, it looks good. Great.
Yeah, it's healing really good. So I'm happy about that. Because at first when it was healing, I was actually kind of like disgusted because it was still open and stuff and healing. But now it's like all closed up and looks nice and well taken care of.
That looks great. Thank you both. Really appreciate it. Thank you for joining us. If anyone has any questions, I will get them to you via email and then communicate back. I don't see any questions coming up now, but thank you both for your time and for sharing with us.
You're welcome. Have a nice day, guys.
Yeah, great to see you, Jaleesa. Bye, everybody.
Thank you.
Bye.
Hi, everyone. I'm going to introduce our next speaker, Louise Berry. Louise trained at St. Bartholomew's Hospital and the City University in London, England. She is a state certified midwife, although she is currently inactive, and that training was through Princess Anne Hospital in Southampton, England. Louise emigrated to the United States in 1984 and has worked at the University of Minnesota since 1987. She started in the SICU, mostly taking care of transplant patients. She worked on the abdominal transplant floor before accepting a position as a kidney pancreas coordinator. And then she moved into the auto and allo islet worlds in 2009. Louise developed the care coordination role for the auto islet patient population, and she has spoken internationally at several conferences and organized the last 2 nursing symposiums at the International Pancreas and Islet Cell Association, IPITA conferences. So please join me in welcoming Louise.
Thank you, Allison. I've already run this through with Christine. Can you guys all see my screen?
Not quite yet.
Oh, well, let's see. Let me know when you can see it, because I thought I had it up. Nothing yet?
You got to share screen? Oh, it's
Oh,
coming.
it's coming.
There it
There we
is.
go.
Got it?
Yep.
All right. Well, thank you for that introduction, Alison. I'm not so sure I can follow that last presentation. That still has me a little choked up. It's a testament to why we all do what we do. So thank you so much for that. And thank you for inviting me to speak. It's a real honor to join all the distinguished people speaking today. My talk was titled Updates on the Auto Islets presentation, but it's really sort of more of an overview with some updates thrown in there. So if anybody wants to unmute themselves and interrupt me while I'm talking, please do, because I know sometimes it's hard to remember questions, and I'm going to throw quite a lot of information at you. So today I'm going to talk to you on total pancreatectomy and islet auto transplant. If I can advance my screen. Okay, so hang on, let me go back. So my outline for this is, I'm going to give you a brief history of islet auto transplantation, an overview of the types of pancreatitis, evaluation and testing for total pancreatectomy, selection criteria, surgery. I'll skip over a little bit of the inpatient care, outpatient care, some case studies. That's where it gets very interesting. Discussion on the outcomes, and then some of the research that we're currently doing. So what is a total pancreatectomy? I've lost something here. The main goal of a total pancreatectomy is pain relief. So total pancreatectomy is removing a pancreas for pain relief. The islet auto transplant is done to try and prevent the inevitable post-pancreatectomy diabetes. And I'm sure all of you know this, but an islet cell is the insulin-producing cell in the pancreas. So I'm going to keep going back to this. The main goal of this surgery, this procedure, is pain relief. So a little bit about the history of this. This is a very interesting slide. The first total pancreatectomy islet auto transplant was done at the University of Minnesota in 1997 by Dr. David Sutherland. And how it came about was he was absolutely passionate in his search for a cure for diabetes. And it included his interest in beta cell transplantation. he had a high failure rate for allo islet cell transplantation. And what he was trying to do is figure out why. So he chose to auto transplant the islet cells of a patient who was undergoing a total pancreatectomy into her liver, and they survived and produced insulin. This, to Dr. Sutherland, proved that the procedure for engrafting the cells into the liver was possible. And then he continued to work on the anti-rejection side for his allo islet patients. That first patient, by the way, died with fully functioning islet cells, and she died falling off a horse. She did not die from anything related to the procedure. So anyway, his work led to the total pancreatectomy islet auto transplant at the University of Minnesota, and it was actually a byproduct of his immunology research. So number of cases at the university, as you can see, we peaked in our cases around 2013. The pediatric cases have gone down a little bit, and you can see we're dropping. This is mostly due to this. There's a lot more centers around the country now doing islet auto transplants. Last time I counted, there were 23 institutions, 15 active centers. To me, I would say there are 3 who do the volume that I think is enough to create a good program. To date, we think this is a little out of date, that 1,600 total islet auto transplants have been done, and it is still a pretty rare procedure. So this is just a quick slide showing you some of the places around the country where islet auto transplants are done. This slide shows you where our patients come from. This is a little bit out of date, but we now have, I think, 4 patients from Israel, 3 from Turkey. The Canadian ones are mostly pediatric patients, 2 from Ireland. Right now, we seem to get a ton of patients from Colorado. I think once they figure out we can do this, they refer a lot of their patients. So let's go look a little bit at the types and causes of pancreatitis, because obviously pancreatitis is what leads to an islet auto transplant. 2 main forms of pancreatitis are acute and chronic. So idiopathic forms are, we have no idea why somebody got pancreatitis. Pancreatic devesum, that's when you get impeded drainage of the pancreas, and you can get inflammation from that. Hereditary pancreatitis, I put the names of the most causative genes. There are probably others out there yet to be identified. Iatrogenic is when the pancreatitis has been caused by a procedure such as an ERCP. Medications, obviously alcohol. Alcohol is not always a causative factor. Just because you drink doesn't mean to say you're going to get pancreatitis, but it sure doesn't help if you've got pancreatitis to continue drinking. Smoking is now thought to be a significant risk factor for pancreatitis, toxic exposures. And then there's I think virtually every drug out there has a warning on it that it could cause pancreatitis. Steroids in particular, and interestingly enough, COVID and COVID vaccines. Now, this is anecdotal from my personal experience. I have 2 patients who had stable pancreatitis who got COVID and rip-roaring pancreatitis after it. I also have 2 patients who developed pancreatitis after getting COVID vaccines. So step-up treatment for pancreatitis. We do not just take out somebody's pancreas if they have pancreatitis. We start with medical therapy. If that doesn't work, then we move to endoscopic therapy. And then finally, we start looking at surgical procedures. And there are several different surgical procedures, which I will get to. So medical therapy, again, we ask all patients to stop smoking, to stop all alcohol. A lot of times, pancreatitis can be treated with just pain medication, IV fluids, and bowel rest. So some of our, I hate to call them frequent flyers, but we have set up standing infusion room orders so that if they get a flare-up, they can call an infusion room, go in, get a couple of liters of fluid, maybe 1 dose of IV pain meds and 1 dose of IV antiemetics, and that will prevent a major flare-up and keep them out of the ED and keep them out of the hospital. If that fails, endoscopic therapy is a second line. So ERCPs with stone removal, endoscopic ultrasounds with or without pancreatic function tests. I think those of you who know about pancreas transplants know that the pancreas secretes a lot of bicarb. If you do pancreatic function tests and the bicarb is decreased, that's usually an indication that there's significant pancreatic damage. Pancreatic stents, sphincterotomies, biliary stents, most of these procedures are aimed at unblocking the pancreatic duct so that it drains freely. Then finally, if all of these fail, we start looking at surgical procedures. And as you can see, total pancreatectomy, islet autotransplant is the last on the list. So there's something called a Fry procedure. That's when the pancreatic duct is opened up and attached to a piece of small intestine. Again, the aim is to get that draining into the intestine and not blocking up. A Whipple procedure, that's specific to removing the pancreas head. Then the distal pancreatectomy, that's the tail of the pancreas with or without islets. So this is significant because most of the islets are concentrated in the tail of the pancreas. Then total pancreatectomy without islet transplantation. Obviously, this is only done for somebody who is completely diabetic, who's already diabetic with no C-peptide production. And then finally, we look at total pancreatectomy with islet autotransplant if either of the lesser surgeries are not applicable. So these two slides here is a very graphic, very simplistic before and after picture of what we do. You can see that the pancreas is removed, the duodenum is removed, the gallbladder is usually removed if it's still there. The spleen is removed. Back in the early days, they would try and do spleen saving surgeries, but the spleen and the pancreas sort of share a blood supply, which is often so fibrosed and inflamed that if you try and take the pancreas out without the spleen, oftentimes these patients would end up back in the OR with bleeding later. So now we electively take the spleen out. I will go back to this picture later. So how do we determine if somebody is actually eligible for this surgery? So endoscopic ultrasounds, again, with pancreatic function tests, looking at pancreas function, MRIs to look at the pancreas, endoscopic ERCPs, abdominal CTs will show calcifications or possible atrophy of the pancreas. And then we look at mixed meal metabolic testing. And with this, we're looking at islet cell function. Do we get a positive C-peptide response to a mixed meal test? And C-peptide is kind of also indicates insulin production. So sometimes we'll look at that and we can say definitely from that, they have significant islet cell damage if they're already impaired testing. If it looks normal, we still can't say that we're going to get a good islet cell yield. You actually cannot predict that until you actually take the pancreas out. We also look at some predictors, GAD, islet cell antibody, insulin antibodies. If any of these are positive, it suggests that the patient is potentially going to develop type 1 diabetes anyway. We have had I think, 5 patients with positive GADs. 4 of the 5 all went on to develop very significant, very quick loss of islet cell function within 3 months. One of them is still insulin independent. And then cancer markers, we want to make sure we're not going to be transplanting any cancer cells into the liver. So we have a multidisciplinary evaluation for total pancreatectomy and islet autotransplant, which involves the GI group, surgeons, endocrinologists, dietitians, health psychology and pain management, a social worker, and then obviously the transplant coordinator. And as you can see from this slide, there's a ton of people involved in getting these patients to surgery. Clearly, this is a pre-COVID slide because we no longer meet in person and do it all by Zoom, which is, I don't think it's ever quite as good as having a meeting in person. So we present all these patients at a multidisciplinary meeting. And what we're looking for here is, do we have a clear diagnosis of chronic pancreatitis, hereditary pancreatitis, or acute recurrent pancreatitis? And even if we do, have we selected the right patient for the right surgery at the right time? So we can have a patient that clearly has pancreatitis and pain, but they may just not be ready for the surgery emotionally. A lot of the patients come in a lot of pain meds, or if they have other comorbidities. So really, it's a very tight-knit group making decisions. Are we really doing the right thing for this patient? So we're looking for a diagnosis. So for chronic pancreatitis, we're looking for patients who've had abdominal pain more than 6 months And this is just a list of what we look for. CT findings of calcification, EUS findings. There's a Rosemount criteria, which there are 9 of these. And if there are 6 of 9 without anything else, that's diagnostic of severe chronic pancreatitis. For recurrent acute pancreatitis, we're looking at somebody that's had a minimum of 3 or more separate episodes of pancreatitis when the lipase is 3 times the upper limit of normal. Now, the upper limit of normal at the university is 356, I think. You can have a patient that has a lipase of 1,000 who can be sicker than a patient that has a lipase of 20,000. It does not seem there's a huge correlation between the level of the lipase and the severity of the disease. And also these episodes must be unrelated to any procedure. So if somebody's just had an ERCP and they develop pancreatitis, that's not unprovoked pancreatitis. So for the hereditary pancreatitis diagnosis, I've listed the 3 main hereditary mutations before. So we have seen a lot of patients who have hereditary pancreatitis and a big family history. That doesn't necessarily mean their pancreas needs to come out. There is an increased risk of pancreatic cancer with especially PRSS1, but it's not as high as one was once historically thought. Really what you're looking at is the patient's pain severe enough to cause disability or opioid dependence. At that point, then we start thinking about taking pancreas out, not just because they have a hereditary factor. So additional things that we look at are, we want to make sure these patients are not drinking, not smoking, they have stable mental health, no evidence of malignancy, BMI below 30. There's a lot of evidence for if somebody has an elevated BMI at surgery, that they're going to have a islet cell loss or increased insulin requirements. It's kind of a little bit like a type 2 diabetic. Immunizations for asplenia, and is the patient willing to commit to a difficult recovery? Lifelong pancreatic enzyme replacement, potential diabetes, and all the other lifelong monitoring that comes to it. And the most important thing, is their pain really related to their pancreatic disease? Because other things cause pain. Is it really debilitating? And do we really think surgery is going to help it? So going back to the surgery, here's the surgery again. You can see it's a huge surgery that we're rerouting half the gut and the bile ducts. So the surgery takes anywhere from 8 to 16 hours. And the longer the surgery, usually it's because the pancreas is very fibrosed and difficult to get out. That also means that oftentimes there's a lot of bleeding because the blood vessels are difficult to dissect. It takes about 3 to 6 hours for the islets to process, and we actually send the pancreas out to our islet cell lab, keep the patient in the OR, and then the patients are still in the OR and the islet cells come back to the OR. We do not send them back to the floor and bring them down anywhere else. So these are some pictures of pancreases. So these are interesting because I'm going to show you 2 pictures. This is a small, quite fibrosed pancreas. This pancreas here is a lot bigger, as you can see if I go back. So I wonder if anybody can take a guess which one we got the most islets out of. It's this one. This second pancreas has actually had a lot of fatty replacement, and the islet cell yield from that pancreas was less than the islet cell yield from the other pancreas. And you can see that this pancreas is cannulated. So this is what we do. The pancreas here is cannulated, and it's injected with collagenase. That actually starts simplistically dissolving the pancreas. It then goes into the Riccardi chamber where it's simply shaken up, and then it's centrifuged, spun down, and then the little cells, the islet cells, are spun out and separated out and literally go into an IV bag and go back into the OR. So the islets get infused through the portal vein into the liver. And this here, this initial infusion triggers inflammation. I want you to remember that because a lot of our current research is looking to try and prevent this inflammation because it's inflammation we know causes cell death. So these islets have lost their blood supply. So they have to make a new home in the liver and engraft. And once they've engrafted, they start producing, they respond to glucose in the liver by releasing insulin. So going back to this, losing their blood supply initially must make a new home in the liver. Islet yields very variable depending on the length of disease, severity of fibrosis. Any previous surgery on the pancreas obviously will reduce the yield. The size of the islets is critically important. Small islets are much better than large islets. And the thought is that they are able to oxygenate a lot better. So the gold standard, we hope to get over 5,000 islet equivalents per kilogram. Yes, we do actually count them. If they get over 5,000 islet equivalents per kilogram, sorry, an islet equivalence means we kind of average the size of the islets, then there's a very high expectation that they will come off insulin. So the next 3 slides, this slide, the sort of dark orange are the islet cells. Those are big islet cells. These are medium-sized islet cells. And you have to look carefully, but there are a lot of small islet cells in this slide. And this person is probably going to have a higher yield and better islet cells, and they're more likely to survive. So hospital stay, I'm going to skip over some of this. These patients are in the hospital about 10 to 14 days, usually 2 to 3 days in the ICU. The ICU stay is not because they're unstable, it's for pain control. Because, you know, the reason we do this operation is for pain. And once we've done the surgery, their pain increases tenfold. So they are on a lot of pain medications. They all are on an insulin infusion until the enteral chew fees are at goal rate, at which point we switch to subcutaneous insulin with a blood sugar goal of 80 to 120. And this is critical. There's a lot of belief that if you stress these islets by asking them to try and work in the early postoperative period, then you're going to increase cell death. IV pain medication until pain is controlled, then it goes to elixir down the J tube, liver ultrasound at day 5 to evaluate for any portal vein thrombosis. If we find anything or sluggish flow, they'll go on 3 months of anticoagulation. And discharge planning starts when pain is relatively controlled, blood sugars are controlled, there's a stable insulin dose, and they're tolerating their chew feeds. So I would beg for the inpatient people to exercise a lot of caution when you look at these patients' pain management, because they are on some incredible doses of narcotics. They've been in pain, many of these have been in pain for years and years. They come in narcotic dependent. And so pain control is very difficult. So as I already mentioned, they have an ICU stay for Precedex. They all get patient-controlled analgesia, oftentimes ketamine, local wound analgesia, lidocaine patches, and then eventually they come out of the hospital on both long and short-acting narcotics. And they are mind-boggling doses. I'm going to skip over some of this. Glycemic management is one of the single most important things we can do. As I said before, we want to maintain those glucose levels at 80 to 120 to prevent any islet cell stress or death. Or I think every one of these patients now comes out of the hospital on insulin. Anywhere between 2 and 3 months, these islets will start functioning, and all of a sudden you'll see patients' blood sugars dropping, and we have to make rapid decreases in their insulin doses. Here, Dr. Bell and our endocrinologist here, she doesn't take anybody off long-acting insulin for at least 3 months because she thinks it has a protective factor. Once in a while, we just have to take somebody off if their islets are functioning really well. But we have patients who will become insulin independent at a year, even though they spent the first year on insulin. Up to 1 year, they may come off insulin. Patient self-care after discharge, they're checking their blood sugars every 4 hours around the clock, taking long and short acting insulin and a correction scale to keep their blood sugars 80 to 100. They're giving themselves chew feeds, elixir medications, pancreatic enzymes. It's a lot of work for these folks, and we send them all to the advanced treatment center the day after discharge because it's such an intense self-care regime that most of them fall apart the first night that they're out of the hospital. So if we bring them back into the advanced treatment center, we go over everything again, figure out what was missed at discharge, put it right, reassure them that they're going to survive. They all do, believe it or not. So long-term issues, and this is where it becomes tricky because there are a percentage of patients who always have abdominal pain. So are these the patients that have central sensitization, opioid-induced analgesia, steatorrhea, related to difficult pancreatic enzyme replacement and balance, small bowel overgrowth. I'm going to get to a bit more of this later. And then there is a small cohort of patients who have really quite difficult to control diabetes. Some of our patients don't seem to be able to gain weight. Sorry. And then oftentimes we'll find they have nutritional deficiencies, fatty acid deficiencies, fat soluble vitamin deficiencies, and interestingly enough, iron deficiency. This tends to be in the first 6 months post-surgery. If they don't respond to oral iron, we just give them a course of IV iron, and almost always that seems to correct the problem, and they then go on to have normal hemoglobins. So what are the risks and complications of islet autotransplant surgery? Well, obviously the islet preparation, these are all cultured, and oftentimes they'll come back with positive cultures. So the patients will go on 7 days of IV antibiotics. We don't see very many abdominal abscesses. It's more common if they have to have intraperitoneal islets. We don't see very many wound infections. We see a lot of GJ tube site issues, not so much infection, but just irritation and fibrotic tissue. Portal vein thrombosis is not that common. Deep vein thrombosis is not that common. We don't get much bleeding at all since they have a splenectomy with the surgery. So I'm going back to this initial slide. What is total pancreatectomy islet autotransplant? It's an operation done for relief of debilitating pain. The islet autotransplant is to prevent the diabetes. The main goal is pain relief. So again, the main goal of this surgery is pain relief. So I'm going to go through a couple of case studies, and I'm going to go kind of success, failure, or other. So case study number 1 was a patient who was done in 2006, whose weight at the time was 70 kilograms. She currently weighs 55 kilograms. She came out of the hospital on a 200 microgram fentanyl patch every 48 hours. And as most of you RNs will know, that's usually every 72 hours, and up to 180 milligrams of morphine orally a day. So recently, because of some survey that she received, she got in touch with us. She's still on 120 milligrams of morphine a day, and she has an intra-abdominal pain pump, but my pancreatitis pain is gone. She's on minimal insulin. I think she was on 5 units once a day. We had no contact with this patient for, I think, 12 years after surgery, and she's on disability. So success or failure. To me, somebody that's on that many narcotics, 12 years after surgery, I have no idea what her GI system's functioning like. I do not think that patient was a success. So case study number 2 is a 32-year-old male who weighed 58 kilograms at the time of surgery. He was discharged on 30 micrograms of fentanyl. This was every 300 micrograms every 48 hours, and 120 milligrams PRN of oxycodone a day, and 1,200 milligrams of gabapentin a day. I almost refused to take care of this young man because I was so scared of how much he was on. But look at this, completely weaned off pain meds at 6 months post-operatively. He had minimal islet cell function. We got hardly any islets out of this young man. He has an insulin pump and a continuous glucose monitor. We followed him very, very closely for a couple of years because he was local, but he moved to Florida. But I talked to him recently. He is now an RN and working full-time. So success. Again, our goal is pain relief. He's on insulin, but he's working, he's functional. So case study number 3, and I threw this one in because I just saw this gentleman yesterday. This is a 57-year-old male who was discharged on 70 units of Lantus a day, 70. He got a very, very good islet cell yield. He came off insulin completely at 3 months after surgery. He's pain-free. He has absorption issues. He never seems to be able to gain weight, and he's currently 7 years post-op. Now, you'll have to crank your head. I couldn't put this picture straight, but this man, if you could have seen him before surgery, he looks like $1 million. And he asked me to share this photograph because he just is doing so well. He's actually taking part in one of our studies right now. So success is measured in, is the patient pain-free, or do they have vastly improved pain? Do they have well-controlled diabetes? They don't have to be off insulin, but is their diabetes controlled? And have we restored their quality of life? So for Jeff here, the answer is yes, yes, and yes. So I'm going to just, this is a story I just have to share with people, because this is a patient whose life was saved by his local hospital, but we restored his life. So he was hereditary pancreatitis, who was very ill when he was a child. And then from 9 to 16 years old, he did just fine. No episodes, was attending school. He was a high school football player. And all of a sudden, something triggered his pancreatitis. I have a suspicion it was medication, and I have a suspicion I know what medication it was. However, that's supposition. So he had a near fatal event. He had a stricture in the duct of the tail of his pancreas, which caused a blowout at the tail. He had a fistula which formed into the lung, and he had amylase in his lung. He underwent a VATS procedure. Now, for all those lung people on here, take a look at this x-ray. See that lung? He was airlifted to the local hospital, and anyway, he survived this episode. And these are the pictures of him. So when I get to some of the GI issues in a little bit, look at the weight of this guy. This was him as a high school football player. I think he was 210 pounds at this point. He was 150. This was right before his surgery. I think maybe right afterwards, but you can see this progressive weight loss of this poor young man. And this was him in the ICU after surgery. This was 3 months after surgery. And if you look closely, he has a continuous glucose monitor there and an insulin pump here. And look at the size of that tiny little scar he's got. At 3 months, he had an A1C of 5.6. He had iron deficiency anemia, but he was off all pain medication, and he weighed 157. This islet cell yield was absolutely unbelievable. Dr. Billman said when he did this young man's surgery, he said, it looks like a bomb's gone off in his abdomen. And this is this young man now. Look what he's eating. And at 1 year, his A1C was 5.2. He has an insulin pump. He has no anemia. All his fat soluble vitamin levels are normal. No pain meds. He now weighs 190 pounds. And he's working he's from Louisiana. So he works as a swamp guide and a trapper, and he has proposed to his girlfriend. So what do we have for diabetes outcome? How do we really do for this? So 60% of these people are going to probably be on insulin for life. Obviously, the more islets you transplant, the better chance to come off insulin. It's approximately, we get 1/3 of these patients off insulin completely, 1/3 are on actually just a once a day long acting dose, and then 1/3 of them are on multiple daily injections. So other diabetes outcomes. So all of you who have worked with type 1 diabetes know that these are complications of diabetes. So I'm going to get to this a little bit more because we're actually just developing a study to look at this. So pain outcomes. 85% of our patients undergoing total pancreatectomy and islet auto transplant tell us at a year that their pain burden is significantly improved, 85% of them. Now, up to 40% of them are still using opioids at 2 years. But if their pain is improved and they're functional, I think that's a successful outcome. So what's the elephant in the closet here? We seem to have good diabetes outcome. We have extremely good pain outcomes. And this is the elephant in the closet to me. And this is anecdotal. This is my experience. I think we haven't got a handle on the GI outcomes. We have a lot of patients that have pancreatic insufficiency despite what seems like good enzyme replacement. Steatorrhea, constipation. A lot of patients have terrible constipation they're not aware of. Is this due to long-term opioids? We're not sure. We have 2 or 3 patients that have had rectal prolapses because of their constipation. We've had patients have ascending colitis, presumably because of the anastomosis of the bile ducts. Malabsorption of vitamins, fat, and iron. Inability to gain weight. Issues with C. diff. This one here, small bowel intestinal overgrowth, is a big problem. And going back to today's first speaker, I was fascinated when she was talking about the gut microbiome, because we are starting to talk about this with some of our patients with significant problems. And the idea of a fecal microbiota transplant has raised its head. We haven't done this. We've done it for patients with C. diff, but that is in the back of everybody's mind is there a way we could potentially reset their gut and help them by doing a fecal microbiota transplant? But I say that's in the future. It's just something we've been talking about. So what are we doing for research right now? So I'm just going to go over past, present, and some of the ongoing future. So past research, we did a study, we called it the sitagliptin study. So the patients were double blinded and they either got sitagliptin, which is a DPP-4 inhibitor, basically a type 2 diabetes drug. Half of these patients took a placebo, half of them took sitagliptin once a day for 12 months. And we followed it with a bunch of metabolic testing. And when we unblinded them and looked at all the results, there was absolutely no difference whatsoever. Of course, all the patients who are on sitagliptin think that that helped them, but actually, statistically, it did not. Anti-inflammatory study, so if you remember, I talked about the islet having cell death with the inflammatory reaction at infusion. So we have the results of this study are pending, but we enrolled 28 patients and randomly assigned them to receive one of the following. So one of them was IV alpha-1 antitrypsin. The other branch was subcutaneous etanercept. And the third one was we gave them nothing, which is standard of care. And we are currently waiting for the results of that study now. So that'll be very interesting to see if the anti-inflammatories helped, and if so, which one. The research nurse and I already think one of these helped significantly. We can't prove it yet, but we think we might have some good results. So current and ongoing research, the post study is a prospective observational study of total pancreatectomy. This is a multi-center study. We're gathering information as to the treatment they had before they had the pancreatectomy and afterwards. And the hope is that we will be able to go back and look at this and figure out who did the best and why they did the best. Retrospective prospective study is a survey that we've been sending out for years and years and years. And most of our pain data outcome comes from those. This here, the LIFT study, the long-term islet function and impact study, this is the one that's going to be very, very important. So currently Medicare does not cover an islet autotransplant. So we have been trying for years to try and get them to cover the islet autotransplant part of this. So what we're doing is enrolling 200 to 300 participants. These are patients who have had their islet autotransplant from 5 to 20 years. So they are 5 and 20 years post-transplant. And what we're looking at is IHEXL studies for renal function, iPhotos for retinopathy, nerve conduction studies for neuropathy, mixed meal metabolic testing, and carotid ultrasounds to look at vessel disease. And what we're hoping to do is use this data to compare to the many existing long-term studies of patients with type 1 diabetes to show that the islet autotransplant has definite benefits to rather than doing a pancreatectomy alone. Now, so far we've enrolled 4 patients in this. It's very time consuming, but we're hoping very much that this will be the study that persuades Medicare to cover this. And then future research, we've got the DREAM study coming up. We haven't even started this, and we're starting to look at diabetes related to acute pancreatitis, because you often see patients with severe acute pancreatitis requiring insulin during the acute pancreatitis phase, but then coming off it afterwards. So we're looking to see what impact that might have in the future and whether we can learn anything from it. So here's your test. What's the primary goal of total pancreatectomy islet autotransplant? Pain relief. Secondary goal is stable diabetes and restoring a patient's quality of life. And it takes a whole bunch of people to do this. So thank you very much for listening to me. That's about as much as I can get into half an hour. Thank you.
Louise, thank you so much for that wonderful talk. It was a really great overview and excited to hear about what is coming in the future. Does anyone have any questions for Louise? Feel free to either unmute yourself or put it in the chat. Got a couple of thank yous in the chat. Okay. Michael says nicely done. Great overview.
That's a great compliment. Thank you, Michael.
Right.
From the man that hired me all those years ago.
All right, thanks guys. Louise, if I get any additional questions, I will go ahead and forward them on to you and connect you with who's asking.
Okay, thank you.
Thank you. Have a good day. All right, our next speaker is Dr. Raja Kindaswamy. Dr. Kindaswamy is the Vice Chair of the Transplantation Division, Sutherland Butterfield Professor in Immunology and Transplantation, Director of the Kidney and Pancreas Transplant Programs, and Director of the Abdominal Transplant Fellowship Program in the Department of Surgery at the University of Minnesota, where he's been on faculty for the last 20 years. He serves on both national and international bodies, including serving various roles in the IPTA leadership. Dr. Kindaswamy is also the Senior Staff Member for Pancreas Transplantation at SRTR since 2008 and continues to serve on various committees of the ASTS, currently as the co-chair of the Standards and Quality Committee. After receiving his medical degree from the University of Madras, he completed his general residency in general surgery at Howard University Hospital and his fellowship in transplant surgery at the University of Minnesota. Dr. Kindaswamy has published over 100 articles, has over 300 accepted abstracts at national and international transplant meetings, and has been an invited speaker at conferences nationally and internationally. He's an associate editor for clinical transplantation, and he's a reviewer for several journals, including the American Journal of Kidney Disease, American Journal of Transplantation, and Transplantation. Dr. Kindaswamy's surgical expertise is in the area of multi-organ abdominal transplants, including kidney, liver, pancreas, and islet transplantation. He has spearheaded the effort to develop and implement laparoscopic donor nephrectomy at the University of Minnesota and perform the world's first laparoscopic hemipancreatectomy in combination with nephrectomy as a donor procedure. His areas of research interests are in kidney, pancreas, and islet transplants, of which he has led several major studies in, including those involving steroid avoidance and withdrawal. Thank you, Dr. Kindaswamy, for speaking with us today. And Dr. Kindaswamy will be speaking on eplet testing for optimizing kidney donor and recipient matching.
Thank you, Christine. Appreciate the invite to speak to the ITNS group, and it is indeed a pleasure to be here and share some of our experiences as it relates to eplet matching, specifically in kidney transplantation. Let me see if I can share screen. You can see my screen. Okay. So I'll spend the next few minutes here talking about eplet matching in kidney transplant and the application of this new technique, relatively new technique. For disclosures, I'm a member of the medical board of the National Kidney Registry, through which we do most of our eplet matching at this point. And I'm also senior staff at the Scientific Registry of Transplant Recipients, which Christine mentioned. It has no direct conflicts with this talk, but I do like to mention it because it's a government contract. We'll start off just talking about matching in kidney transplantation. As most of you are aware, we look for blood type compatibility, where we screen out donors that are incompatible and try to pair them up with other donors that may be compatible. So the first layer of matching is blood type. The second layer of matching is HLA matching, and HLA matching started in 1960s. Was introduced by Paul Terasaki at the UCLA histocompatibility lab, which was a legendary lab for a long period of time and is now run by Mike Sheka. However, after about 45 years of experience with HLA matching, we found that it's of limited usefulness. It's useful when you have a zero mismatch, meaning a 6 of 6 match. And if you start looking at anything beyond a zero mismatch, then a DR locus matching was the only one that was found to be impactful for outcomes in kidney transplantation. So we've been searching, I think, for the last many decades for a better form of matching in kidney transplant that could potentially improve outcomes over and above traditional HLA matching. And that's where molecular matching or eplet matching comes into play. Eplet matching uses epitope analysis, and I will go into more details as to what this is in a moment. Currently, as it's practiced today, the eplets from the DR and DQ loci are the only ones that's used for matching, because those are the ones that's associated with outcomes. And better eplet matching at a high level results in decreased DSA formation. DSA stands for donor-specific antibody, and may allow for lower immunosuppression. So that's a very high level 3-bullet statement on what eplet matching is. We'll dive into more details in the following slides. HLA identical transplantation definitely prolongs kidney graft survival. We know that from the first set of transplants done in 1950s by Murray and group. But if you look at the experience since then, this graph shows you different levels of HLA matching and outcomes over 10 years after kidney transplantation. You can see that zero mismatches and other phenotypically close matches are represented in the upper curve, and anything greater than one antigen mismatch is listed in the lower curve. So anytime there's a mismatch, it has a lower outcome, but it doesn't seem to really tell you whether 2 is better than 3, being better than 4 or better than 5. So we don't have very much granularity in HLA matching, except it sets apart the zero mismatch or the perfectly matched donor recipient pairs. I want to introduce the concept of antibody mediated rejection for the audience, just so we are aware of what we are targeting with eplet matching. Antibody-mediated rejection is one of 2 types of rejection, the other being cell-mediated rejection. It was recognized in the 1990s. It's mediated through antibodies, de novo or preformed. And AMR was officially recognized as a distinct form of rejection with its own diagnostic criteria, not until 2003, although it's been present since the inception of transplant. And it's mediated through donor-specific antibodies. And today, the ongoing challenge in transplantation is donor-specific antibodies. So this is the risk of donor-specific antibody development in kidney transplant patients over time. If you look at 5 years post-transplant, about 20% of all patients will develop donor-specific antibodies. What is the problem with donor-specific antibodies? It can lead to graft loss. That's really what it comes down to. And we'll show that in the next slide. If you look at the impact of donor-specific antibodies on graft survival, the green line here shows those that did not develop donor-specific antibodies versus the orange line, which shows patients who developed donor-specific antibodies. And this graph is quite striking in that the survival curves go down significantly once you start developing antibodies to the donor. And this can be measured by a simple blood test to look at DSA measurement. Non-compliance or non-adherence and a presence of HLA DR beta 1. So DR mismatches and non-compliance were shown to be risk factors for de novo DSA development, at least in this study by the Canadian group in 2012. So DR started getting a little interesting, as well as DQ, because those were the 2 mismatches that showed increased development of DSAs. And if you look at causes of late graft failure after kidney transplant, about 50% of them are due to antibody-mediated rejection. Again, all these slides are just to show you that donor-specific antibodies are a major problem in kidney transplant, and antibody-mediated rejection is a major cause of graft loss, and there's a connection between the 2. So our goal is to try to decrease this by using newer technologies, and that's where eplet matching comes into play. What are eplets? Eplets are small patches of polymorphic amino acids within the larger HLA molecule. So this shows the HLA antigen, the whole structure of it. It's a 3D representation, but there are specific loci on the amino acids on the HLA itself to which the antibody binds. The AB portion of the FCAB portion of the antibody binds to specific sites. So when the antibody and antigen react, it's not like the entire surface touches each other. There are specific touch points, and these touch points are called eplets. And these eplets vary even amongst very similar HLA antigens. And they may be alike even in very different HLA antigens, because it's just like a specific character. For example, 2 people who look completely different may have exactly same shaped nose, or they may have exactly same colored eyes. So there are specific parts of them that could be matching well, even though they're very different in their general appearance. That's kind of rough analogy of this. HLA eplets better describe the immunogenicity of HLA antigens, and HLA eplets are patches, which is basically what I just said. And these are the targets of the antibodies. How is it different from traditional HLA matching? Traditional matching is to show how many HLA antigens are matched with recipient antigens, and it's usually given as a product of 6, 1 to 6 out of 6 match. And the numbering system doesn't always describe the quality of the match. Whereas in eplet matching, we look at the number of differences in eplets between the donor and the recipient. We do not pay attention to the HLA itself, in that we don't pay attention to the overall appearance of the individual, just very specifically to the color of the eyes, the shape of the nose, and so on and so forth. Eplet match load represents the amount of non-self that can be presented to the host immune system. So is eplet matching superior to HLA matching? There are some retrospective studies. I have to warn, I perhaps should have put here retrospective studies only so far. We have 5 major studies. 2 of them are from Europe, Eurotransplant and the Belgian study, and 2 from Canada, Edmonton Group, and 1 from the University of Colorado in Denver. And they're all recent, as you can see. Starting in 2017, there's been a flurry of studies in this area. There's been a lot of interest. And as you can see, there's several thousand patients in this overall cohort. There's about 5,000 plus patients that have been looked at. And prior to this, Canada did some background studies with almost 10,000 patients. And I'm not showing you that data here, but these are the most recent studies, and they look at the percent of de novo DSA in each of these studies, and when the DSA was monitored, and what percentage of patients were living donors. It should be noted that none of these series here have over 50% living donors. So meaning the majority of patients in all these retrospective studies are deceased donors. So all the eplet data we have so far, and keep this in mind, is 1 retrospective, although it's strong because it involves several thousand patients. And 2, it's in deceased donors. So it's not been shown in living donors as yet. And that's what we are setting out to do. So this is one of the studies which I alluded to. This is from Pete Nickerson's group, who have pioneered this area from Canada. And they classified the mismatched eplets from the DR and DQ loci only into 3 different matches. One is a low risk, which is a green line, then the intermediate risk, which is blue, and high risk mismatch, which is red. And each one has a certain number of mismatches that's counted in. The details are not that important. For example, if you have no mismatches in both DR and DQ, obviously it'll be a 0 or low eplet mismatch. If you have greater than 7 and greater than 9 DR and DQ mismatches, then it's a high, and somewhere in between would be a intermediate. And this was how they layered out their patients and look at the outcomes. When they look at their DSA-free survival, when it was low or intermediate, then they had a very good outcome in terms of DSA-free survival. When they had a high-risk mismatch, the DSA-free survival dropped off quite tremendously, where almost 20+% of their patients developed DSA in this group, compared to less than 5% in the first 2 groups. The Colorado group more or less replicated this with American data, also retrospective, and they show that the high, intermediate, and low risk groups, they use the same grouping as the Canadian group for reproducibility, and they showed good difference in DSA formation between the 2. This is again another representation of that. Percent of de novo DSA, which is donor-specific antibody, was only 1% in the low-risk eplet mismatch group, and up to close to 20% or 17% in the high-risk mismatch group. And remember from the previous slide, DSA is bad for antibody-mediated rejection, and antibody-mediated rejection is bad for graft loss. So the goals of eplet matching are to improve transplant outcomes by decreasing DSA formation and potentially providing an opportunity to lower immunosuppression in well-matched transplants, because they are lower risk for for rejection. There is an independent study that shows that immunosuppression, lower immunosuppression can be tolerated better in the well-matched groups of eplets, but I'm not going to show that study in this talk. How do we achieve these goals of eplet matching? We systematically have to do what's called high-resolution tissue typing. The traditional typing does not give you an epitope analysis or an eplet analysis, so we have to do what's called high-resolution typing. For that, you need specialized techniques instituted in your laboratory, which is the HLA lab, for both donors and recipients. And maybe it's advantageous to get that very early in the process. Then evaluate to see if you can actually improve the match. If there's, this can only be done in a living donor situation where you take a poorly matched eplet mismatched pair and try to improve the match by going into a paired exchange scenario and finding a mix and match where you can find a better eplet matched recipient and for your donor in exchange for a better eplet matched donor for your recipient. So patients with a medium or high eplet mismatched donor can generally upgrade to a low eplet mismatch. That's been our general experience, subject to some limitations. If you look at parent to child matching, we've used the eplet matching a lot in pediatric transplants. 75% of parent to child matching is medium or high eplet mismatches, and that's pretty striking. So if you look at this group, and even if you just took the high, it's about 13%. So 1 out of 6 or 1 out of 7 parents will be a high risk mismatch for their child. And 75% will be the high or medium. It's very common for parents to volunteer to donate to their children, but counseling to see if we can, if they fall into this bracket, then it's fine, they could go direct. But if they don't fall into this bracket and they fall here, then you stand the risk of diminished outcomes in terms of DSA formation and poorer outcomes for the child. So this is a paradigm shift for counseling, and it's really taken a lot from our team to try and do this for pediatrics, which I think is paying off. So I'll give you an example. A 30-year-old patient has 2 potential living donors. I'll give you an example of what the HLA matches were. If you look at the HLA categories, the recipient is an 8224, recipient is 6824. So there's there's a single antigen mismatch, single antigen match, same with donor 2. If you look at B, same thing. There's a single antigen match and a single antigen mismatch. And DR, they match all at the DR1 single antigen match, single antigen mismatch. So this would be a 1-1-1 mismatch for both donor 1 and donor 2. So if you just use the traditional HLA matching, these 2 are identical donors immunologically. But if you took the same donors and did eplet typing on them, here is their eplet load, mismatched eplets between the 2. And you can see in each loci how many eplets are mismatched. In donor 1, the total number of eplets mismatched is 21. In donor 2, the total number of mismatched eplets was 46, almost twice the number. So we clearly have a lower immune reactivity with donor 1 as opposed to donor 2, which you would not have recognized without the high resolution typing and eplet analysis. So how do we use this information to do our living donor transplants? Because currently this technology is only available for living donors because the turnaround time is a few days to get high resolution typing. It cannot be used in deceased donor transplants. So when we have a compatible pair of a donor and recipient, we look to see if they're a 0 eplet mismatch. Of course, if it's a 0 eplet mismatch, they go directly from donor to recipient. If it's a low eplet mismatch, in the majority of cases, we let them go directly, but we will look to see if a 0 eplet mismatch can be obtained within 2 months. We have that predictor in the National Kidney Registry system where we can go to a predictor for wait time. And if it looks like they're going to be able to score a 0 eplet mismatch within 2 months, we may consider putting them in as a pair. But almost invariably, if they're either an intermediate or a high eplet mismatch, we will try to upgrade them at least 1 level from a high to intermediate or from an intermediate to low. Sometimes we'd like to go, even to two levels from high to a low, but it all depends on the number of donors available for them and the type of tissue that they have and the type of eplets. So I'm not going to go too much into the details of each of these boxes, but suffice to say that 0 eplets go direct, low eplets majority of the time go direct, intermediate and highs, we try to upgrade them and move them closer to lows. Some of the highs, which are hard to match, we may just move up 1 to intermediate. So this is what we have done so far. We started the program mid 2020, and our first transplant, we started analyzing these in mid 2020, around end of June. And we started our first transplant in August, and since August, about a year, 11 months into, actually 13 months into this program. This is a report from the country in National Kidney Registry. As you can see, we have done the largest number of low or 0 mismatched eplet transplants in the country. There's about Georgetown, University of Wisconsin, Madison, Intermountain Health in Utah, and Salt Lake City, and NYU in New York are the top, round out the top 5 centers that have performed these type of transplants. The numbers are not huge. You can see that we have touched 20 and we are the largest in the country. So these are quite complex to do, involves a team putting together immunology, transplant coordinators, both donor side and the recipient side, and meeting almost on a daily basis to try and look at these tissue types and find these matches in order to improve the outcomes. We have had some proud moments. This is our first 0 eplet mismatch transplant. This is a nurse who's a Minnesota native, went to New York and worked during the peak of COVID times last spring, and she served there for a few months. Came back quite exhausted, and like she hadn't done enough good deeds, she came back and decided she's going to be a non-directed donor and donate a kidney to somebody that needs a kidney. And then she matched up with a toddler who lives locally, and to our surprise, we found that they were 0 eplet mismatch. It was the perfect situation, and she donated a kidney last year, and both donor and recipient are doing great. This is really why we do this, and we are hoping that in the future we will continue to expand this program. What's the future of eplet matching? Of course, what I talked about, which is uncoupling of compatible live donor pairs. What would be deemed compatible in the past, right? A blood type match would have been deemed compatible. And right now we're trying to find them and uncouple them if they are not well matched from an eplet standpoint in order to improve the outcome. The idea would be to actually study this. It's one thing to start the practice, but we want to have a prospective randomized trial. We have written an NIH grant in conjunction with 5 centers. A couple of them are in those top 5 centers that I showed in the slide. The grant is yet to be funded. We are still in the process of negotiating with the NIH. So hopefully it'll get funded and we could start a prospective randomized trial to study the effect of eplet matching on DSA and graft outcomes in the long term. It would be a real long study. You would need about 7 years to really show differences and get enough patients enrolled. With, as you can see from the number of transplants, we can't get hundreds of them done every year. But at least the study will be cooking, but I don't think we're going to be waiting for those study results to come out, because the strength of the retrospective data makes one believe that this would be the way to go. And really, there's no downside to it. That's really, whenever you're thinking about a new technique that you're planning to use, if you don't see a harmful effect to the patient, then you have a much lower threshold to adopt it. Granted, you have to utilize resources and pay more attention to and use uncoupling and paired exchange more often. But that system is becoming fairly smooth with the National Kidney Registry. The third possibility in the future is that you may be able to actually select out the well-matched pairs. And if they're going to do so well, they only have a 1% risk of DSA. Why not try to decrease the immunosuppression? And because immunosuppression, as we all know, is bad in many ways. It has several side effects, and we want to try and decrease it whenever we can get away with it. And this may be a good opportunity to select out patients in whom you could trial decreasing immunosuppression. Finally, I think that we could apply this to deceased donor transplantation as well, but the technology for eplet typing has to catch up. And Dave Maurer, my HLA lab director, tells me that we are a good 3 to 4 years away from having this turned around in a couple of hours for us to be able to apply this in deceased donor transplantation. But that perhaps is the future, since the data on deceased donor transplantation is already out there. I want to acknowledge my team and the folks that work with me at the University of Minnesota in this endeavor, which started last year and has brought us to being the lead center in the country. Dave Maurer and his colleagues at the HLA lab here, Lisa Warnke, who's a living donor program supervisor, and her team. The National Kidney Registry with its staff has been very helpful in working with us on this. And all the people in the eplet review team, we meet every morning at 11:30 to look at eplet matching of potential donors and recipients. And the donor coordinators, recipient coordinators, the HLA lab personnel and physicians are all involved. So it takes a village really to run this. So, and I want to acknowledge all of them. And for the slides as well. Some of these folks on this slide have provided some of the slides for me. So thank you very much for giving me the opportunity to speak here, and I'm happy to take any questions.
Thank you, Dr. Kandaswamy, for your talk. I think I've heard talks about eplets now probably 3 or 4 times, and every single time I learned something new. So thank you. Is there any questions from the group? Yeah, I don't see anything, but if I hear of any, I will send them your way and get you connected with the person asking.
Excellent. Thank you.
Thank you so much for speaking for us. Really appreciate it, and have a good afternoon.
You too. Bye.
Thank you. Bye-bye. And next we have, I think I saw Tina log on. Next we have an optional talk from our program sponsor today, AstraZeneca. So Tina will be speaking for us. Tina Gady lives in the northwest suburbs of the cities. She's with AstraZeneca in the renal division as an executive hospital sales specialist. She covers all of Minnesota, North Dakota, and South Dakota, and she enjoys educating when she can and will work hard to help your patients who suffer from hyperkalemia. Thank you for joining us, Tina.
Thanks, Christine. I really appreciate this so much. I really do. Thank you. I'm going to share my screen here. Okay, can we see that?
Yes.
Okay, perfect. Excellent. Sounds great. I'm just going to get started if that's okay, because I know I have limited time. So thank you, Christine, for that. I'm going to speak here today in regards to Lokelma for the treatment of hyperkalemia. I know with your transplant patients, some of the drugs that you put them on do cause, it's one of the side effects of these drugs, such as I believe Prograf, and then Bactrim is the branded names of some of the drugs that you may or may not put your patients on. And they both do have side effects or adverse events for causing hyperkalemia. So that's where Lokelma would fit in for your patients. So if we jump into, oops, let's see here, advance my slide. There we go. So if we jump into the indication of Lokelma and its limited use. So Lokelma is indicated for the treatment of hyperkalemia in adults. Limited use is Lokelma should not be used as an emergency treatment for life-threatening hyperkalemia because of its delayed onset of action, which we'll get into further. And Lokelma is not indicated to reduce the risk of death. So Localma is a little bit different than the other two that are out there currently. So it's very innovative. It's a highly selective potassium binder that is different. And Localma has a unique, first of all, let me back up. Localma preferentially captures the potassium in exchange for hydrogen and sodium. And it's not a polymer. So that's where the unique crystalline structure comes into play. And it's insoluble and does not expand in water. So it is not expected to swell within the GI tract. Localma works within the lumen of the small and large intestine or GI tract. And so basically that results in the early capture of that potassium. And in vitro, Localma has a high infinity of potassium, even in the presence of other cations such as calcium and magnesium. And clinical pharmacology does not correlate with efficacy or safety. So some of the features, if you will, of Localma, the table shown here represents selected features of potassium binders. So Localma, as I mentioned, is a selective K binder. And unlike SPS or Veltessa, it may also bind calcium and magnesium respectively. As you can see here, Localma and SPS are calcium free. And the sodium content unit dose of Localma is 400 milligrams. And the recommended maintenance dose range of Localma for non-dialysis patients is 5 grams every other day to 15 grams daily. And for dialysis patients is 5 grams to 15 grams once daily on non-dialysis days. And as I mentioned before, Localma is a non-polymer and it works in both the small and large intestines. So just getting into some of the warnings and precautions, I won't read it word for word, but you've got your GI adverse events in patients with motility disorders. So avoid Localma in patients with severe constipation, bowel obstruction, or impactation, including abnormal post-operative bowel motility disorders. Edema is going to be your next one. Each 5-gram dose of Localma contains approximately 400 milligrams of sodium, but the extent of the absorption by the patient is unknown. So in a trial that was done, it's with about 500 and some patients, 562 patients to be exact, only 1 patient discontinued due to edema. So it's not significantly significant. Hypokalemia in patients on hemodialysis. Patients on hemodialysis may be prone to acute illness that can increase the risk of hypokalemia on Localma. So here is a graph of patient demographics just to really understand Localma, and across all these studies, there were studies 1 through 3, which included a similar population of patients with comorbidities, such as your heart failure, chronic kidney disease, diabetes, and patients taking your RAS inhibitor therapy. In studies 1 through 3, they were real similar in heart failure, 10%, 11%, and 15% for study 1, and then study 2 and study 3, respectively. And your CKD patients were 60%, 60, and 65 for study 1, 2, and 3, respectively. For diabetes, you can see it was 62, 66, and 64% for study 1, study 2, and study 3, respectively. And for your RAS inhibitors, it was the 67, 70%, 65% for study 1, 2, and 3, respectively. Now you can see with the dialysis, the study 4 was comprised of 196 patients with ES or end-stage renal disease on stable hemodialysis. 34% of patients in study 4 had diabetes, and there will be an opportunity later to present this in greater detail if we get to that point. So as I mentioned, Localma does work fast to reduce potassium. It starts as early as 1 hour. And the reductions in the potassium levels were observed, as I said, in 1 hour after initiation of the therapy of Localma with 10 grams daily, continued to decline over the 48-hour treatment period with Lokelma, 10 grams 3 times daily. Now the dosing arrows follow, found behind or below the graph indicate when Lokelma 10-gram dose was administered during the study. The study met its primary endpoint, and the difference in exponential rate of change in mean serum potassium levels during the initial 48 hours, demonstrating a great reduction in the serum potassium levels for patients receiving the Lokelma 2.5 grams, 5 and 10 grams 3 times a day compared to placebo. And the exponential rate of change includes the time to onset and incorporates all potassium measurements in those 48 hours, throughout the initial 48 hours. Just real quickly here too, I want to preface that Lokelma should not be used as an emergency treatment for life-threatening hyperkalemia because of, again, that delayed onset of action. Okay, so as we see here, we've got a whole graph, and I won't get too into great detail with this as well due to time, but Lokelma helped patients, of course, rapidly achieve the normal kalemia, as we state, and sustain the potassium control for up to 1 year with continued treatment. And that was study 2 that that I shared just recently. Now, about 92% of patients achieved the normal kalemia within 48 hours from baseline. And Lokelma sustained mean potassium at lower levels than placebo over the days 8 through 29. And if we look at the third graph here, for the 11 months, Lokelma sustained normal potassium levels with continued treatment in patients who remained in the open label extensive phase. So it just shares that, you know, it works. 92% of those patients had that normokalemia within that 48 hours, and it sustains throughout the time frame. So Lokelma is shown to be very well tolerated in the majority of your patients. And oops, am I missing? I'm missing a slide here. Hold on, let me go back. Oh, I am, let me see here, let me jump ahead. Oh, I'm sorry, here we go. So as I was saying, Lokelma has shown to be safe and generally well tolerated in non-dialysis patients. So as we can see here, safety was evaluated in this clinical trial with more than 1,700 patients not on dialysis with hyperkalemia and comorbidities, including again the CKD, DM, and CHF, with 507 patients were treated for at least 1 year. There were no GI side effects listed in the Lokelma prescribing information. However, there were GI adverse events observed in the clinical trials. So adverse events in the non-dialysis patients include edema and hypokalemia, as we discussed. And in clinical trials of Lokelma, edema was generally mild to moderate in severity. In placebo-controlled trials in which patients who were treated with once daily doses of Lokelma for up to the 28 days, edema was reported in 4.4%, 5.9%, and 16.1% of patients receiving the 5, 10, and 15 grams of Lokelma, respectively, compared with 2.4% of patients receiving placebo. 0.2% of patients, one again out of 479 discontinued Lokelma due to the edema. And in longer term uncontrolled trials in which most patients were maintained on doses of the 15 grams QD, edema was reported in 8% to 11% of patients. We're going to skip through that one. So with Lokelma, it's very simple to take. So here we're going to get into a little bit of the dosing, the recommended dosing. So Lokelma is a once daily option, and following initial treatment period of up to 48 hours in the non-dialysis patients. So, excuse me, so we want to monitor their potassium and adjust the dose of Lokelma based on their potassium level and desired target range. So for maintenance treatment, the recommended dose is the 10 grams daily. And During the maintenance treatment, up titrate based on the serum potassium level at intervals of 1 week or longer in increments of 5 grams. So decrease the dose of Lokelma or discontinue if serum potassium is below the desired target range. And then again, the recommended maintenance dose range is the 5 grams every other day to 15 grams daily. So in general, other oral medications should be administered at least 2 hours before or 2 hours after taking Lokelma. Because of the reason that it can transiently increase the gastric pH. So that's why we want to do 2 hours before or 2 hours after. And the nice thing with Lokelma, unlike some of our competition out there, is it is tasteless and odorless. Very simple to take. Patients love that aspect of it, and it doesn't need to be refrigerated whatsoever, so it can be placed in the emergency room or anywhere on the floor or in the Pyxis machines as well. It's a great opportunity for that. But as I stated before, Lokelma is available as a 5 gram or 10 gram white powder in a foil lined packet for the oral suspension. So very simply, just take it and pour it into a glass of 3 tablespoons of water, stir it up, and then drink immediately. If you have any residue left over, add more water, and then go ahead and stir it and drink it right away. And again, just remember, in general, other oral medications should be administered at least 2 hours before or 2 hours after taking Lokelma. So just really quickly here, of course, safety and efficacy. We want to get into some of the adverse events. As we've mentioned before, the most common adverse event in non-dialysis patients with Lokelma was mild to moderate edema. You've got in placebo-controlled trials, up to 28 days, edema was reported in 4.4%, 5.9%, 16.1% of non-dialysis patients treated with the 5 grams, 10 grams, and 15 grams of Lokelma once daily, respectively, versus the 2.4% of non-dialysis patients receiving placebo. Drug interactions, as I mentioned, Lokelma can transiently increase gastric pH. Again, taking those medications 2 hours before or 2 hours after. And then with the help with the non-dialysis patients with hyperkalemia to achieve the rapid and sustained potassium levels with Lokelma. Lokelma started to work again as early as in 1 hour. Lokelma sustained normokalemia for 1 year with continued treatment. So it does have that maintenance, of course, capability for treatment. You can continue Lokelma for at least 1 year. The limitation of use, as I mentioned, Lokelma should not be used as an emergency treatment for life-threatening hyperkalemia because of its delayed onset of action. Although with the emergency departments today, a lot of the K-Oxalate or SPS is being used. You may have heard of that. It's been out for decades. And we see a lot of GI necrosis with SPS. It doesn't taste pleasant. It has to be refrigerated. So there's a lot of consequences to that drug. And really, there's newer things out there than SPS, such as a Lokelma. And we're working really due diligently with the healthcare systems to get that to change. And I know change is hard at times. So this is a great, basically, addition or adjunct to what's currently being used with your calcium or loop diuretics within the emergency room. Add Lokelma to those. So it's an adjunct therapy to the emergency department. As I mentioned, generally well tolerated. The only adverse events listed in the Lokelma label were the edema and hypokalemia. And then, of course, there are no GI side effects listed in the Lokelma prescribing information. However, there were GI adverse events observed in clinical studies. Real quickly here, I'm going to jump, if I can, and go through a couple of these. This is also what the packets look like as well. And then I wanted to get to this because, of course, this is one of the questions that I always get as far as affordability. Can we afford it? Can the patient get it? If the doctor prescribes it and writes for it, can my patient get it? Absolutely. Localma is very well covered here in the state of Minnesota, amongst other states, but I'll speak solely on Minnesota. We do also have, just like other companies, we have these capabilities of a zero copay card. That is for commercial patients only, so patients will not pay anything for their Localma. We also do have the free trial offer. Now that is good for anyone. Patients who have insurance, patients who don't have insurance, Medicare, Medicaid, anyone can use the free trial offer for Localma. So it's very easy to get that prescription. We have so many different assistant programs to help out with prior authorizations, or we have programs to help with patients who don't have insurance and go off of what they make, the patient assistance program. So we do have AZ&Me is a great program. They will walk and help you through and really take care of the patient. As I stated, the provider is writing for Localma and we need to get our patients on it. And there's ways to go about doing that, whether or not they have insurance or not. We have the free trial offer. And then of course we have that zero copay for those that do have insurance. So if you have any questions, I'd be more than happy. I know Christine has my information, and you can certainly email me, contact me with questions, or if you want these copay cards or anything of that nature, I would love to help your patients who do come with hyperkalemia. So I do want to thank you, Christine, very much for allowing me to take this time to speak to you.
Thank you so much, Tina. Thank you.
Yes, thank you. I appreciate it. Thank you so much.
Yeah. Anyone, please feel free to email me if you have questions for Tina. Otherwise, we will come back in 15 minutes after a break. Thank you.
back and I'll find it and get it rolling.
Hi, everyone. Welcome back. Welcome back from the break. Our next speaker is Michaela Calhoun from Graphica Medica, and Michaela has recorded her talk. And I believe she will be on at the end to answer any questions we might have. But for now, we will watch her talk. I've got her intro here, so you know a little bit more about her. Michaela is a board certified clinical anaplastologist and owner of prosthetics at Graphica Medica. Michaela studied anaplastology at the University of Illinois at Chicago, where she earned both a Bachelor of Fine Arts and a Master of Science degree. In addition to her clinical work, Michaela is passionate about her work with several organizations that work to advance the visibility and continual evolution of her field of anaplastology. Michaela is the current president of the Walter Spahn Trust, a nonprofit organization that administers grants and supports educational research in the field of prosthetic rehabilitation. As a native of the St. Croix River Valley, Michaela enjoys exploring the Minnesota wilderness, volunteering in her community, and spending time with her extended family. So we will watch Michaela's talk.
Hello, I'm honored to be speaking to the Upper Midwest ITNS conference. My brief involvement in a transplant event was one of the most fascinating experiences in my life.
What is going on? Stop share. Let's retry that.
Give us 1 second here, folks.
Okay, I'm gonna do something else here. Let's see here. Not minimize when you're recording Zoom meeting. Okay. Oh, met somebody. Sorry about this, folks. Right here. Screen, this one. Share. You got it? You see it? Okay.
Hello, I'm honored to be speaking to the Upper Midwest ITNS conference. My brief involvement in a transplant event was one of the most fascinating experiences in my life, and I truly respect what you all do. My name is Michaela Calhoun. I'm an anaplastologist at prosthetics at Graphica Medica in St. Paul, Minnesota. I'm going to be speaking about the process of creating life masks for the donor of a face transplant. I had the opportunity to be part of the team at Mayo that completed the first transplant there in the summer of 2016. I'm going to share the small part of the process that I was involved in. And I'll start by giving you an introduction to my field, anaplastology, share a little bit about what we do on a daily basis. And then I'll talk about our partnership with LifeSource and a couple of the ways that we've collaborated, specifically on the life mask for a face transplant donor. First, I'll go over some background information about anaplastology. Anaplastology is a specialized healthcare field providing custom restorative prostheses for patients impacted by disfigured or malformed anatomy. Our prostheses are non-weight bearing. This is what distinguishes us from prosthetics and orthotics, the field that makes arm and leg prostheses. We use medical grade silicones, acrylics, and other polymers, as well as specialized pigments and other materials like human hair. Our prostheses are artistically designed to be highly realistic, and they do function for people in many ways. But the bottom line is that everything we make is restorative. If something's missing from your body, you have the right to restore it. The need for a prosthesis can come from trauma, disease, or congenital malformation. We see patients across the spectrum from infants to folks in their 90s. Many of our patients requiring partial hand and foot prostheses have lost a body part as the result of a traumatic injury, often a workplace accident or motor vehicle accident, gunshot wounds, or other injuries. Anatomy loss due to disease is usually the result of cancer. Most of our facial prosthetic patients and breast patients are cancer survivors. We also see many patients who were born missing anatomy or were born with conditions that resulted in the loss of anatomy shortly after birth. So we see a lot of kids who are born with missing an ear or with an underdeveloped ear. And we also work with patients as young as 4 months who were born with an underdeveloped eye or with cancer in their eye that requires the removal of the eye. The services that we specialize in here at our clinic are facial prostheses, partial hand and foot prostheses, breast prostheses, and then miscellaneous medical devices, which includes the sports mask that you can see here. And I'll just kind of go over the range of products we make. So these images here represent the most common types of facial prostheses that we make. Each one is custom designed for the individual who will be using it. Ocular prostheses are the most common type of facial prosthesis out there, often called glass eyes. These prostheses are made of acrylic plastic, and they're hand fitted and painted to match each individual. Partial hand and foot prostheses are most often in the form of individual fingers and toes, but they also take the form of a partial hand or a foot that is worn like a glove. You can see an example of that here. Breast prostheses are typically off-the-shelf shapes, like you can see in the lower image there. Those are fitted and worn inside of a bra. But breast prostheses also include fully customized lifelike breasts, like you see in the upper image. And like I said, because we have the tools and the problem-solving skills available to make custom devices, we're often engaged to make other miscellaneous medical devices. So we make sports masks to protect athletes' facial injuries. We make custom facial compression garments. And this is an example of a heated and insulated mask that we made for a patient with extreme cold sensitivity following facial reconstruction surgery. The process that I will outline for creating the donor mask uses kind of the traditional techniques that we use in the clinic. But very briefly, I'll just mention some of the technology that we use to help us with our work. Many of our patients are able to take advantage of osseointegrated implants, the same type of technology as dental implants, but placed extraorally. So this allows the ear in the image here, for example, to be held in place with magnets. And when we're working with a patient who wants to have osseointegrated implants, we design surgical templates that show exactly where we want those screws to be placed in relation to the patient's existing anatomy and the potential prosthesis. So this is an image of a typical traditional surgical positioner that we might make. And this case shows a little more in-depth surgical planning that we can also be involved in. So here we have a 3D printed model of the patient's previously reconstructed orbit, and we're planning implants to be placed in a fibula graft. And then you can see in the lower images the surgical positioner and the models that we would make for the surgical team. We also employ scanning technology when we can, and many of our colleagues in our field use various types of desktop and handheld scanners. Sometimes that can replace the need for tissue impressions, and it can allow for digital sculpting and design to be done. So we use a simple iPad scanner when we're working with custom breast patients and some larger facial prostheses. And when we have digital scans of patient data, then that allows us to use 3D printing to expedite some of our lab work. So this is an example of this is a 3D printer that we built to print models directly out of the wax that we use to sculpt with clinically. I want to walk you through our typical process of fabricating a silicone prosthesis so that I can compare that to the process that we developed for making the life mask for the face transplant donor. When we start a custom silicone prosthesis, we make impressions of the patient so that we can make plaster models of their anatomy. In this case, we use a dental silicone material called vinyl polysiloxane, or VPS. This is the same material your dentist uses if you've ever had a mold taken of your teeth. And then we duplicate the anatomy by filling that VPS impression with plaster. So this gives us a positive copy of the anatomy that we can measure and reference when we're sculpting the matching ear. And we also cast a plaster model of the tissue around the missing ear, and that becomes the base for us to sculpt the new ear design on top of. When we have a wax sculpture of the prosthesis ready, we fit that model onto the patient to test out the position, the shape of the ear. So we spend a little time with the patient to determine if the size is correct, make sure it's not sticking out too much, or the rotation of the ear, make sure it matches the sound side, and make sure the fit against the tissue is good. There aren't any gaps or pressure being created anywhere. And once we're happy with the sculpting and the fit of the ear, we move on to color. We choose a base color swatch that most closely matches the patient's skin in and around the area of the ear. And then we mix 4 to 6 detail colors. These glazes will be mixed up in small batches and painted into the mold to simulate the changes in tone that you see within the ear due to the cartilage that's there, due to blood vessels, freckles, etc. And then a mold is created by enveloping that wax sculpture with plaster. It's made in 3 separate pieces, and then the wax is melted away, leaving the negative shape of the ear. The silicone colors that we mixed are then catalyzed and painted into the mold in thin layers, starting with the most superficial details and then building up detail and backfilling the mold with the base color. This is then heated in the oven and to cure it for about an hour. So here's the finished ear for this patient. This ear is designed to be glued on to the skin daily and removed. So the patient then comes back to the office to get the final prosthesis. They're instructed about how to use and care for the ear, and they practice donning and doffing. These steps that I outlined are just those that we take to fabricate an ear. But fabricating an ear is just one part of our overall treatment process. So over the course of these appointments, we end up spending hours sitting with our patients, talking through their medical history, managing their expectations for the prosthesis, discussing how the prosthesis changes their interaction with the public or with their family. So we see these patients also for follow-ups and continue to work with them through the years as they need repairs or replacements for their prostheses. So our philosophy and our goal has always been enhancing the quality of life through the art of prosthetics. Our product doesn't work unless the patient and their family and friends can accept the prosthesis. with its benefits and its flaws alike. A prosthesis will never be perfect. It will never give someone back their own natural skin, their normal way of life. But if it can give them the peace of mind to forget that they're wearing it, then it's working. So when LifeSource approached us with their hopes, their concerns, and their goals for a donor restoration mask, we quickly realized that our mission and philosophies were naturally aligned. The VCA team was looking for an option to offer the families of a facial donor to restore the honor their loved one of their loved ones after transplantation. They wanted a mask to restore the appearance of the donor and to honor the gift that they were giving. And we named this project the Life Mask. I have colleagues who've been involved in making masks for other transplant teams, and I had seen some examples. The LifeSource team also had some examples of masks that they were aware of that had been developed by other groups. So we had an idea of what had been created before, but LifeSource really wanted to go the extra mile to create a mask that would honor the donor and their family. Together with the VCA team at LifeSource, we developed the goals for this Life Mask project. First and foremost, we wanted a lifelike and faithful representation of the donor's image. A big part of the discussion of the quality of the mask was centered around whether or not we would be comfortable offering an open casket viewing to the family of the donor. We also wanted to ensure that the mask would be securely attached to the donor, so it would remain with them throughout their continued care by healthcare professionals and funeral home staff. We needed to develop a protocol to fabricate the mask on site at the transplant facility within a 10-hour time frame while the donor was in surgery. This required the anaplastologist to be on call to immediately attend to the transplant facility once a donor was identified. So we began to develop our Life Mask protocol. We were in touch with colleagues who'd been involved in similar cases, as I said, and we were able to discuss with them some of their protocols and processes. We came up with a list of priorities for our process. So first, we wanted this protocol to be in line with our approach to clinical work, which meant using quality medical grade materials. We wanted to choose from a suite of materials with which we were already confident and proficient to ensure success under pressure. On the left, you can see the impression materials that we chose to use, which is just the same as we use with our patients. On the right, you can see this is our silicone coloring kit that we put together. We were also very wary of using anything that could create too big of a mess. It had been determined through our discussions with LifeSource that the impression of the donor would take place in the ICU prior to surgery. So we wanted to make sure that we chose materials that were easy for us to keep under control. Through our discussions with LifeSource and among our team, our list of priorities became using medical grade materials, materials that wouldn't make a mess in the ICU, finding a fast curing silicone, and one that cured under room temperature conditions, using our familiar color mixing protocol, using all compatible materials so we wouldn't run into any contamination or difficulty curing the mask, and using only equipment and materials that could be packed easily into a travel kit. Next, we started testing our protocol at practice sessions at Mayo's Cadaver Lab. So the surgical team had already been practicing their transplant technique for some time, and we were fortunate to be able to join in with them to test our part of the process. In the photo on the left here, you can see just a fraction of the actual face transplant team at one of the Saturday morning practices at Mayo. And the right there we are at one of our practices. So we started working with the practice team in the spring of 2014, and we probably attended about 20 sessions. Just like with our typical patient process, we start with an impression of the model donor. In this case, the model donor had no hair, so we took the impression all the way to the back of the head and down the neck. But our protocol was that if the donor did have hair, we would take the impression along the hairline and then down onto the neck. We used 2 coats of VPS. The first blue coat is much softer. It sinks in and gets every detail down to the pores. And then the yellow coat is a little bit harder, so that provides some support for the first layer. And then we also embedded gauze strips into the material to prevent it from tearing when we removed it and when we were working with it later. When the impression is removed, we wash it out with alcohol and soap and water. Check for any areas that didn't cure properly. We can fix those. This impression is going to become our mold that we layer silicone into. So next we have to apply a thin separator on the entire surface of the blue VPS so that the silicone that we paint into it won't stick. And while the separator is drying, we mix up custom colors for the model donor. There are usually about 10 layers that went into these molds. The colors include red, tan, and green glazes. All of those detail colors for the lip, freckles, eyebrows, lashes, and other facial hair. And then several layers of base color with slight variations within them to produce shadows, highlights, and depth within the mask. We also embedded silk fabric into the edges of the mask so that it could be sutured onto the donor when it's finished without tearing. In the picture on the right, you can see the blue surface, that VPS, starting to get covered up by several layers of silicone as we paint them in. The picture is a little bit of an optical illusion where it looks like the nose is coming out toward you, but this is actually a close-up view looking down into the concave surface of the impression. Then we developed a thermoplastic mesh substructure. So this is a semi-rigid material that provides some structure to support the mask. A sheet of this plastic mesh is heated in hot water, and we use a hair dryer, and it's pressed into the back of the cured silicone mask while it's still in the blue impression mold. When the plastic is cooled, it's removed from the mold, fitted onto the model donor, and we trim up the edges so that it just covers the surface where tissue has been removed. Then the substructure is sutured in place to keep it from shifting under the silicone life mask. The last step then is to suture the life mask onto the donor. So this is the before and after photos of one of our early practices. I'm going to show a few images from the actual transplant event that took place in June of 2016. And I wanted to start with the timeline that we followed. So here I'm just including the active part of the timeline just for our life mask team. As you all know, there were many, many more hours of detailed planning and coordinating and testing and matching to get this donation event to happen that preceded and that followed our timeline. But we were notified of a match on Thursday, the 9th, and we arrived at Mayo early on Friday. There were several hours of setup time before the impression was taken. And then we spent an hour and a half for the actual impression. And that was because the donor had a full beard that we had to shave. We spent 13 hours making the mask. Our goal was to do it in 10, but at some point during the process, it became clear that we were going to have ample time. So we slowed down a little bit, took our time. And for the next 24 hours, we waited at Mayo. We had periodic team meetings, visits, and updates from the surgical team. And then at 5:30 on Sunday, we were able to bring the life mask into the OR and attach it to the donor. So we were at Mayo for a total of 43.5 hours. At the moment when we first met the donor, we had no idea what his, of his identity. We didn't know his story. We didn't know if we would ever get the opportunity to find out anything about him. But we were meeting with our patient, just like with any of our prosthetic patients. Our approach is always one of care and respect. And we did eventually get to find out about him. So I included these photos, which were provided by his family. So this is our patient, Rudy. When we met with the patient, as I mentioned, he had a full beard. So these images were taken after we shaved his beard. His eyes had been affected by his injury, so we made sure to close them gently for the impression before we started. And then the plan was to take the impression along his hairline, in front of his ears, and then down onto his neck just above his trach. So we followed the same process that I outlined earlier. And here is the resulting mask that we made. When the surgical team was ready for us, we brought the mask into the OR, and one of the surgeons stayed back to suture the substructure and the mask onto the donor. And here's the finished life mask on Rudy. And just a few more images of the mask in place. So after the event was completed, my partner and I sat down, we compiled our thoughts, we documented the timeline, came up with a list of questions and concerns that we had about the whole process and possible updates, changes for next time. We had the opportunity to speak with a couple of the staff members of the funeral home where Rudy went after the transplant event, and they were really helpful in answering our questions about the way that we attached the mask to the donor. They gave feedback about steps that would be taken by funeral home staff in the event of an open casket viewing. And that was very informative to us to consider how we might design the mask differently to serve them better. We were also fortunate enough to get to hear the reaction from Rudy's family. They did choose to view the mask at the funeral home, and the family had a very positive experience with the mask. And that was really informative to us. It really highlighted the importance of LifeSource's insistence on creating a mask of the highest quality possible to really honor the donor and thank his family. So we considered this a successful first event with some helpful lessons learned. And since the transplant event in 2016, we have had the opportunity to share our experience and our techniques with colleagues internationally. So we've learned some good information for next time, and hopefully other transplant teams out there have benefited from what we learned. As I mentioned, I also wanted to touch on another collaboration that we did with the LifeSource VCA team. So one of the services we offer is finger and partial hand prostheses. And because of this, we were asked to also come up with a restorative prosthesis for a potential hand donor. The hand transplant gloves project was approached with the same way as the life mask, which was to create a donor restoration to honor the gift of the donor and their family. Our criteria for this project were a little different. We needed to make several glove pairs that would match a range of acceptable donor demographics for a specific identified recipient. The details that we wanted to match included age, skin color, height, and gender, because the donor would most likely be female, although a male donor that met the height and size requirements would be accepted. So the team wanted 4 pairs of gloves representing a variety of donors within those variables. We wanted lifelike realism for up close open casket viewing. And again, they needed to be easy to travel with and easy for funeral home staff to place, modify, and potentially customize. We ended up making 4 pairs of gloves from the wrist down. And here's the first pair that we completed. So we identified models for the gloves who met the physical criteria of the recipient. We also included a pair of adjustable foam arms with elbow joints. The arms can be shortened, modified, cut, and positioned as needed. And then they included a stretchy silicone sleeve that could be used to join the foam arm with the donor's remaining arm. So you can see the sleeve peeled back in the lower image. And the kit that we created included 4 pairs of gloves, 1 pair of arms, and a set of acrylic nails that could be used to customize the hand, and laminated instructions for funeral home staff about what kinds of products, makeup, etc., could be used on the silicone. So I wanted to end with Rudy again and thank him for his amazing gift and his family. And thank you all for what you do. Thanks for listening and inviting me here to speak.
Thank you so much, Michaela. I see that you logged on. So if anyone has questions for Michaela, hi.
I'm honored to be speaking to the Upper Midwest ITNS Conference.
There we go. Okay. Does anyone have any questions for Michaela? That was so interesting. Thank you so much for providing that wonderful talk.
Can you hear me?
Yes, we can. Thank you.
Okay. Yeah, wonderful.
I don't see any questions in the chat. So if anyone comes up with questions, what an amazing service. Thanks for what you do in the chat. Thank you.
Thanks.
Yeah, getting some very interesting. Thank you for sharing. Quite the process. Thank you for providing this for donor families. An amazing work. Well, thank you, Michaela. Really appreciate it. If people come forward with questions after the fact, I will definitely forward them along to you for response. And
Great.
We really appreciate your presentation, and thanks for joining us live to ask questions. Oh, we did have a question come up. Michael wants to know what your background was in preparing for this role.
Say it again, what my background was?
Yep. What's your background for preparing for this role?
So, I mean, as an anaplastologist, my background, my education is in medical art. So I have a degree called biomedical visualization, which is a master's degree in medical art. And I mean, that's generally my background for my field of anaplastology. And then, you know, preparing for this project specifically, it was a lot of research, which involved kind of talking to all of our colleagues internationally. We're really lucky to have an international organization for our field that's really a tight, close community of people who are always really great about sharing their experiences. And especially internationally, we have colleagues in Belgium and in France who had been involved in face transplant cases, who shared a lot of their experiences with us. And then we really just tried to translate our clinical process into this process so that we could try to have predictable outcomes, you know, using things that we were really comfortable with. And and that we had confidence would work.
Thank you. We had one more question come up. If someone wants to learn more about anaplastology, how would you suggest that we do some research on it? I think some people have maybe never heard of it before previous talks or even this talk. How would we learn more about it?
Yeah, there's an international organization, so called the International Anaplastology Association. And their, their website has some great resources. And I'm also the chair of the Walter Stone Trust, which is a nonprofit organization that helps to, in addition to funding research and education in our field, we also have, part of our mission is just to help share information and get that out there. So the Walter Stone Trust also has a great informational website, and we and our social media pages, we try to share lots of interesting information about the field. Those are the two main resources.
Awesome, thank you. We have one more question. Yeah. What was the biggest change you would make during the next case?
The biggest change, I suppose, one of the things that we talked a lot about and that we kind of tried different techniques on was kind of a nitty-gritty detail about the edges of the mask, how we stopped where we brought the silicone to and what materials we embedded in the mask. So we ended up using a silk fabric, because if you could imagine, if this thin mask was just made out of silicone, once you tried to suture it, the sutures would just tear right through. So we embedded silk fabric in it, which worked fine, but I think that was the main difficulty for us, was getting the edges to line up correctly and to be user-friendly to the surgeon who is attaching the mask. So that's the part to my mind that needs the most refinement. I think we would try to come up with a bit of an extension to the edges that we could kind of add in, and maybe have try out some different fabrics for reinforcing the edges.
Great, thank you.
Mm-hmm.
Thank you again for your talk. Really appreciate it. Thank you for joining us to answer questions.
Yeah, absolutely. Thanks for inviting me.
Yes, have a great day and a great weekend.
You too. Thanks, you guys.
Thank you. All right. I will go ahead and introduce our last speaker for the day, Dr. Yuka Fuyuya. Dr. Fuyuya completed her internal medicine residency at Temple University in Philadelphia, and then completed her fellowship and MS in clinical investigations at Washington University in St. Louis. She joined the University of Minnesota in 2019 and specializes in interstitial lung disease and lung transplantation. Dr. Fuyuya's research interests include clinical outcomes in lung transplantation, chronic lung allograft dysfunction, and transplant access. And she will be speaking with us today about optimizing immunosuppression after lung transplantation. Welcome, and thank you for speaking.
Thanks, Christine. Good afternoon. I'm an assistant professor in pulmonary and critical care division here at the University of Minnesota. And I also work as a transplant pulmonologist and specialize in interstitial lung disease. I want to extend my gratitude for Christine and others for inviting me. Thank you. It's truly a pleasure to get to talk to you all about our new immunosuppression protocol at the University of Minnesota. So lung transplantation, since it was first performed in 1983, has evolved over time in terms of surgical technique, immunosuppressive regimen, and also in patient selection. In 2005, the lung allocation score, or LAS, was introduced, and allocation of organs changed from waiting time based, which obviously has its flaws, to score based, which is the LAS. Probably analogous to the way many other organs are allocated. The score takes into account the primary diagnosis of needing a transplant, the severity of the disease, and how well you're likely to do after transplant. When it was waiting time based, patients with rapidly progressive disease, which were mainly our patients, interstitial lung disease patients, who also tend to be older, just didn't have enough time to receive an organ. Since the introduction of LAS, the waiting time has decreased, waiting list mortality has decreased, and sicker patients have been getting a chance to receive a transplant. But also as a result, the percentage of older patients, here is the graph to the right from the SRTR yearly report, shows that the percentage of patients who are greater than 65 years old have increased dramatically since the introduction of LAS. And with evolving demographics, not surprisingly, new challenges have emerged. Transplanting a 68-year-old IPF patient is a totally different game than transplanting a 40-year-old with cystic fibrosis. These are some of the post-op complications that emerged as our recipient population evolved, who tend to be older, as I mentioned, who also have comorbidities and are more frail. Of the many post-op complications, we identified the rate of AKI at our center to be unacceptably high. I analyzed the data for patients that underwent lung transplantation between 2005 and 2019 and their incidences of AKI, and particularly AKI requiring renal replacement therapy within their initial hospitalization. So in incidences of AKI was greater than 70% within the first month, and AKI requiring renal replacement therapy was almost 11%. Median time to RRT was about 5 days. This is particularly important, and I'm not showing this data, but requiring RRT at initial hospitalization is associated with about 4-fold increase in fibrin mortality. So it's an important, obviously, point. I tried to find comparative numbers to this, and the closest I got was the requirement for RRT within 1 year of transplantation, and that's according to the International Society of Heart and Lung Transplantation Registry, which is about 1.2%. Now, I realize this is not necessarily comparing apples to apples, since people who initially required RRT might have recovered. People who didn't require RRT initially might have developed CKD that requires RRT. Another study that it's a pooled meta-analysis that was published in 2019, requirement for RRT was about 9.3% during the initial hospitalization. However, they included patients that are very much high risk. So papers that only looked at lobar transplantation for critically ill patients, or case series of short telomere patients who are a different population. So I would say this is probably an overestimate. So risk factors that are associated with renal failure are many in lung transplant. Obviously, things like hemodynamic instability in the perioperative period, pre-existing CKD, hypoxemia in our patients, cardiopulmonary bypass versus ECMO intra-op, with ECMO having been reported with lower incidences of renal failure. Bilateral versus single transplant, with single transplant requiring a shorter OR time and being associated with lower incidences of AKI, pulmonary arterial hypertension, which is a known risk factor, duration of mechanical ventilation, and ECMO support prior to transplantation. So the two that I focused on is supratherapeutic cyclosporin or tacrolimus trough, as well as the use of IV tacrolimus. So even having one supratherapeutic tacrolimus trough have been implicated, or at least have been associated with renal failure in the post-transplant period. And this is a little bit more controversial, but IV tacrolimus is thought to potentially potentiate the effect of the nephrotoxic effect of tacrolimus. And there's thoughts that the pegylated castor oil that is included in the IV tacrolimus formulary may be directly nephrotoxic. So this is highlighting our current, which is now our former immunosuppressive protocol, focusing on the reducing the incidences of AKI. So at our center, we have not traditionally used induction therapy, except for the Solumedrol, a gram that is giving intra-op. We use IV tacrolimus immediately post-operatively to a trough goal of 10 to 15, which I'm sure is mind-blowing for those not in the lung transplant field. So our new immunosuppression protocol, one big change is universal induction with basiliximab that is given within 30 minutes of incision versus no induction. Sublingual tacrolimus immediately post-op versus IV tacrolimus, and goal trough to be reached within 7 days versus immediately with IV tacrolimus, and lowering the tacrolimus goal to 8 to 12 versus 10 to 15, which is what we have traditionally done here. So let's talk about induction. So notably, there has been an increase that is a national and honestly a worldwide trend towards the use of induction agent in lung transplantation. In 2008, less than half of the lung transplant centers in the US were using induction agents. And in 2018, 10 years later, at a little less than 80% of the centers now are using induction therapy. And if you look at the right table graph here, which is an international data from the ISHLT, the increase is predominantly driven by increased use of IL-2 receptor antagonists, which basiliximab is the only one available in the United States. So induction therapy might be redundant to most, but is used in an effort to produce a significant immunosuppressive effect at the time of allograft implantation or recognition. Initially, it was thought to that initial depletion and the subsequent repopulation, quote unquote, in the presence of an allograft induced tolerance, while even in kidney or liver transplant recipients, induction did not lead to tolerance per se. Recipients still obviously do require maintenance immunosuppression. Subsequent large RCTs in renal transplant demonstrated reduction in allograft rejection and failure when induction therapy was used versus no induction. This diagram shows the mechanism of action for drugs used for induction therapy in lung transplant commonly. The interaction between antigen-presenting cells and T cell receptors initiates the first signal that results in a cascade of events that lead to T cell activation. So co-stimulatory blockers like the belatacept highlighted there block that step. After T cell activation, IL-2 is expressed and secreted, which results in a second wave of signaling that ultimately results in T cell proliferation and clonal expansion. So induction therapies like basiliximab blocks the IL-2 dependent signaling and downstream cascade, theoretically preventing those T cells with the ability to recognize the allograft antigen from proliferating and expanding. Other drugs used for induction include Campath or alemtuzumab, which is a CD52 receptor antagonist, more commonly used in other organ transplants like kidney. The problem, if I can call it that, with alemtuzumab is that lung transplant recipients are already fraught with infectious complications because of the degree of immunosuppressive medications that they require. And CD52 is not just expressed in T cells, but in most leukocytes. And it results in non-selective and profound depletion of T cells, B cells, and NK cells for months following induction. It could also can cause serious infusion reactions in some patients. Another induction agent is ATG, which are polyclonal antibodies against a variety of T cell surface antigens. And it does have some lymphodepleting effects, although not as profound as Campath or alemtuzumab. So basiliximab is what we are using. Brand name is Simulect. Is, like I mentioned, now the most commonly used induction agent in lung transplantation. It is a chimeric monoclonal antibody, and it binds and blocks the IL-2 receptor alpha chain at the surface of the lymphocytes. And IL-2 receptors are highly expressed in activated T cells, and it prevents further activation and clonal expansion, is the theory. The half-life is about 7 days. It is generally well tolerated. Our acquisition, quote unquote, cost, because there's a lot that goes into that, is about $5,000 a dose. And it's given usually day 0, the day of transplantation, and day 4. Daclizumab is a humanized IL-2 receptor antibody that is unfortunately no longer available. This was adapted from the ISHLT, the International Society of Heart and Lung Transplant slide set in 2019. It's important to point out that it is an unadjusted survival. So there's, center-specific practices and other factors that are not controlled for. However, this analysis have consistently shown survival benefit, albeit small, in lung transplant recipients who have received induction versus no induction. This is an ILS-HHT registry study that was published in 2008, and adult lung transplant recipients who received no induction, IL-2 receptor antagonist, and ATG were compared. They looked at graft survival as their primary outcome and freedom from BOS, which is short for bronchiolitis obliterans syndrome, which is the most common form of chronic rejection for lung transplant. The Kaplan-Meier curve for graft survival is on the right. They found that graft survival was better with those receiving IL-2 receptor antagonists. And this is the dotted line right here, compared to both no induction and ATG induction. The left graph shows both IL-2 receptor antagonist and no induction was associated with a longer time to BOS, or again, bronchiolitis obliterans syndrome. This is a UNOS data analysis that we did for about 6,000 adult lung transplant recipients. We compared alemtuzumab or Campath versus basiliximab versus no induction. The primary outcome was patient survival, and secondary outcome was freedom from BOS. Median survival was longer for patients receiving both Campath and basiliximab compared to no induction by almost more than a year. In the multivariable Cox regression, the use of either induction therapy remained independently associated with survival. Notably, in the Campath group, there was an increased incidence of both non-CMV and CMV infection as a cause of death compared to no induction. But that was not the case when comparing basiliximab induction to no induction. Hopefully, I've convinced you that induction therapy might be a good idea for lung transplant recipients, and has been associated with better outcomes in terms of reduced incidence of and prolonged time to chronic rejection in lung transplant recipients. In terms of when to give induction therapy, there was a limited amount of published literature, but I would like to review that here quickly. So we found 3 articles. The first 2 were for heart transplant recipients. The first article was not powered to test for efficacy, but was to evaluate safety and tolerability of basiliximab. They found that, in fact, it was well tolerated, and the safety profile that was similar to placebo infusion. They also found that mean days to biopsy proven acute rejection, grade 3A or more, or any rejection with hemodynamic compromise was delayed in the group that received basiliximab versus placebo. The second article here looked at pediatric heart transplant recipients who either received no induction or post-implantation basiliximab, so after the allograft is put in, or pre-implantation basiliximab. Overall freedom from ACR was greater in patients who received pre-implantation basiliximab, and this difference persisted in the multivariable Cox regression. This is a third article that actually looked at lung transplants. Finally, they used historical controls from 1994 to 2000. They used no induction, and they changed their protocol in 2000 to give basiliximab post-implantation. And they again changed their protocol in 2006 to give basiliximab now pre-implantation. And maintenance therapy did change in 2002 from cyclosporin-based to tacrolimus-based. But otherwise, there was no change in antimicrobial prophylaxis or maintenance immunosuppression. They looked at overall cumulative acute rejection score, or the CAR score, at 1 year between the 2 induction groups that were given at different timing. And they also looked at freedom from ACR, BOS, and overall survival in invasive CMV or fungal disease. The cumulative acute rejection score, the CAR score, at year 1 was significantly different between those who received basiliximab pre-implantation and post-implantation. So the CAR score was the highest in those who received no induction, but this was not statistically significant. Freedom from the first episode of ACR, grade A2 or greater, was significantly longer in patients who received pre-implantation basiliximab versus post-implantation. There was no difference in freedom from BOS and survival. but follow-up period was limited in the pre-implantation group because they just were doing that for shorter periods of time at that point. So the rationale behind goal trough to be reached in 7 days versus immediately. This is an abstract that was published or presented at ISHLT this year, which was done virtually. It's an abstract from Duke, and they compared time to de novo DSC development and acute cellular rejection in patients who achieved therapeutic tacrolimus levels, which in their case was 8 to 12 within 7 days and after 7 days. They all received basiliximab induction. And tacrolimus was started at sublingual or PO on or before postoperative day 2. There was a slightly longer time to development of de novo DSC in patients who achieved therapeutic trough within 7 days, but there was no difference between the groups in the incidences of ACR. There was no difference in the rate of AKI or need for renal replacement therapy, which was about 4.1%. There was no difference in infection within this first 6 months either. So that I guess prolonged time to de novo DSC development was a rationale for doing trying to achieve target trough within 7 days. These are the outcome measures. With the goal of reducing the rates of AKI in mind, we identified 3 basic outcome measures. So our biggest aim, obviously, is to decrease the incidences of AKI requiring renal replacement therapy by 30%. Aim 2 is to assess the rates of rejection, both ACR and AMR, as well as chronic rejection. We'll also be measuring the time to de novo DSC development as well. And lastly, we'll be looking at the fidelity of our intervention, and in particular, the timing of basiliximab infusion, which is supposed to be within 30 minutes of incision, and administration of sublingual versus IV tacrolimus. Those 2 things take cooperation and education of our colleagues in the anesthesia department and the bedside nurses. We have distributed learning systems to be to the bedside nurses, particularly in the ICU, to prep for the administration of sublingual medication, since we typically don't use sublingual medications immediately post-op at the very least. I will admit that there was some amount of confusion in the beginning where meds were administered into the NG tube instead, but it's a learning curve. And we will see if we're able to meet this hefty goal of reducing our AKI incidence. We did just implement this change this past August. So maybe I'll come back next year and tell you all how it's going. That concludes my presentation, and I'm happy to take any questions if there are any.
Thank you so much for your presentation. That was a great overview on why changes were made. Does anyone have any questions for Dr. Furuyuya?
You're welcome.
Give it one more second, see if anyone pops up there. Otherwise, if anyone does have any questions, I can definitely forward them to you for a response.
That represented several changes in your program. Is this Michael Petty, our Michael Petty? I would call it our program, but yes.
All right. Well, great. Thank you so much again for coming and sharing with us. We really appreciate it. Oh, Michael does have a question. How can we sort the difference in outcome, the differences in outcome?
Yeah. So our outcome goal is to reduce the incidence of AKI. So when it came to let me back up. Initially, we were actually proposing to change our MMF dose and other immunosuppressive protocol as well. But exactly to your point, it does make things like rates of acute rejection, chronic rejection, the analysis of that a little bit muddled. So we're just changing purely the basiliximab induction and the sublingual tacrolimus. Does that answer your question? Kind of. So I think of this as a package deal because, yeah, because the introduction of induction agent, in my view, allows us to lower the tacrolimus goal and allows us to introduce tacrolimus at a later time point than what we have done traditionally. Okay. You're welcome.
Thank you, guys. All right. Thank you so much. Thank you again for joining us. Really appreciate your talk and have a great weekend. I think that concludes our program for the day. Just want to say thank you to everyone for joining us. I will plan to send out the link to the recording as soon as we have it available and uploaded to the YouTube site, the ITNS YouTube site, and the link for the survey to those who attended live. For those that are listening to the recording, please email me when you have completed listening to the recording and I'll send you the survey at that time so you can get your contact hour sheets. Again, once you complete the survey, you'll be prompted to enter your email address and the contact hour sheet will be sent automatically to whatever email address you enter there. So again, look forward to hearing more from us about nominations for the 2022 year for board members. And thank you very much for joining us today. Please feel free to give us feedback on that survey so we can tell what we should do for next year and what we could maybe tweak a little bit. And this was our first year going virtual with the whole conference, so we really appreciate your patience as we work through some technical difficulties. And thank you all just for joining us on this lovely Friday. Have a great weekend.